issues, I'll connect with you, or you can take the system. It is. Okay. Hi guys, hope you're doing great. So we meet on another new week, the week of preparation, I would say. So I think you gotten used to the grind in spite of the heat and that negative news of 100 hottest cities in the world being limited to India. So I don't know, India is a special country. We always have problems, but we are like Indians. We are able to overcome them also. So let's get started for today. I'll begin from this particular page, that is diseases of the adrenal glands. This was like what in my last time's discussion I had said I'll be discussing with you subsequently. So, okay. So I think the audio and the visual part is perfectly fine. I'll just check myself also, and then we can get started for today. You have to move on to page number 89. That is pending from last time's discussion. And then we'll be talking about a couple of other technical issues also. Endocrine is an easy system, so I don't think so that you would have had problems as much as students have problem understanding cardio and neuro. But I can say cardio, neuro, and endo is like those topics where, and respiratory, four, like these are where 80% of the questions would be coming. So it's like 80% of the heavy lifting that we are doing is in the first 4 days of our discussion. That is cardio, neuro, endo, and then subsequently pulmonology that I'll be starting in front of you in the later part, because in last time's exam there were 5 questions of on ABG, right? And I think five in FMG, or like 3 in NEET PG, or 2 in NEET PG. Ulta tha shayad, I forgot, but then like that's a lot of load that the students had to do. So okay guys, uh, I think I'm live, and the audio and the visual part is fine. Good morning to everybody. I missed a couple of names in the chat, but we're good to go for the first topic, which is very classical terminology. Yeah, I understand. Understand. Okay. So we'll take care of those, whatever is to be handled. Mhm. The first terminology I want you to get used to is called as ACTH, independent Cushing syndrome. Whenever you read this phrase, what should come in your mind is this line diagram that I'll be making in front of you. You see, there are multiple layers of the adrenal gland. We have cortex, we have adrenal medulla. But today I'm talking about a tumor. And the tumor that I've shown in red is present in the second layer of the adrenal gland. You are all aware from physiology that the first layer is zona glomerulosa, then fasciculata, then reticularis. GFR is the mnemonic for it. And I hope I don't need to write that. That's basic physiology. Glomerulosa, fasciculata, reticularis. And you can see here that there's a tumor, unfortunately, in my patient in the second layer of the gland, that is in zona fasciculata, and it is producing very one hell amount of cortisol. And when cortisol levels will rise, then from the feedback perspective, the ACTH levels in the body will begin to get suppressed. So since my patient is having this tumor, and the blood test report may be given in the question, like he might either write the word ACTH independent Cushing syndrome, or along with that, to assist you, he might also write that the person is having high cortisol. Obviously, Cushing syndrome likha to cortisol would be elevated and ACTH will be suppressed. And then he will say, what is the best investigation for this patient? Then because this is a tumor in the abdomen, so I will be doing a CT abdomen in this patient. The main investigation that we will be doing for diagnosing that the person is having a ACTH independent Cushing syndrome is CT abdomen. And well, what are you supposed to know from here is either you remember the theory word adrenal adenoma, or instead of adrenal adenoma, you remember the fact that there is a tumor in the second layer of the gland, vice versa. I mean, either of the two basically mean the same only. And I will subsequently be teaching you ACTH dependent Cushing syndrome also. For the dependent word, I will say pituitary adenoma. And the moment I say pituitary adenoma, what will you do? You will do a MRI here. Cool, no? ACTH dependent, then you say it is pituitary adenoma, that is MRI head. If I say ACTH independent, it means a tumor in the adrenal gland of the patient. So both are tumors. Dependent on the top, independent at the bottom. That is how you can remember. The independent one can be evaluated with help of CT abdomen. And now I will change the perspective and say that the person is having a tumor in the first layer of the adrenal gland. The first layer of the adrenal gland is responsible for production of aldosterone. So remaining layers are okay. Zona glomerulosa is producing aldosterone. Fasciculata is okay, reticularis is okay, even inside the adrenal medulla, this is the medulla which we'll talk about, responsible for pheochromocytoma, that is also fine. The patient of mine is unfortunately having a tumor in the first layer of the gland, and the first layer of the gland produces aldosterone. So the word is primary aldosteronism. The moment you pick this up, aldosterone in the body is more. What you should understand is that this chap is having Conn syndrome. Conn syndrome क्या होता है? तो your answer is primary aldosteronism. What do you mean by primary? Is that the gland is having a problem, and that is a tumor in the first layer. Now, sometimes they might make it a slightly clinical oriented by mentioning regarding the manifestations. I think you are aware from physiology that what is the name of the aldosterone receptor. You can comment in the chat box also. Hit the comment box for the first comment for today. What is the name of the receptor for aldosterone, and where is it located also? Your answer will be that the receptor for aldosterone is located in the collecting duct, and it is called as epithelial sodium channel. ENaC is the short form of it. When I say the word epithelial sodium channel, ENaC, it basically means that the channel will be now having to do more work, and more salt and more water will be coming in the body. Well, the bad news is the person came to my hospital. He said, sir, I'm having too much of stress at work. I'm having too much of headache. And when I checked his blood pressure was high because there is more salt and more water coming in the body. Yes, a lot of comments came, though the comments were a little lesser. So I assume aapko aata hai, right? You're not listening passively. So epithelial sodium channel is the one that you can see is causing more salt and more water to come in, but there is a price to pay. When you buy something more, you have to pay more money for it also. So here what the body is doing is that the body is purchasing more salt and more water, but then you have to pay more price for it as the body operates on barter system. So there would be a development of loss of potassium and hydrogen also. And because of the caliuria component, there would be hypokalemia and muscle cramps. And because of loss of hydrogen, metabolic alkalosis. So some of the questions that have come in the previous of this topic, they have not been like blunt by saying primary hyperaldosteronism or Conn syndrome. What is the main investigation? The examiner first wasted your time, precious seconds, by saying patient came with complaints of too much of stress at work, headache was there, doctor found he was hypertensive, he was having muscle cramps also, so a doctor ordered, doctor evaluated electrolytes, and he was found to be having hypokalemia with metabolic alkalosis. So it was like, just eating up into your energy and eating up into your time, because Conn syndrome, the classical presentation is like this only: hypertension with hypokalemic metabolic alkalosis. And the moment you say that hypertension with hypokalemic metabolic alkalosis or Conn syndrome, the main test that we will be doing in this patient. Yes, guys, I'm waiting for your comments here. What is the investigation choice for Conn syndrome? Because endocrine mein the whole game is you should be able to get the IUC rate. Rest is all crap. They'll just fill up the data in the question. How do you know it is Conn syndrome? Obviously, CT will tell me it's a tumor, but CT will not tell me what is the tumor producing. CT will tell me it's a tumor, but it will not tell me what the tumor is producing. Yes, Prashant was the first one to hit the comment button correctly. That is the main test for this condition. The main thing, baki sab is junk in this particular column. The main word is what you have answered very rightly, guys. Two of you have done the right job. It is saline infusion or salt loading test. Salt loading test say most doctors are able to approximate, no, because aldosterone is related to salt. If you are having, let me say, lot of salt, you are having more salt in your body, then aldosterone will get suppressed ultimately, right? If suppose you are eating too much of salt, you will be able to suppress the aldosterone production. But this is a tumor. Tumor will not respect physiology. Tumor will say, bhai, tu kaun? Why should I respect you? Tumor does not respect physiology. So the test answer is saline infusion test. And those of you who have salt loading test, you are also right. There are different ways of writing it, but then as I explained to you, why I did not write the word salt loading test initially is because the examiner will avoid using this term primarily because from salt आप अंदाजा लगा लेते हो कि aldosterone is the villain, so he will write the word saline infusion test. That's the main agenda. Yes, Raghib, Alam, also you are right. Tejas, you are fine. Saline infusion test and salt loading test is the main test that would be done for this particular condition. So we have sorted for 2 questions at the moment. Let me just revise them, and in case you are joining in late, I hope you are able to figure out. We are on page number 89. We are discussing ACTH independent Cushing syndrome. That's a tumor of the adrenal gland in the second layer. But if the tumor is in the first layer, then first layer mein, then it's gonna be saline infusion test and salt loading test. And now comes the aspect of pheochromocytoma, that is a hot favorite. 24-hour urinary test would be required. For pheochromocytoma, however, I would like to describe and divide the discussion into two parts. One is the screening test and second is the investigational choice. If he says what is the screening test, obviously I need to check for catecholamines. So, VMA is to be avoided. I'll tell you when VMA is to be added or answered. The answer in this case would be 24-hour urinary fractionated metanephrine levels, जो catecholamines का end product of metabolism होता है. जो catecholamines का end product of metabolism होता है, that is the one that we'll be checking here. So 24-hour urinary fractionated metanephrine levels is the main test that would be used for diagnosis of this condition. या तो कार्सिनोइड में करते हैं ना. So 24-hour urinary fractionated metanephrine levels is the main test. If he says what is going to be the investigational choice, then investigational choice is plasma free metanephrine levels. Keep your eyes careful on the board because in the MCQ he will swap it. वो प्लाज्मा के लिए लिख देगा फ्रैक्शनेटेड और यूरिन के लिए लिख देगा फ्री. सो द वर्ड्स आर, एक याद करना है आज के लिए, स्क्रीनिंग इज 24-hour urinary fractionated metanephrine levels and the investigational choice in endocrine is always going to be like a blood test only. We have to find out whether there's a tumor or not. So plasma free metanephrine levels would be, because we need to find out what is the tumor producing. So plasma free metanephrine levels is the main test that we'll be using for diagnosis of this patient. MRI will just tell you that, okay, there is a tumor present, but then it is in endocrine. What is the investigation? It's always a blood test checking the level of hormones. Now, catecholamines have a short duration of action. क्योंकि छोटा duration of action होता है, तो by the time you process the sample, the hormone will be degraded. So I want to check out the end product of metabolism, which is why it is plasma free metanephrine that will be used. And we'll come on the topic of pheochromocytoma again also, but at the moment, the main tests are being discussed. Somebody commented 24-hour urinary VMA levels. Those who are sitting for NEET PG, can you please comment on this question? 24-hour urinary VMA levels are accurately used for identification of. No, you don't have to remember normal levels. 24-hour urinary VMA levels being elevated are going to be used for diagnosis of which of the following. Which condition? I don't need to say the number, name, right? 24-hour urinary vanillin mandelic acid levels are used for evaluation of which of the following. Yep. It is used for evaluation of a neuroblastoma. So whenever you read this question, don't answer pheochromocytoma. Basically, the point is in the older books and in pathology, you will still notice pheochromocytoma written. So I'm just putting a mark here to say that in one of the FMG exams, he had asked 24-hour urinary VMA levels. Neuroblastoma was not in the options, तो वहाँ pheochromocytoma चल जाएगा. But specifically, if he says 24-hour urinary vanillin mandelic acid levels are used for evaluation of, then your answer is this tumor, which is usually seen in patients with neurofibromatosis 1. The defect is related to chromosome 1 NMYC gene that is involved, that is neuroblastoma. This is related to NMYC gene and is also related to chromosome number 1. So two more points added to your knowledge base. 24-hour urinary VMA for neuroblastoma specific answer. If this is not in the options, then okay, pheochromocytoma. But especially now a statement for FMG students. Suppose paper में VMA भी लिखा है and 24-hour urinary fractionated metanephrine भी लिखा है, तो फिर क्या मार्क करोगे? तो fractionated metanephrine levels आंसर करना है. Then is Addison disease. Addison disease would be having destruction of all the three layers of the gland, and इसका जो investigational choice है that begins with A, that is ACTH stimulation test. तो इसके लिए बहुत ज़्यादा rational में जाने की जरूरत नहीं है. Addison disease is gonna be ACTH stimulation test. Normally you stimulate the gland will be stimulated. Here it is destroyed. So here, in fact, he can also put it as the two-step question. What is the reason for Addison disease? Yes, guys. What is the number one reason why a patient will end up with Addison disease? Aldosterone is low, cortisol is low, sex steroids are low. All the three layers of the gland are destroyed. Whenever you read Addison disease, the impression in your mind will be moth-eaten gland. Glomerulosa is destroyed, fasciculata is destroyed, reticularis is destroyed. All the three layers of the gland are destroyed. Yes, the most common cause of autoimmunity is most common cause of Addison disease is autoimmunity. So autoimmunity we blame for type 1 diabetes, but even in Addison disease and also autoimmunity for Hashimoto's thyroiditis as well. So the point to be remembered is it's an autoimmune disorder, but yeah, in India, especially if a person is having AIDS, then you can be having disseminated tuberculosis, and the disseminated tuberculosis can also cause this moth-eaten gland. Overall, the answer of all of you is fine, autoimmunity. But if he specifies like AIDS positive patient and then he's immunocompromised, then it is disseminated tuberculosis, which will eat away into all the three layers of the gland. By the grace of God, the medulla will be spared. Like the blue dot is the medulla will be spared, but the remaining three glands would be specifically destroyed. So this slide is, I would say, a very dense, high yield slide for like what is the investigational choice for various adrenal conditions. And now we will focus on, this was page number 89. We will now focus on certain more, yeah, Waterhouse-Fridson syndrome is like that meningococcemia that I've already explained to you. This was page number 89 that I had left in last time's discussion. So please come back to page number 94 now, and we'll discuss some more endocrine situations, but this time it would be more of endocrine related emergencies. And the situation I'm gonna give to all of you is of an unconscious, unresponsive diabetic patient. The person is like, we know he's a diabetic patient and you need to give me interpretation. So let's get started. I'll be mentioning regarding the pH, PCO2, bicarbonate, urine ketones, RBS, and special investigations also. And it is a very simple discussion that we'll be doing at this point of time. My patient who got admitted to the hospital today is having a pH of 7.3. So there is an acidosis component present. And metabolic acidosis, whenever it is present, will cause small breathing. And because of the small breathing component, hyperventilation will occur. And that will cause a washout of carbon dioxide. Everybody knows normal pH is 7.35 to 7.45. I don't need to say that. There was acidosis. Normal is 35 to 45 PCO2. In this particular case, there is a carbon dioxide washout. Why? Because my patient is having small breathing or hyperventilation. Even if I don't say hyperventilation, I can say any sick patient can be doing hyperventilation. Then the bicarbonate of the patient, normal is 22 to 26. In this case, the value of this is low, that is about 15. So you can see that all the three arrows are going down, down, down. Though we'll discuss like ABG separately also, but at this moment, I just want to give a simple hack that if you get a question in which pH, PCO2, bicarbonate, all three are less, it means the person is suffering from metabolic acidosis. So one thing is clear, this is a unconscious, unresponsive diabetic, is a metabolic acidosis. I checked for urine ketones. The urine ketones in the patient are turning out to be negative. So you can understand this is not a case of diabetic ketoacidosis, not a case of diabetic ketoacidosis. The random blood sugar of the patient is hitting that threshold of 250, which I had explained to you is like important for evaluation, though we can have euglycemic diabetic ketoacidosis due to SGLT2 inhibitors as well. So at the moment, I think everybody appreciates this is a diabetic. His sugar is high, he's having metabolic acidosis. There are no urinary ketones. So initially I thought that the reason why the urinary ketones of this patient is negative because sometimes the dipstick can be false negative also. So I wrote a plasma beta hydroxybutyrate values. That is like a more specific test for ketones, and even the test is normal. There is no ketones in the body, but still the person is suffering from metabolic acidosis. If I write something more, then the answer will become very, very obvious. So I am gonna put this question to everybody who's listening to me today. Person diabetic, unconscious, unresponsive with metabolic acidosis, but there is no ketones present. Neither in the dipstick and neither in the blood are the ketones elevated. Then what will be the first differential diagnosis, or the question will say, what is the special investigation that you will be ordering for this patient? I've had surprisingly only one input, considering that I have 900 students lined up there, and this I would not rate as something very great or very technical. Yes. The test that you will order in this particular case is serum lactate. And if serum lactate levels are elevated, then the possibilities are either the guy could be having lactic acidosis due to metformin, or it could be lactic acidosis due to sepsis. Lots of time when person is going into septic shock, under perfusion of the tissues will cause serum lactate levels to be elevated. You are right, guys. Since lactate is given to be elevated, and even if it was not mentioned, what is the thought process of you guys? Then you will not answer as diabetic ketoacidosis. Make an entry right here. The entry to be made here is lactic acidosis, and then there are two further differentials of this. Differential number one for lactic acidosis can be that this guy was started on metformin by his physician in spite of the fact that the estimated glomerular filtration rate was less than 30. Metformin is contraindicated. Metformin is contraindicated if the estimated glomerular filtration rate is less than 30. This makes me liable for medical prosecution, legal prosecution. It would be an error on my part, and lots of doctors do that mistake that don't even check the KFT regularly of diabetic patients who regularly follow up with them. Every time a diabetic patient comes to you, ideally on a yearly basis, preferably on a 6 monthly basis, at least get a baseline KFT done or get a GFR evaluation, because the person can be having drug-induced lactic acidosis, that is metformin-induced. The second possibility in the patient can be, obviously, like I said, sepsis. So I will also draw blood culture for the patient. So this was a question in the paper where like acidosis was given. So everybody assumed diabetic ketoacidosis, but you guys are smart guys. You were immediately able to identify that this question is not of diabetic ketoacidosis. It is lactic acidosis, as I think everybody or most of the people who did at least made attempt to comment have been able to figure out. I will now be zooming out once again and I'll give you one more report. This time it will be easy. pH is 7.3, PCO2 is 30, bicarbonate is 15. I've given same report so that you can draw comparison here. So yeah, this is metabolic acidosis. The urine ketones in this patient is 4 plus. The urine ketones in the patient is 4 plus. The blood sugar of the patient is like I've just slightly modified it to 300 milligram per deciliter. So yep, I mean the sugar values are up. And in this particular case, when I did a special test, the special test that I should be doing in this patient is again plasma beta hydroxy butyrate values. Though it is written, I'm doing the hard work of writing that again so that I can emphasize before you that this is the most acidic ketone body. Yes, guys, what is the most acidic ketone body? Plasma beta hydroxy butyrate levels. Since in this particular patient, the plasma beta hydroxy butyrate levels are super elevated, and the patient is satisfying the routine criteria, you will be able to answer it as diabetic ketoacidosis. So for the second entry, which is in white, I deliberately kept it in white column to say that nobody, I don't think so, anybody, like, if you read the data for, diabetic ketoacidosis once in your career, only once, and you are able to figure out the answer. So first report of lactic acidosis is of more importance than the second report of diabetic ketoacidosis. Now I will make it slightly more trickier, though, because some of you have listened to me, so you will be able to figure it out very fast. The student of mine said, boss, pH was normal, 7.40. PCO2 of the patient was also normal, like 38. Bicarbonate was also normal, like 24 millicoulant. So he said, sir, I was thinking to myself, if everything is normal, then where the hell is the problem? I mean, he's mentioning unconscious, unresponsive diabetic. He said when I scanned the question further, it also mentioned ketones as 2 plus. I'll give you the reason for 2 plus though. And he said blood sugar was outrageously high, 800 milligram or 600, 700. I mean, outrageously high blood sugar. Khoon meetha ho gaya, no? I was saying like Rooh Afza or like Rasna, like it's like a concentrated, it's like concentrated, that is situation that is present. So what I need to do, no, here, I know you know the answer. We have discussed this already, guys. The question would be, considering that ABG report is normal, then this cannot be obviously ketoacidosis or lactic acidosis. Now we will say what is the special test that you would be doing in this particular patient. So the special test that you will be doing is a plasma osmolality. And when you run a plasma osmolality for this particular gentleman, the plasma osmolality will be elevated. Normal plasma osmolality is about 275 to 295 milliosmoles, and in this question the plasma osmolality will be given to be like super elevated. Most of the time in the questions the value will be like 310 milliosmoles, or might be saying 320 milliosmoles. So you are picking up the word hyperosmolar coma, that is hyperglycemic hyperosmolar coma in this patient. Before I write the final diagnosis, all of you write, let me know why is the person having ketones present. Why ketones are 2 plus? The ketones are 2 plus because the person is unconscious for maybe 1 or 2 days. So since somebody will not eat for 2 days, the body will basically burn fat to produce ketones. If somebody has not eaten for 2 days, then the body will burn the fat to cause production of ketones. So ketones are 2 plus primarily because of the starvation component here. And yes, I think everybody is right. You have been able to correctly identify that what is the problem of this patient. The problem is a hyperglycemic hyperosmolar state. When you have so much of sugar in the blood, it will cause fluid shift across the brain. Fluid shift across the brain is never welcome. It causes coma. Repeat my statement. When the blood sugar is ultra high, then brain does not like rude shocks. Brain likes normalcy. By rude shock, I mean if blood sugar will become very high, then there would be fluid shift across the brain. And that fluid shift across the brain will explain why the patient of mine is suffering from like this unfortunate situation of hyperglycemic hypersmolar coma. The word coma is primarily because of the fluid shift that I wanted to bring to your attention. And when we will treat this patient, then obviously things are bound to improve. Can you hit the comment button and tell me for hyperglycemic hypersmolar coma, what will happen to sodium concentration? You just have to answer more versus low. Suppose he says, what will be the sodium values in this patient? Hyperglycemic hypersmolar coma, the sugar will draw water intracellular from intracellular into the blood vessels. When water will come in the intravascular compartment, it will cause a dilution, and therefore the sodium values in the body will begin to reduce. So if you will say, how will you treat the hyponatremia? Beta kam ho jayega na, sugar will draw water into the blood vessel. Sugar अपनी तरफ पानी खींचता है ना, sugar draws water. So when sugar will be drawing water, then water will come in the intravascular compartment. That water will cause a dilution and will cause hyponatremia. So if he says, how will you correct the hyponatremia? Then don't answer 3% saline. You will say, I will treat hypersmolar coma. And when you treat hypersmolar coma with fluids and with insulin, then gradually when the sugar will come down, then that osmotic load will also go away and sodium will normalize. So in this particular case, the point to be understood is sodium will be low. But why is the sodium low is because of the shift of water. Water is drawn in because of high concentration of sugar, and therefore we need to treat the cause. Yes, Priyesh, you're right. It is pseudo. We don't need to treat the hyponatremia component unless and until it is seizures. Like suppose I said sodium is 120, person was having seizures. What will you do? So then to chalega. I mean, we will have to give 3% saline, but otherwise there would be treating the cause that would be responsible. So let's do it one last time, guys. I'm just making it a little smaller slide, but yep, now you will be able to see why I made it smaller. The question said patient came to the hospital, pH is 7.4, PCO2 is 38, bicarbonate is 24, urine ketones are like trace or negative. Random blood sugar is something like 150. Diabetic में blood sugar 150 तो कोई बहुत high नहीं है. So everything is normal in this particular patient. Pranav, I've already explained. So if everything is normal, diabetic में sugar of 150 is not something that you will be very significantly worried. Then what is the first differential diagnosis? Your answer will be you will suspect stroke in the patient, and the special investigation that you will be doing in this patient is a non-contrast CT head. And non-contrast CT head will let you know whether it is a ischemic or a hemorrhagic stroke. So the last differential that I mentioned here before you, जहाँ पे सब कुछ normal होगा, would be a CVA, that is a cerebrovascular accident. What I've explained to you at this moment is a critical part of again endocrine emergencies continued. Though I have given you a heads up with respect to DKA and hypersmolar coma even in the last week class that I took with you, but at this moment I have tried to highlight the core aspects, which is that what would be the differential diagnosis. I will just write it a little bigger for because you would be reading this note subsequently, that in this case it is lactic acidosis because obviously lactate is elevated. And the reason for lactic acidosis was, one is metformin misprescription, that is metformin is contraindicated if the eGFR is less than 30. I'm not writing that word once again. I think you already noted it down. And the second one is a query sepsis, that is septic shock that needs to be evaluated in a patient. So these are 4 differentials for unconscious, unresponsive diabetic: lactic acidosis, diabetic ketoacidosis, and hyperglycemic hypersmolar coma. If you are an FMG student, you need to remember only 2. Diabetic ketoacidosis and hyperglycemic hypersmolar coma, the ones in the middle. If you are a NEET PG aspirant, all 4 of these have to be remembered. Diabetic ketoacidosis is more common in type 1 diabetic, and hyperosmotic hyperglycemic coma is more common in type 2, but it is not a guarantee that DKA cannot occur in type 2. I want to clarify this fact that lot of students are under impression कि type 1 diabetes में ketoacidosis होता है. No, it can occur in type 2 also, and similarly hyperglycemic hypersmolar coma is more common in type 2 but can occur in type 1 also. So आपने type 1 और type 2 से नहीं निकालना है. You need to look at the labs. You need to look at the labs that I've currently explained to you. What are the specific labs that I've highlighted? A beta hydroxybutyrate is normal and serum lactate is elevated. Lactic acidosis. If plasma beta hydroxybutyrate level is elevated, diabetic ketoacidosis. If plasma osmolality is high, hyperglycemic hypersmolar coma. And if CT head is turning out to be abnormal, that it is a metabolic, it's not a metabolic problem, it's a CNS problem. It could be a cerebrovascular accident in the patient as well. या डायबिटिक ओपियोइड्स नहीं लेगा, है ना, जो सफर कर रहा है बेचारा, है ना, वैगाबॉन्ड की बात करूं, कोई कोई भिखारी है सड़क पे, राइट, सम ड्रग एडिक्ट, then I can understand that drug overdosage can be there, but a diabetic patient to be doing drugs is very, very unlikely. So yeah, urine toxicology I would still be considering, but these are the common differentials that I wanted to remember. Yes. What is the name of this patch, guys? What you can see on the screen at the moment? What is the name of this patch on the screen that you can see at the moment, where I put the red arrow? Yes, guys, quick answers, please. Yes, I'm waiting for your answers. Yeah, CGM. It is continuous glucose monitoring. This patch that you can see at the moment is a CGM monitor. It is a continuous glucose monitor. You can sync it to the mobile phone, you can sync it to an insulin pump, and therefore you can adjust the amount of insulin that is delivered. Like this continuous glucose monitor can be synced with this insulin pump that you can see is put in the patient has attached it to the pads that the person is wearing. And this insulin pump is now having a Teflon catheter. From the Teflon catheter, the insulin will be delivered subcutaneously into the body of the patient. You can see that this is a Teflon catheter. Through the Teflon catheter, the insulin will be provided to the patient subcutaneously. And this small device that the patient is wearing is called as an insulin pump. Though a lot of patients in India will not be able to afford that 1 lakh rupees device, but for you, if they ask you what is the best method of insulin administration, then the best method of insulin administration is an insulin pump. The technical word that you will use for insulin pump is CSII. CSII stands for continuous subcutaneous insulin infusion. What I was casually referring as an insulin pump is a continuous subcutaneous insulin infusion pump, and insulin infusion pump, and this is like one of the best strategies to deliver insulin, because then you are avoided the hassle of, like, filling up in a syringe and doing a calibration, because here this is an automated system. Like you can put a SIM card into this and you can connect it to the internet. If the insulin pump is connected to the internet, then you can connect it to any AI enabled site. So if the sugar is turning to be high, then the computer automatically, though microprocessor is intelligent enough, but I'm saying even I can in real time see how the insulin pump is working. If I put a SIM card and have an internet connection, that through a dedicated app, I can see the performance of the device. A doctor can monitor it, AI can monitor it, and the computer inbuilt processor will obviously handle that. If the sugar is high, then it will increase the delivery of insulin. And suppose if the sugar is falling, then it will stop the delivery of insulin. So continuous subcutaneous insulin infusion, that is CSII, is the best way to basically deliver insulin to a patient. This is where, like, you can use AI to advantage also, because we can keep the records of the patient for a long time onto the server. And well, the advantage of that would be that you can see how the blood sugar of the patient is working. Okay, great. Now coming to the next aspect which I want you to understand is that if a person cannot afford an insulin pump, then we will tell them to avoid using insulin syringes, because calibration is a problem. So you can use the insulin pen. In insulin pen, from the back side, now uski jo cap hoti hai, you can rotate that cap and you can adjust the dose of insulin, 10 units, 11 units, 12 units. You just need to turn the screw and you can adjust the dose of insulin. And here you can see also, like, what is the exact mathematical value of insulin that will be used. The insulin pen का जो needle होता है वो छोटू सा होता है. The needle of the insulin pen is very छोटू सा. It is a 32G needle. It is hardly having a length of 5 millimeter. So I can say that this insulin pen will be a painless and almost a bloodless delivery of insulin. It is a harmless, painless, bloodless delivery of insulin. An important aspect that he has asked is that when you will give this injection, it should be given at how much angle to the skin. Now normally you are aware that when you have to give a vaccine, the subcutaneous vaccine is given at an angle of 45 degrees. But here the needle is so chotu sa, if you give it an angle of 45 degree, it will not even reach at the subcutaneous tissue. So you hold the pen anterior, directly, like perpendicular to the anterior abdominal wall, and it is given at 90 degree angle. I repeat this once again. The question said that while using a insulin pen, what is the angle of the pen to the skin? Then this is 90-degree angle to the skin to deliver the insulin. If I will try to use the oblique approach of 45 degrees or lesser, then the drug will be not deposited in the subcutaneous tissue. It will be deposited in the skin only. So the injection is given at 90-degree angle to the skin on the anterior abdominal wall. The preferred site of insulin administration is the anterior abdominal wall. That is why you can see the CSI. That is why you can see the CSII pump is also attached to the intra-abdominal wall. Then the another way, like some people are very afraid of injections. Some people say, "Nahi sir, injection to nahi lagana hai." So if somebody is very afraid of injections, then you can use inhaled insulin. That is Afreeza. So inhaled insulin can also be used. That is Afreeza. This would be a rapid acting insulin. This is mainly like suitable for traveling. Like, somebody is going by flight, then it is a hassle to carry all those vials and injections and syringes and everything across airport security. So it can be carried like a small puffer in the pocket. And mid-flight, when the air hostess serving food, then just before that, the person can take this rapid acting insulin 5 to 10 minutes ago, and then this will start working in the body and the sugar in the body will be maintained. Yeah, Afreeza. No, not used for Alzheimer's disease. Okay. Now comes the aspect of what Indian patients will be doing. Most Indian patients will be purchasing this multi-dose vial of insulin. Most Indian patients will be purchasing a multi-dose vial of insulin that is like having 10 ml. The concentration here is about 100 units per ml. Concentration is 100 units per ml. It would be like a 10 ml vial. Though this vial can be misused by criminals also, no? If they inject so much of insulin to somebody, the person can die because of hypoglycemia. You know, some kidnapping cases have happened where where these guys they injected insulin into the victim, and the blood sugar of the patient began to fall, and the person became hypoglycemic, had a seizure, and finally died. And then, like, the murder cannot be proved now because you strangulate, or if there is some asphyxia marks, then it is easily identifiable. But if you are injecting insulin into body of somebody, then it becomes little difficult to like pick up like why the person had died. And even these Mossad guys, no, those Israeli guys, Mossad is a rogue agency. They keep on committing murders all over in the world, in Europe and everywhere else. I think Mossad is also responsible for killing some of Indian nuclear scientists also. Homi Baba's case was an air crash, but like lot of time our nuclear scientists have died. So many Iranian scientists, Iran ke jo scientists and nuclear scientists, they have been killed by Mossad. Again, the modus operandi has been the same. They've just barged into an apartment. They made it look like as if it is some kind of uh, theft attempt or like a break-in attempt, and then they injected insulin into the victim, and the victim finally died. So I mean, yeah. I mean, depends on like on which side you are, but then like I just want to say that killing scientists is not something which I would recommend, but they've been killing Indian and nuclear scientists all along, right? uh, Coming back to the agenda, multi-dose vial will be used with 1 ml insulin syringe that you can be purchasing here. That 1 ml insulin syringe will be having like markings, like if I slightly zoom in, you can see like 10 unit, 15 unit, 20 unit. So calibration because of the calibration issues also, like there can be errors on administration of insulin to the patient. Now what is the storage temperature of insulin? No, it is 100 units. It is 100 units per ml. Total will be 10 ml in the patient. No, it is 100 units in 1 ml. 100 units in 1 ml, but it would be like a total of 10 ml. Okay. Okay, ji. Yes, guys. What is the storage temperature? Bolo, bolo. What is the storage temperature of insulin? Obviously, इतनी गर्मी में तो खराब हो जाएगा ना, the potency will become lesser. So the storage temperature of insulin will be +2 to +8 degrees Celsius. The storage temperature will be +2 to +8 degrees Celsius. Like you have opened the vial, then it will be kept in the door of the refrigerator. And just like you keep vaccines now, so store to 2 to 8 degrees is the storage temperature. And as far as the shelf life is concerned, the shelf life would be of an opened vial will be under 4 weeks. Because अगर आप पड़ा रहने दोगे तो then the medicine potency becomes a little lesser. So it is recommended that you use a fresh vial, and you should be using up the insulin in the 4 week period or whenever the vial has been used. Then is long acting insulins also. So like okay, you guys, I give you an option. Can you tell me the longest acting insulin? Can you tell me the longest acting insulin? I think everybody has read pharmacology. So which insulin injection would be given like once a week, every 7 days? सारा इंसुलिन, हाँ ऑल इंसुलिन शुड, देखो पेन वाला तो पॉकेट में कैरी करेंगे, तो ऑफिस में जा रहे तो पेन में नहीं रखेंगे ना, पर्सन विल बी कैरिंग इन द पॉकेट. But wherever, like if it is like purchased from the market, like I purchased 5 pens, so I'm not going to carry all the pens together with me, na? So I'll keep couple of pens in the refrigerator, and then subsequently, yes, Glargine, Degludec. भाई वीकली हफ्ते में एक बार लगाना पड़ता है. I'll be blunt in this. अगर आपको ये क्वेश्चन का आंसर नहीं आता है तो आपने फार्मा में एंडोक्राइन सिस्टम नहीं पढ़ा है. Yes, that once a week insulin that we are using is basically called as Ecodec. जो वीकली होता है वो इकोडेक होता है. इकोडेक इज वंस अ वीक इंसुलिन दैट वुड बी यूज्ड हियर. डेटिमिर नहीं यार, वंस अ वीक इंसुलिन, द वंस अ वीक इंसुलिन इज कॉल्ड एज इकोडेक. दिस इज हफ्ते में एक बार लगाना पड़ता है. दैट इज 7 into 24. दैट वुड बी समथिंग लाइक ऑलमोस्ट, कैलकुलेट कर लो, तो एक हफ्ते में 168 आवर्स के आसपास बनेगा. So this is one of the longest acting insulin. No guys, it is not 42 hours. The answer is not 42 hours. That 42 hours is for Degludec. मैंने क्या बोला, मैंने बोला once a week. The question I said was what is once a week insulin. The once a week insulin is Ecodec that should be used. और कब इंसुलिन स्टार्ट करना होता है, तो इंसुलिन शुड बी स्टार्टेड इन एनी एसिम्प्टोमेटिक पेशेंट और टाइप 2 डायबिटीज इफ द HbA1c is more than 10%. ऐसा ना हो कि you answer metformin if he specifically says asymptomatic type 2 diabetes patient with HbA1c of greater than 10%, you will start insulin. And second is अगर symptomatic है, if weight loss is happening, then the threshold is 9%. In those circumstances, the threshold should be given as 9%. I repeat this fact once again. This is again an important concept to be remembered. If he says, how do you manage a patient type 2 diabetes and HbA1c is between 8 to 10%, I will give oral hypoglycemic agents and lifestyle modification, etc. that I will speak. But what is the threshold at which I should be starting insulin? Then for type 2 diabetes, more than 10% if it is asymptomatic. If he mentions symptomatic word, if he specifically mentions the word symptomatic, एंड अलॉन्ग विद द सिम्टोमेटिक वर्ड वो ये भी बोलता है कि पेशेंट का जो HbA1c है दैट इज अराउंड अबाउट 9%, देन यू विल से दैट आई विल बी स्टार्टिंग अगेन इंसुलिन इन द पेशेंट. सो इंपॉर्टेंट एस्पेक्ट हियर, आई विल रिपीट द स्टेटमेंट. आई वुड वांट यू टू इम्बाइब दिस इन योर माइंड. Type 2 diabetes, I agree, metformin. That's for values between 8 to 10 with lifestyle modification. If he says person is asymptomatic, values more than 10, he will have high incidence of microvascular complications. And because of that high vascular complications, the person can like deteriorate further. So I have to like, initiate aggressive treatment. Especially weight loss, the threshold is 9%. इंसुलिन और कहाँ पे देते हैं, तो डायबिटिक कीटोएसिडोसिस में देते हैं. The first two scenarios are the generic kind of data. Asymptomatic type 2, HbA1c 9%, symptomatic with value more than 9%. Then is obviously diabetic ketoacidosis. मैंने इसको बोल्ड में लिखा बिकॉज यहाँ पे जो इंसुलिन यूज करते हैं वो रेगुलर इंसुलिन यूज करते हैं. बाकियों के लिए तो लॉन्ग एक्टिंग इंसुलिन यूज करेंगे. फॉर 1 and 2 इट इज लॉन्ग एक्टिंग इंसुलिन दैट वुड बी रिकमेंडेड. बट फॉर पॉइंट नंबर 3, diabetic ketoacidosis, hypersmolar coma, and if the person is having life threatening hyperkalemia, then the type of insulin that you will be recommending to the patient is regular insulin. The advantage of regular insulin is that it can not only be given subcutaneously, it can be given intravenously. And if it will be given intravenously, तो वो तुरंत act करना शुरू कर देती है. When you are gonna give insulin to the person intravenously, it will start acting immediately. So these are the medical emergencies that I'm talking about. DKA, hypersmolar coma, hyperkalemia, where insulin of the regular variety will be given. Whereas for point 1 and 2, patients will always nowadays come to you and say, give me long acting molecule. I cannot be taking insulin injection multiple times per day. Agreed that in starting you might have to give insulin almost 3 to 4 times per day, but then gradually as control comes, then you can shift to like that either twice daily or once a week, or like, I mean, depends on how compliant the patient is. स्टार्टिंग में जब आएगा तो मैं सीधा नहीं वंस अ वीक नहीं चालू कर सकता. आई कांट स्टार्ट विद वंस अ वीक. I will have to go for aggressive management initially, and then subsequently once I get a control and I know the compliance of the patient is there, he also understands the side effect, hypoglycemia. That is when I'll be more comfortable managing this patient with like long acting formats. And insulin के साथ में हमेशा एक दिक्कत रहती है, that is hypoglycemia. Hypoglycemia is usually referred in multiple choice questions as Somogai phenomenon. Somogai phenomenon means that there was extra amount of bedtime insulin given to the patient. अगर आपने रात को extra insulin दे दिया, suppose you had to give Glargine to the patient, bedtime insulin 10 unit, and patient by mistake took 16 unit. You had written 10, but patient had taken 16, then the blood sugar of the patient will begin to fall. So there can be graph also given here where he will say like the person at 10 p.m. in the night, the blood sugar was, let me say, 150 or 200, whatever, and glargine was taken because I want euglycemia. So what will happen is the sugar will now begin to fall. The sugar will begin to fall in the patient. When sugar will begin to fall, there will be release of counter-regulatory hormones. What are the counter-regulatory hormones that will be released? Counter-regulatory hormone that will be released will be one, glucagon, because whenever insulin in the body is excess, then body will basically counterbalance insulin by releasing glucagon. Along with glucagon, cortisol will also be released. Along with cortisol, catecholamines will be released. Along with this, growth hormones will also be released. जब ब्लड शुगर कम होता है तो बॉडी क्या करता है, बॉडी विल ट्राई टू कॉम्पेंसेट एंड इसकी वजह से इसका जो ब्लड शुगर है वो बढ़ना शुरू हो जाएगा एंड देयरफॉर व्हेन ही विल वेक अप इन द मॉर्निंग द शुगर माइट बी हिटिंग लाइक 220 250. If you look at this representation, I wanted to teach you the following statement. Somogai phenomenon will be having nocturnal hypoglycemia. When the person is sleeping because he is taking more insulin, he will also have a lot of cold sweats at night. He may not wake up because of that, that's a secondary issue. But Somogai phenomenon will be corrected by nocturnal hypoglycemia. And then because counter-regulatory hormone release hoga. There are four counter-regulatory hormones. So look at how insulin, how powerful it is. That insulin का मुकाबला करने के लिए चार है ना अलग अलग hormones का काम होता है. Glucagon, cortisol, catecholamines, growth hormone. So what will happen in those circumstances is now the sugar will begin to rise and this will result in development of pre-breakfast hyperglycemia. Nobody has a challenge in remembering that diabetes will have hyperglycemia when the person will wake up in the morning. The only thing you need to remember is Somogai में alphabet O आता है. From that alphabet O you can remember that there is a nocturnal hypoglycemia in a patient. I repeat the statement again. Somogai phenomenon, there is a O component present. So it is रात को sugar drop करती है. That is nocturnal hypoglycemia due to extra amount of insulin. So I don't need to even ask you कि इसमें क्या करेंगे. Will you increase the morning? I am not even asking you. I know you know the answer. I'm not even asking you. I know you know the answer. Will you be increasing the morning dose of insulin or will you be adjusting the night dose of insulin? Obviously, it will be adjustment of night dose of insulin because the patient is taking more than what you had prescribed due to maybe miscommunication or sometimes patients have poor eyesight, cataract, etc. So they might be filling more insulin in this range than what you had prescribed. Somogai phenomenon is nocturnal hypoglycemia. I don't think so. He will even ask in the exam, how will you manage it? Because it is very simple that even a non-medico can understand that क्योंकि sugar drop कर रही है due to extra insulin, you need to stop, you need to adjust and recalibrate the dose of insulin taken at night. You don't need to increase the morning dose of insulin. Now we will study where will we be increasing the morning dose of insulin. That is what you can see, dawn phenomenon. डॉन फिनोमिनन क्यों होता है तो दैट इज बिकॉज ऑफ अ फिजियोलॉजिकल हार्मोन ग्रोथ हार्मोन जो होता है इट इज अ हार्मोन दैट इंक्रीजेस ब्लड शुगर बिटवीन 4 a.m. to 7 a.m. So here the graph will be like this. Like suppose this is 10 p.m. The person is taken glargine injection. The sugar is 150, 150, 150 and then from 4 a.m. के बाद से like the sugar will start showing a increasing trend and at morning the sugar might be still something like 250 or maybe even 300 in the morning. In patients or dawn phenomenon, at night you could be having a nocturnal euglycemia और अ माइल्ड हाइपरग्लाइसीमिया क्योंकि 4:05 पे क्योंकि जैसे हॉर्मोन्स आर वेरी वेरी फिक्स टाइम टेबल. So I can say that at night the blood sugar of this patient will either be stable or there will be a mild hyperglycemia present in a person. That would be like values of maybe it was 150. So instead of 150, it might go up to like maybe 170, maybe like 175, something like that after 4 a.m. After 4 a.m. in the patient. And when he will wake up, then obviously there will be a very significant pre-breakfast hyperglycemia. For this, you cannot do anything, sir. For this, you don't need to adjust the night dose. But what you can do is you have to curb the pre-breakfast hyperglycemia by giving and increasing the morning dose of insulin for the patient. Dawn phenomenon is unlikely to be asked from the diagram perspective because there will be a spike only present and you can understand from the spike it is a pre-breakfast hyperglycemia only. But if you check out the dawn phenomenon, in dawn phenomenon there are two things that are happening. एक जगह पे hypo है और एक जगह पे hyper है तो वो combos बना देगा. The combos in the PYQ were like nocturnal pre-breakfast was given. Combinations were nocturnal hypoglycemia, pre-breakfast hyperglycemia, the correct one. They were hypoglycemia, like 2 times hypo. hyper, and hypo. I hope you got the gist of it. There were 4 permutation combinations made by the examiner. He said which of the following is correct. The logic to be used is patient ने ज़्यादा इंसुलिन ले लिया तो रात को शुगर ड्रॉप करेगा तो बोलेंगे नॉक्टर्नल उसमें भी हुआ होता है, हाइपो उसमें भी होता है, हाइपोग्लाइसीमिया, and then the counter regulatory hormones will be causing the insulin level to rise. So I hope it's clear to everybody, guys. Just let me know if this is clear. Very good. Like there is no hassle in remembering the aspects of Somogai phenomenon versus that of Dawn phenomenon in a patient. Yeah, Dawn phenomenon is more, not exactly. I'll not say Dawn phenomenon is physiological. It is exaggerated in type 2 diabetes. Dawn phenomenon, growth hormone is the peak. Yeah, that's the same thing, na? Why the GLUT4 is down regulated? वो सेम है ना बेटा. जो GLUT4 है, वो GLUT4 का जो अपटेक है, वो क्यों GLUT4 काम नहीं कर रहा? क्योंकि ग्रोथ हार्मोन स्पाइक कर रहा है ना. तो वेदर आई राइट द वर्ड GLUT4 और ऐसे ग्रोथ हार्मोन भी, क्योंकि वो हार्मोन के पर्सपेक्टिव से पूछ रहा है ना. मैंने आपको हार्मोन कंपैरिजन दिया. आई होप यू आर अप्रिशिएटिंग. हियर द हार्मोन्स आर ग्लूकागॉन, कोर्टिसोल, कैटेकोलामिन्स एंड ग्रोथ हार्मोन, राइट. और यहाँ पे द ओनली हार्मोन इज ग्रोथ हार्मोन. सो ही विल नॉट आस्क यू ग्लूट बिकॉज इट इज इजी फॉर यू टू क्रैक द क्वेश्चन. वो हार्मोन के हिसाब से पूछ लेगा कि हाउ मेनी हार्मोन्स आर इंक्रीमेंटेड इन कॉजिंग डेवलपमेंट ऑफ सोमोगोई 4. How many are incremented in causing Dawn phenomenon? Then it would be only one, that is growth hormone. So yes, you are right, Shubham, and a couple of other people who had written that GLUT4 receptor is not working. वो उसका non working का reason ही वही है कि the growth hormone levels are spiking. But like in the exam, it is like from the hormone perspective, 4 hormones versus 1 hormone that would be taken. That would be responsible for this. Patient skips meals and takes insulin. Right? Absolutely, yeah. Absolutely right. बट सोमोगाइज क्लासली देखो बड़ा कम होता है. राइट, पेशेंट को भी समझ होता है कि स्किपिंग अ मील पे इंसुलिन नहीं लेना. यू नो, like I can understand if newly diagnosed patient he does not understand insulin much can happen, but if they've been suffering from the disease for so long ना, तो they have some education because they are in contact with you. तो इतना तो आप और मैं समझा ही देते हैं कि इंसुलिन से शुगर ड्रॉप कर जाती है. तो अगर मतलब खाना नहीं खाया तो इंसुलिन की डोज लेनी नहीं है या कम लेनी है. Right, like if the person is eating 1 roti instead of 4 rotis that he eats, then I'll say reduce the dose of insulin. And this is the reason why people prefer that pump now. That insulin pump is, it's a automated system. आपको झंझट नहीं है कैलकुलेशन करने का हाउ मच इंसुलिन टू बी टेकन. अदरवाइज वी विल हैव टू कैलकुलेट ऑन द बेसिस ऑफ बॉडी वेट. वी विल हैव टू यूज अ ग्लूकोमीटर एट द हाउस और कंटिन्यूस ग्लूकोज मॉनिटर. सो द हैसल लाइक फॉर प्रॉब्लम फॉर मोस्ट डायबिटिक्स इज कि सर बार बार प्रिक करना पड़ता है, बार बार शुगर चेक करनी पड़ती है. सो आई विल टेल अ डायबिटिक सर इफ यू वांट टू गो इनटू ऑटोमेटिक मोड कि आपको टेंशन ही नहीं है, आप अपना नॉर्मल लाइफस्टाइल जियो, रूटीन सिंपल खाना खाओ, दाल रोटी चावल, राइट, वट एवर यू वांट टू डू. यू वांट हैव चिकन, आई एम ओके विद इट. रेड मीट नहीं खाना, हार्ट अटैक का रिस्क इंक्रीज होता है. बट लाइक अल्कोहल मत पीना. बट इफ यू वांट लीव अ बिंदास लाइफ, केयर फ्री लाइफ, तो जस्ट गेट अ ऑटोमेटेड CSI एंड दैट विल डू द जॉब फॉर यू. चक्कर ही है बार बार कैलकुलेशन करने का. सो इन दीज सर्कमस्टांसेस we would be like done with the somogai and the Dawn phenomenon aspects that I have highlighted before you. And generally, I would like to put a question to everybody before I move on to the next point, that is basal bolus regimen. Like the question for everybody is that if a diabetic is having, like this is a diabetic, type 2 diabetes, his HbA1c is between 8 to 10% in spite of lifestyle modification. It's a patient with type 2 diabetes, his HbA1c is between 8 to 10% in spite of lifestyle modification, and he's not having any comorbidities at the moment. Like there is no heart disease, there is no kidney disease, there is no atherosclerotic cardiovascular disease. Then apart from metformin, what medicine should be started? What are the guidelines that what medicine should be given to this patient for control of blood sugar? Metformin plus what is the second medicine? Nowadays we recommend two medicines for all diabetics, just like in hypertension also we give two medicines together, like ACE inhibitor and CCB. For type 2 diabetes the recommendations are yes guys, can I have the answer please? What drug would be recommended? Type 2 diabetic, HbA1c 8 to 10%, no comorbid, no heart disease, no retinopathy, no nephropathy. What is the medicine that you will add? Like options are wahi sulfonylureas, SGLT2 inhibitor, DPP4 inhibitor. So what medicine should be given? Your answer will be that I will be starting the patient on SGLT2 inhibitor. Yes guys, nowadays we don't wait for complications to occur, because we know heart disease will occur, because we know the kidney damage will occur. So in spite of the fact that the MCQ will deliberately try to play a trick on your mind by saying no comorbidities, if lifestyle modification is not working, उसने सब कुछ try कर लिया, dieting, gymming, कहता है sir walking, exercise, everything, but the sugar is still remaining in these values, we should be starting the patient on metformin with SGLT2 inhibitor. But if I modify the question and say type 2 diabetes, same HbA1c range, and I say that the person is having atherosclerotic cardiovascular disease. I've already explained to you this concept, but I'll just write it once again that for those patients who are having atherosclerotic cardiovascular disease, that is ASCVD, the drug that will be given in this patient is, ये तो चलेगा ही चलेगा, ये तो चलेगा ही चलेगा, but the extra medicine that should be added in this patient is semaglutide. The semaglutide molecule that will be given is GLP-1 receptor agonist. That is how he will write the word GLP-1. I'll write it once again. This is GLP-1 receptor agonist, that is semaglutide should be added to these patients, because I have explained to you last time also that for atherosclerotic cardiovascular disease, GLP-1 receptor agonist would be recommended. Modifying the question once again, if he says diabetic patient HbA1c in this range, and he says that the person has already had heart failure and what medicine will be given, then it is the same medicines that will continue, metformin and SGLT2 inhibitor. Maybe you might have to slightly increase the dose of SGLT2 inhibitor to cause more salt loss from the body. So for most of the MCQs, you will notice that the answer will be metformin with SGLT2 inhibitor only. I could have avoided writing it saying that doctor, I've already told you this, you are expected to know this, you are expected to know it from pharma, but I've handwritten this. If you're not noted it, please do it right now. Metformin with SGLT2 inhibitor is the standard answer for all questions. Metformin with SGLT2 inhibitor is a standard answer for all questions. Only 2 MCQs will you be answering a different aspect, which is add-ons. The add-ons will be one, that if he says atherosclerotic cardiovascular disease, that is already heart attack has occurred in a person, or like stenting ho gaya hai, coronary artery bypass grafting ho gaya, you will add GLP-1 receptor agonist. This additional aspect which I want to say is that if eGFR is given to be less than 20, then SGLT2 inhibitors are not very effective in that eGFR zone of less than 20. जो empagliflozin है ना, that's like one of the commonest ones that is used, because it can be used in low eGFR also. So one, I'm just saying practically, I mean, like you will notice lot of doctors writing EMPA. The reason why everybody is after empagliflozin is because it can be given in low GFR also, but don't answer it for eGFR less than 20. If he says eGFR is less than 20, what medicine should be added now? Then I mean, SGLT2 inhibitor will not be recommended, and the medicine would be given as DPP4 inhibitor. DPP4 inhibitor would be like sitagliptin or saxagliptin that can be given in this patient. So I repeat my points again. For all MCQs of type 2 diabetes, initially if HbA1c is very very high, I can start with insulin and then I can downgrade to these medicines. But metformin के साथ में अभी sulfonylurea नहीं देते. Metformin के साथ sulfonylurea नहीं देते because it does not cause any cardiorenal benefit. SGLT2 inhibitor, I have explained to you already, it causes a cardiorenal benefit, and then 2 additional points have been added to your vocabulary. The concept of semaglutide, when and why. I mean, I've been very vocal about it because they've asked about it. Atherosclerosis, heart attack, not heart failure. Heart failure is already on the board. And if eGFR is less than 20, then SGLT2 inhibitors, EMPA will not be used. Then the drug that will be used in this patient is DPP4 inhibitor. Is it clear, guys? Is it clear, guys? Can I get a quick yes or a no for this? This is a standard algorithm, right? आपको डायबिटीज का बाकी कुछ नहीं आता, मैं बोलूंगा माफी है, लेकिन ये जो मैंने अभी बोला ये आपको आना ही आना है, because this is what they love to ask in the paper nowadays. Okay, fine guys. Now I will talk about fine guys. Now we will focus on basal bolus regimen. Basal bolus regimen is recommended especially in children who are having type 1 diabetes mellitus, because उनमें तो insulin से ही yeah we can start DPP4 inhibitor also. We can start the DPP4, तभी तो ये बंद कर देंगे ना यार. यार मैंने बताया हुआ है, you know, अब क्या होगा कि ना मैं जो डेटा लिखूंगा वो रिपीट हो जाएगा, बट चलो अब आपने बोला तो metformin is not to be given if eGFR is less than 30 ना. That's the gray area ना. metformin is not to be given, क्या करेंगे, इंसुलिन दे देंगे ना. If he says, दो मैंने इसको आगे किडनी में बोलना था पर आपने अभी पूछ लिया तो मैंने बता दिया कि metformin is not given if eGFR is less than 30, तो क्या करेंगे, इंसुलिन दे देंगे. इंसुलिन भी कितना देंगे, तो 80% ऑफ द कैलकुलेटेड डोज, दो आई वुड हैव लव टू आस्क यू गाइस, बट उल्टा आप लोगों ने मुझसे पूछ लिया तो मैंने बोल दिया। तो ये मैं चाहता था कि सस्पेंस रहे, एंड वी विल डिस्कस दिस अगेन, क्योंकि इंसुलिन कहाँ से मेटाबोलाइज होती है, तो इंसुलिन भी तो किडनी से ही मेटाबोलाइज होती है, वो भी तो किडनी से मेटाबोलाइज होती है। सो देन इट इज गोना बी 80% ऑफ द कैलकुलेटेड डोज दैट विल बी यूजिंग इन दिस पेशेंट। ओके जी, नाउ कमिंग टू द बेसल बोलस रेजिम। Basal bolus regimen can be used specifically in patients with type 1 diabetes where we need to get, because there's an insulinopenia. So the rationale in this particular case is, and I don't want you to draw anything, it's already drawn, but just listen and hear my words out. When this child will eat his breakfast, then the sugar will suddenly spike in the body. Because you know the sugar will spike. I'll say that again. If a person will eat breakfast, then the sugar will spike, and diabetics में जो postprandial spike होता है, that causes glucose toxicity. If you want the sugar to come down to euglycemic range, if you want the sugar to come back to euglycemic range, what you should do in the patient is कि 15 मिनट पहले या 10 मिनट पहले you can be giving rapid acting insulin to the patient. The rapid acting insulin का जो ग्राफ है मैंने अभी दिखाया, that is in black color. So when rapid acting insulin will work, it will bring down the spike and it will help in achieving euglycemia in the patient. The message I'm trying to say is that if a person is like type 1 diabetic child, before 10 minutes before breakfast, 15 minutes before breakfast, rapid acting insulin should be given to the patient. This black graph that I have made here before you, this is of rapid acting insulin. This rapid acting insulin can be in the form of Lispro, Aspart, Glulicin, any of those can be used, and is basically referred as bolus insulin. Why we are calling it bolus insulin is because it is the bolus that is neutralizing the spike of the sugar. The red is the spike of sugar and the black is neutralizing the spike of the sugar, so that euglycemia in the patient can be maintained. Now, when this person will have his lunch, let me do this again. Person had his lunch. Normally, like when the child will come back to school, तो लंच थोड़ा हैवी होगा, क्योंकि मोस्टली देखो बचपन में लाइक इवन व्हेन यू वुड बी गोइंग टू स्कूल, तो मॉर्निंग में खाया नहीं जाता ज़्यादा, तो द चाइल्ड माइट बी हैविंग वन पीस ऑफ ब्रेड और मे बी वन एग और ऑमलेट समथिंग लाइक दैट, तो द कैलोरीज वर लेसर. नाउ द मदर विल मेक हिम ईट मोर. सो बिकॉज द चाइल्ड विल ईट मोर ऑल्सो, ऑब्वियसली व्हेन ही इज कमिंग बैक फ्रॉम स्कूल थका भी हुआ है, तो शुगर का राइज भी ज़्यादा होगा. एंड इफ द शुगर विल राइज मोर, and if the sugar will rise more, you will want to achieve euglycemia also very very fast. So what you will do is you have to again give a rapid acting insulin a few minutes before he has his lunch, and the euglycemia part will be obtained. What I'm trying to say here is that you need to adjust the dose of insulin proportional to the amount of carbs the person is eating. You have to adjust the dose of insulin proportional to the amount of carbs that the person is eating. 1 unit of Lispro or Aspart, इसको नोट नहीं करना है, 1 unit of Lispro or Aspart can neutralize 15 grams of carbs. 1 unit of Lispro can neutralize 15 grams of carbs. So suppose the child is eating 2 paranthas and they're having 60 grams of carbohydrate, then 4 units of Lispro will be required to neutralize the carbs. Nowadays you don't need to do this noting part. You will click a picture of the plate. Nowadays there are apps available. You will tell the mother, ma'am, when you made the paranthas for the child, when you're giving the plate to the child, click a picture of the food plate and the app will tell you how much insulin needs to be given to the child based on the amount of food. No, because the food that we eat normally वही same ही रहता है ना, दाल रोटी, some dal chawal, something combinations are standard, or mutton or something. I mean the combinations are mostly the standard routine items, or to split of sabji before a bit of some additional items might be added. So what you will tell the mother is that we will determine how much is the insulin requirement of your child, not on the basis of like overall weight, but on the daily calories that are consumed. Because every day the amount of food that we consume is different from the previous day. So here we are giving proportional to the amount of food that is eating. And then at the same time I'll draw a third curve fast here also, like your dinner लिया तो डिनर वाला जो इंसुलिन जो शुगर का ग्राफ है उसको नॉर्मलाइज करने के लिए अगेन 15 मिनट पहले 10 मिनट पहले रैपिड एक्टिंग इंसुलिन दे देंगे. बच्चे खुद से खाना नहीं खाते, बच्चे खुद से खाना भी नहीं खाते और बच्चे खुद से इंसुलिन भी नहीं लेते, तो मदर को देना पड़ता है. तो यू हैव टू टेल द मदर दैट मैम इफ यू आर गिविंग इंसुलिन, तो विद इन 10 मिनट्स टू 15 मिनट गिव फूड टू द चाइल्ड टू ईट, क्योंकि बच्चे खुद से तो खाते नहीं. आधा टाइम द चिल्ड्रन आउट इज द फसी ईटर्स एंड दे डोंट ईट. सो अगर बच्चा नहीं खाएगा तो हाइपोग्लाइसीमिया हो जाएगा. See, a mother has so many things to do in the kitchen. Now she is juggling all the things in the house. She might forget वो kitchen में खाना बनाने में busy हो गई, and she could not give food to the child on time. If the food will be delayed, the blood sugar will begin to fall. So at this moment, one, I wanted to standardize you to what do I mean by rapid acting insulin. It is bolus insulin, which is before meal. बोलस इंसुलिन जो भी खाना खाने से पहले देते हैं, जो भी बोलस इंसुलिन मेजर मील से पहले देते हैं, उसको हम रैपिड एक्टिंग इंसुलिन बोलते हैं. नाउ व्हाट आई विल डू इन दिस ग्राफ इज आई विल यूज अ डिफरेंट कलर पेन टू से कि कल रात को 10 बजे, imagine this is last night 10 p.m. At 10 p.m. in the night the child was also given, at 10 p.m. in the night last night the child was also given a long acting form of insulin, that is glargine. This glargine levels will be like this all through working for 24 hours. So what I have shown in color green before you, what I've shown in color green before you is what is technically called as, this is long acting insulin. The name of this long acting insulin is glargine. This long acting insulin is what is called as basal insulin. It is called as basal insulin. So in your exam all they have asked is कि basal वाला कौन सा होता है और bolus वाला कौन सा होता है. आप एक याद करो अभी. Try to remember only one. What is the basal insulin? Basal insulin is glargine. What is the basal insulin? It is glargine. It is the 10 p.m. shot. It will be causing थोड़ा थोड़ा insulin level in the body. जैसे अभी आप खाना नहीं खा रहे हो, you guys are not eating at the moment, you might be munching something, but most of the time like if you're not eating, then तब भी तो थोड़ा थोड़ा insulin आता रहता है ना to stabilize the blood sugar values. So this is that thoda thoda insulin that our pancreas keeps on producing. That's the basal level. That's the basal level. And then if it is required, if you are gonna eat like दो बिस्किट खा लिए, स्नैक्स खा लिए, तो फिर नमकीन खाया, तो then like the sugar will spike and we need a bolus insulin. So your and my pancreas does this job. Our pancreas does basal and does bolus productions. But obviously in type 1 diabetes, the pancreas is destroyed, the beta cell mass is totally hampered. So it is like basal insulin is the long acting form of insulin, and the rapid acting insulin is what I've highlighted before you. The rapid acting insulin that I've highlighted is the bolus insulin that would be given before meals in the patient. This is the meaning of the word basal bolus regimen. I have hand drawn this instead of like drawing in that curve because उसमें थोड़ा सा understanding part में issues होता है. But since you have done the color coding yourself, it will become easier for you. The 15-second summary is what is bolus insulin? Rapid acting. Bolus is फास्ट वाला है ना. बोलस बोलस मतलब फास्ट दे दिए, फास्ट मतलब रैपिड एक्टिंग, ऐसे याद कर लो ना. बोलस मतलब फास्ट, बोलस इंजेक्शन इज फास्ट, सो रैपिड एक्टिंग इंसुलिन. एंड बेसल इज लेड बैक, रिलैक्स. तो वो रिलैक्स वाला कौन सा? दैट इज ग्लार्जिन, दैट विल बी यूज्ड इन अ पेशेंट. सो दैट इज लाइक वन वे बाय व्हिच आई थिंक यू विल बी एबल टू रिमेंबर दिस. And now we will focus on, like there were 3 graphs I highlighted. One was for the insulin part, another part was the Somogai phenomenon, and the Dawn phenomenon that I explained to you. So those are like the graphical representations that would be given here. And now is a question for you guys. What is the most common skin lesion in type 2 diabetes? These are images also. I'll come to the images after I have like done the theory part. So do you want me to give options? I don't think so, right? Or I'll just keep on speaking and you pick up the right answer. One is like diabetic dermopathy, then diabetic dermopathy, necrobiosis lipidoica diabeticorum, acanthosis nigricans. I think this is one of the easiest questions that I'm asking everybody today. What is the most common skin lesion in type 2 diabetes? Options come again. Diabetic dermopathy, necrobiosis lipidoica diabeticorum, acanthosis nigricans. I would like everybody to just go ahead and start discussing regarding the aspects which have been asked here. Yes, I'm waiting for more people to comment there. Okay. Most common skin lesion in type 2 diabetes, I am getting answer as acanthosis nigricans, though some people are given the correct answer also. Guys, if you are having a diabetic in your family, most diabetics in your family will be having these kind of brown spots on their shin. These brown spots on the skin are called as blinky spots. The answer to the question is not acanthosis nigricans. That is a very common misconception. No, it is not acanthosis nigricans. भाई आपने ध्यान से नहीं पढ़ा है, डर्मा के नोट ध्यान से नहीं देखे. It is one of the findings of insulin resistance, but it is not the most common skin manifestation that is present. If you are having a diabetic in your family, तो उनकी कंप्लेंट क्या होगी कि बेटा ये देखो जरा शिन पे ना से काले काले से धब्बे पड़ रहे हैं, ब्राउन से मैक्यूल्स आ रहे हैं, इनको ब्लिंकी स्पॉट्स है, डायबिटिक डर्मोपैथी बोला जाता है. दिस इज द क्वेश्चन विच इज यूजुअली अ सिली मिस्टेक डन बाय स्टूडेंट्स. दैट वो सीधा, क्योंकि भाई डायबिटीज में तो हमने पढ़ा है कि भाई acanthosis nigricans होता है, उसका मतलब ये नहीं होता है कि दिस इज द मोस्ट कॉमन मैनिफेस्टेशन. द मोस्ट कॉमन स्किन लीजन गाइस द मोस्ट कॉमन स्किन लीजन, फिर से बोल रहा हूँ, एकैंथोसिस नाइग्रिकेंस नहीं है, अभी भी वही आंसर आ रहा है. इट इज डायबिटिक डर्मोपैथी which is the most common skin manifestation in type 1 diabetes. This diabetic dermopathy that I've written here before you can casually also be written as blinky spots. The meaning of the word blinky spots would be brown. Yeah. The same complaint, cosmetic complaint will be there. Blinky spots are brownish macules on the shin. If I change the question to what is the most common skin lesion in type 1 diabetes, then your answer will be a very longish name. He will say boy or girl with type 1 diabetes has come to the hospital with lesions on the shin, SHIN. Again, the lesion on the shin this time will be having a central clearing. This is called as necrobiosis lipidoica diabeticorum. I will be linking them to the diagrams also, which are or the images which are given below. But at this moment, the theory part is good, then the images become smooth and easy. Absolutely. Necrobiosis lipidoica diabeticorum is the most common skin lesion in type 1 diabetes. Now we come to most common skin lesion in glucagonoma. This was a nasty question that came in FMG exam. कैसे दिया उसको देखो. उसने बोला patient is having diabetes mellitus. Along with that, the patient is having depression. Along with that, the patient is having deep vein thrombosis. There were D's that were given in the question. Diabetes mellitus, depression, deep vein thrombosis, and he said the patient has been identified with a pancreatic neuroendocrine tumor. He did not write the word glucagonoma. Here I have written that word to make it easy for you. The question mentioned diabetes mellitus, depression, deep vein thrombosis, and dermatitis in a pancreatic neuroendocrine tumor. And then he did not even say that what is the pancreatic neuroendocrine tumor. वो बोला what is the dermatitis that is present. Yes, most guys have answered it correctly. I would rate this as the most technically challenging question of this particular part of the slide. This is necrolytic migratory erythema. Just like point number 1 is a silly mistake, this is something that you have to remember. Necrolytic migratory erythema is a skin lesion of glucagonoma. How glucagonoma was given in the question was in the form of Ds. The Ds are obviously not diarrhea, dermatitis, and dementia. That is for niacin deficiency. Like if I say to you, farmer came to the hospital, corn eater came to the hospital, diarrhea, dementia, dermatitis, then obviously it's gonna be the niacin deficiency. This was diabetes mellitus, depression, deep vein thrombosis, and dermatitis component, which is necrolytic migratory erythema. Here I have got very good answers here. And now we come to causes of acanthosis nigricans. As far as the causes of acanthosis nigricans are concerned, obviously this condition has insulin resistance. So by default, the answer will be type 2 diabetes mellitus. This will be hyperpigmentation on the back side of the neck and can involve even the axilla area or the axilla skin of a patient. So for control of diabetes, type 2 diabetes is your answer was how do you manage it. So control diabetes, they tend to become lesser. Causes of acanthosis nigricans can be type 2 diabetes, that is insulin resistance, that is one. Then is obviously PCOD. But in NEET PG, one of the questions did not have type 2 diabetes and PCOD in the options. Then if these two are not in the options, then your answer is, this especially for NEET PG aspirants, your answer would be given as metabolic syndrome. Then your answer would be given as metabolic syndrome. I will write down the features of metabolic syndrome also once I'm done with this particular part of the discussion in the lower part. But at this moment, these all are basically causes of insulin resistance. But then it can be seen due to malignancy also. The malignancy can be in the form of carcinoma pancreas. The malignancy can be in the form of a stomach cancer. So GI malignancies are also contributing to acanthosis nigricans. तो हल्के में नहीं लेना है. Like if insulin resistance is not the cause, then we must start the patient's evaluation for some occult malignancy. It can start with like a whole body PET scan so that we can identify any occult malignancy which can be responsible for acanthosis nigricans. Now, when you look at the images, you can pick up that the first one that is highlighted is diabetic dermopathy. This diabetic dermopathy is called as blinky spots. The image on the right is having central clearing. You can see that in the middle, the skin looks normal and then around it, all red area is present. This is what I was describing. as necrobiosis lipidoica diabeticorum. Necrobiosis lipidoica diabeticorum is more common in type 1 diabetes mellitus. We will always advise diabetic patients to avoid doing barefoot walking because lots of time diabetic patients can also be developing non-healing ulcer in the sole of the foot. The reason for non-healing ulcer will be one, angiopathy, that wounds will not heal. One of the reasons why there can be non-healing ulcer in diabetics would be that the wounds will not heal because of the angiopathy component. Plus, the skin breakdown rate is also more, nerves are also damaged. So, the combination of angiopathy, dermopathy, and neuropathy will cause non-healing ulcer. You have to tell me what is the most common site of non-healing ulcer in a diabetic. The options are toes, metatarsal head, heel. Please select from this. The ulcer can develop at any point of time. Ulcer is a combination of nerve damage, geopathy, dermopathy. If you combine all of them, skin breakdown rate is more, you get an ulcer. The most common site is going to be the toes. It is the undersurface of the toes, though the ulcer can occur on the metatarsal head also, but the most common site of a non-healing ulcer in a diabetic would be the toes on the patient, and therefore we will advise these patients to avoid weight bearing, regular dressing to be done so that the wounds would be healing. Metatarsal head is the second most common site. Most of the time it is the toes and the undersurface of the toes that can get involved in these patients. And then obviously we have acanthosis nigricans. This acanthosis nigricans is a feature of insulin resistance. This acanthosis nigricans is a hyper velvety plaques. It's a pigmented, hyperpigmented velvety plaques which are present on the dorsum of the neck, but sometimes can involve the skin of the axilla also. So most of the time it will be PCOD female or it would be type 2 diabetes mellitus, but like a NEET PG, it was regarding syndrome X in a patient. So you guys can comment in the chat box for what would be syndrome X when I ask you. One of the components of syndrome X would be centripetal obesity. So what you have to tell me is that abdominal circumference. You will be checking the abdominal circumference of the patient. The abdominal girth of the patient or abdominal circumference should be more than how many centimeter for a Indian male and an Indian female respectively. To say that the person is having centripetal obesity, then the cutoffs are 90 and 80 represently. That is going to be centripetal obesity. Because of centripetal obesity, there would also be a development of hypertension. The cutoff here is usually taken to be 130 by 85. Surprisingly, not written as 130 by 80 or 130, 140 by 90. It is 130 by 85. No, we don't take into consideration cholesterol here, beta. We don't take into consideration cholesterol. These patients can be having impaired glucose tolerance because centripetal obesity causes insulin resistance. So impaired glucose tolerance can be present where the fasting blood glucose of the patient can be in the range of 100 to 125. The 2-hour value of this patient can be in the range of 140 to 199. LDL is not a component, is the main thing. The component which is present here and is neglected is hypertriglyceridemia. The triglycerides of these patients will turn out to be more than 150. And as far as the good cholesterol is concerned, the HDL values will be less than 40 and 50 for females and men respectively. My point is it is gender sensitive. Don't get into like male or female, what are the values. All I want to say is that this is one such report in routine studies where LDL is not a component. LDL is not a component. So acanthosis nigricans can also be a skin manifestation in this particular patient who's said to be having metabolic syndrome. Metabolic syndrome is also called as syndrome X. Metabolic syndrome is also called as syndrome X. Let me know how many out of these 5 should be present to say it is metabolic syndrome. How many out of these 5 manifestations should be present to call it metabolic syndrome? You will say 3 out of 5 should be present to call it metabolic syndrome. 3 out of 5 manifestations should be present to call it metabolic syndrome, and the skin manifestation in this patient would be called as the skin manifestation in this condition would be called as acanthosis nigricans. Additional point, especially for innocent students, is what is syndrome Z? A question directed at innocent aspirants. What is syndrome Z? Syndrome Z would be a combo of syndrome X, and the additional finding will be that of obstructive sleep apnea. Syndrome Z security, Z grade security. Syndrome Z is a combo of syndrome X plus obstructive sleep apnea. What I've explained to you today are lifestyle disorders very common in our country. Uh, the Hindi word I can say for them is halwai. Halwai would be like a person who's sitting at a sweet shop and like he's eating whatever sweets that he's making. So what it's gonna contribute to is impaired glucose tolerance, hypertension. Most Indians have fatty liver concomitantly, triglycerides are elevated. Most of us, including like if you are not working out and you've been sitting for 6 months preparing for any of the exams, I mean, most of us would start developing this because we have a genetic predisposition. Our body cannot adjust food. You know, our the Britishers, they starved us of food. If you read about Bengal famine, if you read about Tamil Nadu famine, they deliberately deliberately put taxes on us, because of which our ancestors were very thin, skinny, and we used to get only one meal a day. I would also take you back to 1970, 71, when we had like, 1970, 71, Lal Bahadur Shastri gave that slogan, Jai Jawan, Jai Kisan. And, at that time, there were famine in India, even after independence. Indians used to eat one time a day. Then the Americans said, we will give you GE wheat, that genetically modified wheat. So we took that wheat from Americans, and then suddenly Punjab started growing lot of wheat, and we start eating roti. And because of that roti came diabetes mellitus. Because our body cannot adjust to that high glycemic index foods that we are eating. In India, our ancestors used to eat bajre ki roti. It was millet-based diet. That is why even this year on Independence Day and Republic Day, the Prime Minister of India came up and he said, I declare this year as the year of the millets. Year of the millets because one, we are having less rainfall and like these crops require a lot of water and we are short on water. And second, our ancestors used to eat bajre ki roti, makki ki roti, so they did not have diabetes mellitus. The moment we started eating this genetically modified wheat, that white atte ki roti, that soft fule rotis जो हम देखते हैं ना, soft roti, fluffy rotis that we all crave for. A lot of you have gone abroad to study, so first thing you would have missed is your mama's roti. That roti has been responsible for causing a development of diabetes mellitus epidemic in India, that almost 11% to 12% of India, that is 10%, 10 to 11 to 12% of India, that's almost like one tenth, more than one tenth of India is a diabetic population as well. So it's like because our body is not able to handle that high glycemic index food. So this is a pure like lifestyle disorder that has occurred in we Indians. Okay. So all these aspects that I've discussed before you are related to diabetes mellitus. I've covered all those PYQs that have come. And now we will just revisit pheochromocytoma once again so that we can get the aspects right. So I would like you to let me know. I think you have had pathology class already. So like what is this pathology finding called as? Like this is a slide from a suspected pheochromocytoma. I'll teach you the manifestations also. But like this are called as nests of Zellbolen. This is one of the most often, yes, this is one of the most often slide that is given where you can see those support cells, sustenacular cells, and even the pheochromocytoma cells. They're forming those nests as you can see. So nests of Zellbolen are like the key feature that are usually asked for pheochromocytoma. Pheochromocytoma will be a tumor related to catecholamines. If he says what is the leading catecholamine produced by normal adrenal medulla, yes guys, you can comment quickly. What is the leading catecholamine produced by normal adrenal medulla? Like in you and me, what is the catecholamine that is produced? Normal people. Options are like वही यार epinephrine or epinephrine and dopamine. So in a normal person, what is the major circulating catecholamine? Then the major circulating catecholamine in you and me is not norepinephrine. In a normal person, it is epinephrine. Yes, guys, pheochromocytoma produces norepinephrine. Tumor will not respect physiology. Tumor will not respect physiology. He will say, who the hell are you? He's gonna misbehave. So if it is gonna be a tumor, if I say to you that, okay, tell me what is the major catecholamine produced by a pheochromocytoma, and you answer norepinephrine, you are spot on. But if he says normal person, then the answer is epinephrine. What is the function of catecholamines in the body? Well, catecholamines often the body are responsible for that fight or flight phenomenon. Like sometimes, somebody says bad things to you, you will suddenly get aggressive. But like, that guy whom you decided to pick up a fight was having cauliflower ears. You decided to, like, you purchased a car, a new car, and somebody scratched it at a Delhi traffic red light. Some biker scratched it at the Delhi traffic red light. So in your anger, you got out of your car and you said ki, aaja samne. So that guy took off his helmet and this guy was having cauliflower ears. You can understand cauliflower ear means that the guy does wrestling and MMA. So if I'm gonna get in contact with like a wrestler or MMA, then I will say कि भाई गलती होगी जाने दे, scratch मैं insurance से ठीक करा लूंगा, and I would not like to pick up fights here. And anyway, in Delhi, never pick up a fight, sir, because Delhi people are crazy. They carry guns. You would have seen so many road rage accidents where people will be just shooting a gun. In fact, I was just reading yesterday, there was a policeman, right? He was involved in a road rage, right? He fought with some Swiggy, Zomato guy, and he shot him, man, with his service revolver. Just over a small thing, right? These guys were parking bike at the corner of the road. You can just check it on Google also. And like policeman shooting a ordinary civilian, crazy man. I mean, over a small tiff, like the guys had parked their car and they were watching mobile, and maybe he asked them move because he wanted to park his car there. They did not move, so he shot them with his service revolver. One guy shot in the chest, and the bullet went through the chest and hit the other guy in the abdomen. I mean, how angry can you be to park your car, right? I mean, that's the amount of craziness people tend to have. That I mean, गाड़ी का parking, right? I mean, and I'm very sure a lot of you who have been to like South Delhi, Greater Kailash area, or like so-called posh areas, right? And people fight with each other for something as simple as parking here. Neighbors, they are like bloodthirsty, and yeah, you can't rely on police at pay. That's why people nowadays will do their own thing. And epinephrine, and now comes the critical question. And व्हाट इज द लीडिंग कैटेकोलामाइन प्रोड्यूस बाय फेओक्रोमोसाइटोमा? देखो, अमेरिका तो कुछ नहीं कहता था। अमेरिका के तो प्राइम मिनिस्टर प्रेसिडेंट पे गोली चल गई कल। हमारे तो यहाँ पे लोकल चली ना, प्रेसिडेंट के तो ऊपर गोली चल गई, तो अमेरिका तो कुछ नहीं कहता था, है ना। अमेरिकन तो उनका तो मतलब सिस्टम ही अलग है। ओके, yes. What is the leading catecholamine which is gonna be produced by pheochromocytoma and multiple endocrine neoplasia type 2? So if it's gonna be multiple endocrine neoplasia type 2, MEN2 syndrome, if specifically he says the word MEN2 syndrome, or if he says the word Sippel syndrome, though like you have read this about in pathology, but still I'm making you practice that if he specifically says MEN2 in the question and says the word Sippel syndrome, then your answer will again switch over to epinephrine. So the point to be understood is that for pheochromocytoma, simple answer is norepinephrine. But you can see two MCQs are having answer as epinephrine, so I will rate them as more important. These two questions will be having higher chances of being asked. These two questions that are putting a mark are having higher chances of being asked. Why? Because standard answer is norepinephrine, but then two questions are having an answer as epinephrine. So be very, very careful. Normal person also epinephrine, and MEN2 syndrome is also epinephrine. And then comes what is extraadrenal pheochromocytoma. So extraadrenal pheochromocytoma is what is called as paraganglioma. The extraadrenal pheochromocytoma is called as paraganglioma. If I change my question and say what is the histopath finding of paraganglioma, same, nest of Zellball. What is the major catecholamine produced by paraganglioma? Same, norepinephrine. Paraganglioma is only a term that you guys need to remember, that is outside the adrenal medulla in the sympathetic ganglia. The location is most of the time, if he says what is the location, your answer will be it is present in the sympathetic chain. It is present in the sympathetic ganglia. But apart from this, what you need to remember is what does it produce? Norepinephrine. What is the histopath finding? That is nest of Zellballen. ये सिर्फ अलग से नाम बनाया गया है for a tumor which is not in the medulla, it is outside the medulla. Then remember an association which always comes in the paper. Neurofibromatosis 1 is associated with pheochromocytoma. That is just an association, NF1 association with pheochromocytoma to be remembered. Sometimes even they read about VHL gene. VHL gene is for renal cell carcinoma, clear cell carcinoma. Even that can be associated. But that NF1 gene is more frequently asked. So that is what I have highlighted that. Though you can read about VHL gene also in your pathology notes. Now, what are the clinical buzzwords that will be given in the question for this? The clinical buzzwords would be PhD, that is palpitations, then there would be headache, and there would be diaphoresis. It is so simple that it is impossible to be missed. Like he will say a young guy comes with complaints of palpitations, he is also having headache. Please don't answer hypertension here. Hypertension is the reason for the headache, but he's asking what symptoms that are present in a patient. So there would be diaphoresis that would be present. So palpitations, then is going to be headache, and then is going to be diaphoresis, which is going to be responsible. PhD is a mnemonic to remember this. And then in the examination finding, he will always say the word paroxysmal hypertension. One of the very good words in the MCQ will be paroxysmal hypertension, or the word will be episodic hypertension. You are not going to come across these words anywhere else. Paroxysmal hypertension and episodic hypertension both mean the same. It means that there will be spikes of blood pressure. Like our blood pressure will be having, like, it's not constant, it's fluctuating, but here it's like spiky, because catecholamines, they cause surge in blood pressure. So it is paroxysmal or episodic hypertension that would be happening in a person. And because palpitations and sweating can happen in anxiety neurosis also, so lots of time the guy might be already on medication, like he's already on benzodiazepines, he's already on I think I asked you also, now, what is the usual benzodiazepine required for anxiety neurosis, which causes less sedation? Yes, the hypertension is because of the vasoconstriction caused by catecholamine. Which benzodiazepine is best suited for anxiety neurosis? Because I don't want the patient to sleep all the time. Benzodiazepine, I'll just wait for a few seconds. Maybe you looked it up. Yeah, we are coming to that. Yes. No, sir, no, sir, absolutely not. So clonazepam दोगे तो सोता रहेगा. It is etizolam that is usually used in the patient. So the benzodiazepine that you are using, भाई ये सारी दवाइयाँ दोगे तो सारा दिन सोता रहेगा. He'll keep on sleeping. वो बोलेगा मेरे को कॉलेज जाना है, मुझे पढ़ाई करनी है and everything. He will not be able to do it. So we have to give those drugs to the patient which cause the least amount of side effects. So most of the time they've asked what is the medicine that is used. Your answer has to be very precise. In young guy, the drug used is etizolam, and the second one is SSRI that is used is paroxetine. फॉर एनी यंग पेशेंट डोंट यूज लोराजेपाम डाइजेपाम. आप देने को तो यार कुछ भी दे सकते हैं, एल्प्रेक्स भी खिलाते हो. आपने खुद कभी एल्प्रेक्स अगर कभी खाई हो एंग्जाइटी में एग्जाम से पहले, तो इतनी नींद आती है कि आदमी काम ही नहीं कर सकता, ड्राइविंग नहीं कर सकता, आदमी का एक्सीडेंट हो सकता है. सो वी गिव इटिजोलम एंड एसएसआरआई दैट इज यूज्ड paroxetine फॉर these पेशेंट्स. So most of the time the question will mention about the following findings. But now another very peculiar thing that will be present in the question is postural hypotension or orthostatic hypotension. When I describe like this, the query of young doctors is, sir, what are you saying? Sir, you are saying hypertension also and hypotension also in the same patient. एक ही पेशेंट को दोनों हो जाएंगे, हाइपरटेंशन भी हो जाएगा, हाइपोटेंशन भी हो जाएगा. मैं कह रहा हूँ yes, same patient will have the same thing, but not at the same time. In the early part of the disease, in the earlier phase of the disease, in the early phase of the disease, you will be having is a presence of hypertension. But in the later part, there would be a development of very severe vasoconstriction. That vasoconstriction will basically help in, that's very severe vasoconstriction would basically help in development of decrease in the intravascular compartment. And in the late phase of the illness, you will be having is a postural hypotension. This is again a peculiarity, because normally if a disease causes hypertension, it causes hypertension always. If some disease causes hypotension, it causes hypotension only. Nowhere else will you ever read in your whole career a disease that first causes hypertension and then causes hypotension. I'll give the reason again. Blood vessels सिकुड़ जाएंगी, जगह ही नहीं है. जब जगह ही नहीं है इंट्रावेस्कुलर कंपार्टमेंट के लिए, तो पोस्टल हाइपोटेंशन हो जाएगी. Initially, the blood pressure is spiking, but now the blood vessels are constricting, so much of constriction that there is no intravascular space available. If the intravascular compartment of yours will shrink, mentally put it on yourself, आपकी सारी blood vessel constrict कर गई, तो अगर आपकी circulating fluid volume ही नहीं है, so postural hypotension will occur in a patient. So therefore, in this particular case, you will notice this is the only medical disorder where like he will not write words like early phase, late phase. वो तो मुझे आपके लिए easy बताना था. What I want to say is that if in any MCQ you read the word hyper and hypotension in the same patient at different presentations, I mean like, but given in the same question with no description given like early versus late, then it means that he's talking about pheochromocytoma. And a lot of these patients would be having impaired glucose tolerance. Yes, because catecholamines increase the blood sugar levels because they counter-regulatory hormones. So he will deliberately begin by saying that person is having weight loss and the person is having impaired glucose tolerance. This can be the starting line of the question, guys. I mean, deliberately in a MCQ pheochromocytoma, don't be under impression that always he is gonna give you like on a gift platter. He will say patient came to hospital with complaints of weight loss and his IGT is like fasting sugar is 100 to 125 and 2R value is 140 to 199, and then he will start talking about the remaining things. That is like palpitations, headache, episodic hypertension, and the aspects that I've said. Now comes the screening test for this patient. What to take what medicines to take for a good night's sleep before the exam. I think you can just do planks. They'll cause pain in the shoulder, and the pain in the muscles always make you sleep relatively better. The best way to introduce pain in muscles is not to do workout heavy, just do simple plank, 30 seconds, 1 minute only. and do it like every 2 hourly. You will get pain in your shoulders and arms, and that will help you sleep relatively better. Yes, the screening test in this particular condition. The screening test in this condition has already been introduced before you. That is a 24-hour urinary fractionated मेटानेफ्रिन levels. Believe me guys, आपको एग्जाम से पहले नींद नहीं आ रही ना, तो आप प्लान कर लो, आपको नींद आ जाएगी. और मैं कुछ भी ऐसा नहीं बता रहा जो मैंने खुद ट्राई आउट नहीं किया हो. I have not told you any other thing that I have not tried on myself. I have done night outs. Night out means I've studied the whole night, and next day I went to college and attended the class the whole day. I did not crib. And I'm giving it as a challenge to you. I always give it as a challenge to all my students on the first day. But for you guys, I'm giving it on the fourth day of my class. Attend this class. Whole night study. Do MCQs, study, don't sleep, and come tomorrow and attend the class, and don't complain कि समझ नहीं आ रहा है, हेडेक हो रहा है. समझ नहीं आ रहा, ये अपने माइंड का दीवार खोलना होता है. हेडेक हो रहा है, पेन किलर खा लो, चाय करो. Might sound a little heartless, I might sound a little like कि क्या सर यू पुटिंग स्ट्रेस, ये तो टॉक्सिसिटी होती है. तो ये टॉक्सिसिटी नहीं होती. आप जिंदगी में एक दो बार अगर इसको ऐसा कर लोगे, मैं रोज थोड़ी ना करने के लिए कह रहा हूँ. If you say the doctor, I'm afraid of the exam, how do you remove that fear? I'm telling you that. I was morbidly afraid of my exams. I could not sleep. I could not do anything. I used to be चिड़चिड़ा समझते हो, irritable, right? So I used to be snapping back, and then one day I realized, yeah, I'm talking rude to my mom. I'm like, I'm just being aloof from my friends, and I'm always having that headache frontal यहाँ पे. नींद आती रहती थी मुझे. यार ये सही है यार, मतलब जिंदगी बिल्कुल बर्बाद सी हो गई है यार. मेडिकल कॉलेज में आ गया एंड आई लिटरली रूड माई लाइफ. सो आई एम टेलिंग यू गाइज व्हाट आई डिड फॉर माई सेल्फ. आई इंट्रोस्पेक्टेड. मैंने कहा यार क्या करूँ, आई वॉज वेरी फ्रस्ट्रेटेड. And like left, right, center, I was at MAMC, Malansa Medical College, New Delhi. So I had a lot of guys who were like very intelligent, DPS, RK Pura, Modern School, Barakhamba, all those elite schools of Delhi. I was from a Hindi medium school and I was struggling. एक तो English नहीं आती, the fancy words समझ नहीं आते ना, fractionated क्या होता है, तो you learn the language subsequently. And at the top of it, you are always feeling headache, you're always feeling sleepy. Then something must be done. And what is that thing? Two things. Blank नहीं, night outs. When you do that once in your life, तो डर निकल जाता है, डर निकल जाता है. हाँ, वो वंस इन अ वाइल कहने के लिए कह रहा हूँ ना, वंस इन अ वाइल एक ही बार होता है. एड्रेनलिन पे ऑपरेट करोगे ना, फिर तो रोज नहीं करना है, रोज नहीं करना है. रोज तो आई वांट यू टू स्लीप 8 hours per day. 8 hours of class, 8 hours of sleep, and 8 hours of paraphernalia. 24 hours are over. 8 hours of concentration, right? 16 hours of study. That means 8 hours of effective output, and then 8 hours of sleep is sufficient for you guys. 24-hour urinary fractionated metanephrine levels. Obviously, like I can say, one shoe does not fit all. So if it doesn't work for you, I'm saying don't use it, man. If it doesn't work for you, don't use it. If you say that I'm those adventure prone kinds, and like I try to take chances with myself, then yeah, I mean, what's the harm in doing it once in or twice in your career? Just you just have to sit at home and do these activities. Okay, चलो जी. 24-hour. प्रणव, तूने वेब सीरीज देखी और फिर तू रैंक मार लेगा तो बच्चा जो है ना, वो बोलेगा मिसगाइड कर रहा था. ठीक है, तो ठीक है. एंड एक और बात बोलूंगा, डोंट एक्सटर्नलाइज ऑल द अचीवमेंट्स दैट यू डूइंग. You might be doing bodybuilding, you might be watching web series, you might be doing coding, a lot of you might be learning AI. I mean, whatever extracurricular activities you are doing, or if you are not doing anything, both the things, positives and negatives, don't externalize कि यार मैं कुछ हो ही नहीं रहा. A lot of you might be कि सर कुछ होता ही नहीं, नींद ही आती रहती है ना. There are a lot of you might be saying कि सर मैं तो क्लॉड पे, like I picked up a program and क्लॉड पे 1 घंटा मैं रोज लगाता हूँ, right? Depends on perspective. When you externalize your negativity or positivity, then the energy goes out, right? So you have to keep it to yourself and then understand that, okay, I need to work on myself. Mostly the things are gonna be, you will not feel like doing anything, right? That's the best way, na? No action, no reaction, no studies, no fear. But over a period of time, it builds up, right? So it's always a good idea to put as much efforts as chalo ji, focus. Now the investigation of choice for this patient would be, as I've explained to you already, I could have told you कि भाई मैंने लिखा हुआ है, तुम कमेंट करो. I'm writing it so that you are developing it as a second nature, कि आपको सोते से भी जगा के पूछा जाए कि भाई बता फेओक्रोमोसाइटोमा का इन्वेस्टिगेशन चॉइस क्या होता है. It is plasma free metanephrine levels, which is the investigation choice for these patients. These words are to be remembered in the question. And आप जब क्वेश्चंस करोगे किसी भी ऐप से, तो उन्होंने ट्विस्ट यही मारा हुआ है ना. जैसे मेरे को जैसे कल मैं एक स्टूडेंट ने मुझे एक स्नैपशॉट भेजा, तो वो मैरो की ऐप का था. उसका आंसर इन्वेस्टिगेशन चॉइस था 24 आवर यूरिनरी फ्रैक्शनेटेड मेटानेफ्रिन लेवल। उसने बोला सर आपने बोला था इन्वेस्टिगेशन चॉइस प्लाज्मा है, क्योंकि एमसीक्यू में प्लाज्मा में उसने लिख दिया था फ्रैक्शनेटेड मेटानेफ्रिन लेवल। देन इफ फ्रैक्शनेटेड नहीं करना ना, फ्री मेटानेफ्रिन लेवल चेक करने हैं। So you have to pick up those words in the question. They deliberately will remove the word free, and then the answer does not become like a plasma. Then the answer becomes a urine test in a patient. That's like the only trick that they have up their sleeve. And now we have to go for management. So the management is obviously surgery. Treatment for benign pheochromocytoma is surgery, but we have to go for a preoperative stabilization. For preoperative stabilization, we will be using a non-selective alpha blocker. The non-selective alpha blocker that we have to use in this patient is phenoxybenzamine. The non-selective alpha blocker that we will be using for this patient is phenoxybenzamine. This will control the high blood pressure of the patient. And after controlling the blood pressure, the second thing what you will be doing in this patient is propranolol. The second thing that you will be doing in the question is propranolol. फर्स्ट यू विल बी गिविंग फेनॉक्सीमेंजाबिन। इसको बोलेंगे कि जब सुबह उठना है तो 7 AM पे 8 AM पे जब भी कभी सुबह उठते हो तो पहले आप फेनॉक्सीमेंजाबिन खा लेना, बिकॉज यू आर हैविंग हाई बीपी, इट्स अ नॉन सिलेक्टिव अल्फा ब्लॉकर, एंड देन propranolol will be given to the patient post breakfast so that we are able to like control your palpitations and tremors also. Now by mistake the patient did opposite. He first took propranolol. You had recommended for me, you had recommended for the patient alpha plus beta. What the patient did was he did beta plus alpha. Let me explain this to you, though I don't think so. You need to note whatever I've drawn in the horizontal line. In the horizontal line, मैंने बोला the guy is already having high BP. Already having high BP. Alpha in the body causes vasoconstriction and beta in the body causes vasodilation. अगर वो beta पहले खा लेगा तो he will block अपनी खुद की vasodilation. If you block खुद की vasodilation, alpha activity in the body will be unopposed. If beta blocker is the first thing taken at 7 AM, because आपने ठीक से बताया नहीं था, the person's alpha activity will be unopposed, and this unopposed alpha activity will cause a spike in the blood pressure of the patient, and the spike in the blood pressure can cause a brain hemorrhage also. So I hope I've been able to explain to you कि इसका इलाज क्या करेंगे. The answer is alpha plus beta, and what is not recommended is beta plus alpha. Beta plus alpha will cause unopposed alpha constriction and will cause a possible CNS bleed, heart hypertension in a patient. But alpha plus beta is what is recommended for preoperative pheochromocytoma, and then we will plan surgery for this patient. The surgery in this patient will be a laparoscopic unilateral adrenalectomy. I mean, the surgeon will have to go in for a minimally invasive surgery to remove the tumor, but then like preoperative stabilization is important. Preoperative stabilization is very much important. Do not answer surgery for malignant pheochromocytoma. Please answer the treatment of malignant pheochromocytoma. Meanwhile, write the data. Surgery is contraindicated in a case of malignant pheochromocytoma. Surgery is contraindicated in malignant pheochromocytoma. What is the treatment of choice for a patient of malignant pheochromocytoma? Can I have answers, please? Quick answers. What is the treatment for malignant pheochromocytoma? Because it has spread. So what we will do, we will use radiation, and for radiation, if it is a malignant pheochromocytoma, then we will not perform surgery because it has already spread in the patient. So what we will do in this patient is that we will be using MIBG for the patient. Your answer will be, I will use radioactive iodine. And what is the radioactive iodine that we'll be using for this patient? It is iodine 125. The delivery method will be MIBG, that is full form is methyl idobenzyl guanidine scan. With the help of this methyl ido, because the cells of the tumor will accumulate radioactive iodine, they'll get destroyed. So methyl idobenzyl guanidine scan. Methyl idobenzyl guanidine scan is the best way for managing these patients where the radioactive iodine will be uptaken and the tumor will subsequently be treated. So the main point is MIBG, methyl idobenzyl guanidine scan, and radioactive iodine will be used, and obviously chemotherapy will also be used for this patient. So if he says, how do you manage a malignant pheochromocytoma? Answer is iodine 125 plus chemo. Now the question arises, हम कैसे differentiate करेंगे कि क्या इसको benign pheochromocytoma है या इसको malignant pheochromocytoma? How will we differentiate whether it is a benign versus a malignant pheochromocytoma? How will we know where is the tumor located? Is it in the medulla or is it outside the medulla at an extraadrenal location? Because sometimes the tumor is deep in the medulla, as I explained to you. but sometimes the tumor can be in the sympathetic chain also. Sympathetic chain would be that organozucker candle. तो हमें कैसे पता चलेगा कि ट्यूमर कहाँ पर प्रेजेंट है? तो हमें ये आंसर चाहिए कि भाई हाउ डू यू नो benign versus malignant? How do you know the location of the pheochromocytoma? Because the surgeon needs to know na, only then the surgery in the patient will be done or will not be done. So the test that you will be doing in this patient is the most important statement of the entire topic of pheochromocytoma that I speak now. If he says, how do you identify where is the tumor located? Then in earlier versions of the app, it was a MRI, but now he does not recommend an MRI. It is the gadolinium 68 dotatate PET CT scan. I would rate this as the most important MCQ of entire topic of pheochromocytoma. You can skip the whole topic of pheochromocytoma, but this should never go wrong. Gadolinium 68 dotatate PET CT scan. Gadolinium 68 dotatate PET CT scan is the best way for identifying where is the tumor located, what is the size of the tumor, what is the location of the tumor. It is the gadolinium. Yes, you're right. Gadolinium 68 dotatate PET CT scan is the imaging modality of choice for this condition. Yes, if this is not in the options and you answer MRI to chalega, but I hope all of you will agree to the fact that MRI is not able to pick up a tumor which is less than 1.5 centimeter in size. So in surgery classes, they mainly focus on the MRI abdomen component, but I am trying to tell you that the main test for this patient is a gadolinium 68 dotatate PET CT scan. That's like the core aspect. At this moment, one of the most famous MCQs of your exam would be, how do you localize a pancreatic neuroendocrine tumor? चाहे वो इंसुलिनोमा पूछे, चाहे वो ग्लूकेगोनोमा पूछे, सोमैटोस्टैटिनोमा पूछे, कोई सा भी पैंक्रियाटिक न्यूरोएंडोक्राइन ट्यूमर पूछा हो, कोई सा भी, हाँ वो तो गैलियम स्कैन अलग होता है, गैलियम 67 होता है वो, है ना, गैलियम 67 स्कैन इज फॉर सार्किडोसिस. अभी हम गैडोलिनियम 68 की बात करें. For all pancreatic neuroendocrine tumors and for pheochromocytoma. I am emphasizing once again, the most important detail for this particular topic is coming right now in front of you. Pancreatic neuroendocrine tumors or pheochromocytoma के लिए he will say what is the imaging modality of choice. Whether he says insulinoma, glucagonoma, somatostatinoma, vipoma, कोई सा भी ओमा दे दे pancreatic neuroendocrine tumor or pheochromocytoma, the answer will be what I have just explained to you. Gallium 68. Yeah, this is not gadolinium, and जल्दी gallium लिखा था. This is gallium 68. ठीक कर लेना guys, gallium 68, not gallium 67. No, 67 नहीं है, gallium. It is gallium 68. So I'm writing Ga68. Dotatate PET CT scan. This is like one of the most famous MCQs. I don't know why, like, the examiner has found a fancy for this, but yeah, this is important information to be remembered. And then एक और जो question था, this is for all FMG students. I would address it to all FMG students here. The question said कि पेशेंट है जिसको डिस्टेंट मेटास्टेसिस के लिए डॉक्टर साहब ने 18F FDG स्कैन किया. इट इज रिटन एज 18F FDG, F 2 बार आता है. 18F FDG scan is being done for evaluation of distant mets. So the question was like, what is this F standing for? It was more of a radiology question only. The question said, what is this F standing for? And do you want me to give options? Okay, it would be like fluoride and then fluoro. Can I have quick hits in the comment from FMG students listening to me at the moment? The traditional NEET PG wala and INISET I've already highlighted that PNET aapko to, and he will ask you somatostatinoma, VIPoma, fancy से नाम लिखेगा. Your answer is gallium 68 dotatate PET CT scan. What is the technical term there? Yes, all FMG students, can you quickly hit the comment button? Is it fluoride? Is it fluoro? Okay. I think most of guys have answered this wrongly. It is not fluoro. It is fluoride. जो फ्लोरो होता है वो इसके लिए होता है. जो दूसरे वाला एफ होता है. तो ये सिली मिस्टेक नहीं करनी है. कई बार एग्जाम में ना बड़ी बेसिक सी चीज़ें पूछता है. इट इज़ फ्लोरोडिऑक्सीग्लूकोज. इट इज़ जो दूसरे वाला होता है ना, दैट इज फ्लोरोडिऑक्सीग्लूकोज. वो ठीक है, मैं समझ गया कि फ्लोरोडिऑक्सीग्लूकोज आप पकड़ रहे हो बिकॉज द कैंसर सेल्स यूज एरोबिक मेटाबॉलिज्म. दैट इज वार्बर्ग इफेक्ट ऑफ फ्लोरोडिऑक्सीग्लूकोज. द आंसर इज नॉट फ्लोरो गाइस. It is fluoride. It is 18 fluoride fluorodeoxyglucose. The answer in the MCQ was this. ये जितने भी forums हैं सब पे ऐसे ही कुछ भी आंसर बोल देते हैं. एंड जैसे कि जी ये तो लास्ट टाइम का FMG का है, एंड देन 2-3 ऐसे कॉमन इजी से क्वेश्चन देखे ना, फिर वो बोलता है कमेंट बिलो, है ना, फॉर PDF. और नीचे देखो 1000 कमेंट होते हैं, पीडीएफ 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 पीडीएफ। ऑल दैट इज लाइक इंस्टाग्राम पे वो अपनी रीच बनाने की कोशिश कर रहे हैं एंड कमिंग अप विद ऑल काइंड ऑफ नॉनसेंस, राइट? Two three easy questions, one would be like very easy, one is going to be moderate, one is going to be slightly hard, and like FMG this or NEET PG this and comment PDF for the whole document। वो YouTube से बनाए यार, उससे तो YouTube के जो वीडियो हमारे वाले वही सुन लो, एटलीस्ट यू गेट अ मोर ऑथेंटिक इन्फॉर्मेशन देयर। उसमें बोलेगा गेट बिलो PDF, और 1000 पीडीएफ चल रहा है नीचे, एज इफ something great will come। तो like it's not like, see, if somebody wants to grow up a page, तो मैं कह रहा हूँ आप जेन्युइन स्टफ डालो ना यार। मतलब वो यूट्यूब से उठा के इधर उधर से डाल के, चैट जीपीटी से उठा के, उसको कोई मतलब नहीं बनता ना। टेक्स्ट बुक डेटा डालो तो इट मेक्स सेंस, लॉजिकल कंटेंट्स टू बी मेड, राइट? I mean, obviously, like it's a free world out there, so you can't comment. But what I am trying to tell you is, you as medical students and doctors have to be wise now. You know what is useful for you and what is not useful for you. So I mean, you have to pick up the stuff wisely. Okay जी। हाँ, पैसा भी मांगते हैं, मुझे पता है, ये भी हुआ है, पैसा मांग रहे हैं। ओके चलो, मूविंग अहेड इन द डिस्कशन। हाँ एग्जैक्टली। चलो चलो चलो, let's focus 18 fluoride fluorodeoxyglucose is what is to be remembered, and for like in ESET etc, he said somatostatinoma and fancy terminologies डाल दिया, and then the answer is gallium 68 dotated PET CT scan that should be used। Now is a question that I'm addressing to all NEET PG aspirants। Every NEET PG aspirant please assemble and answer my question। Give me after 15 seconds। जब किसी फियोक्रोमोसाइटोमा वाले पेशेंट की सर्जरी होती है, तो उसको इंट्राऑपरेटिव ड्यू टू ट्यूमर मैनिपुलेशन देयर वुड बी अ स्पाइक इन ब्लड प्रेशर, देयर वुड बी लाइक हाइपरटेंसिव क्राइसिस दैट कैन हैपन। सो फॉर फियोक्रोमोसाइटोमा वी हैव टू बी लाइक वेरी प्रोएक्टिव, और हमें इंट्राऑपरेटिव और प्री ऑपरेटिव हाइपरटेंशन दोनों को ही मैनेज करना है। सो व्हाट आई वांट यू टू आंसर हियर इज, एंड आई वुड लाइक फर्स्ट ऑल नीट पीजी एस्पिरेंट्स टू आंसर दिस, which drug can work in both? Which drug can work in both pre-operative as well as intraoperative hypertension? Guys, you are being too early in answers. You have not listened to my question. This is last year NEET PG 2025 question. The question said, which drug will work? Which drug works in both? Which drug works in both intra and pre-operative hypertension, that before surgery also and after surgery also we will be giving a drug in the patient? No guys, the answer is not phentolamine. It is not phentolamine. For pre-operative hypertension as well as, yes, intraoperative hypertension, very good Avnish, he was the first one to comment here. I've discussed this in the recall session. I've discussed it in the latest rapid revision also. It is nicardipine, that is the first answer, or the second one is labetalol. This was I don't know like why they love to ask such troublesome questions, but they asked it here। इंट्राऑपरेट, बेटा अशोक आपका जो आंसर है वो इंट्राऑपरेटिव हाइपरटेंशन अलोन के लिए सही है। लाइक सपोज आई आस्क्ड टू यू दैट इट्स अ फियोक्रोमोसाइटोमा पेशेंट। Suppose I asked to you, it's a pheochromocytoma patient, and intraoperative hypertension is occurring in this patient due to tumor manipulation, because when the surgeon will have to operate on the patient, he will have to dissect the tissue. He will have to like surgically dissect the tumor and then like remove it. So when the pressure will be then on the tumor by the hands of the surgeon and the retractors that are used, that is what is going to cause a spike of blood pressure, and that spike of blood pressure can cause a brain hemorrhage. So your answer of intraoperative hypertension due to tumor manipulation is perfectly correct if alone this was given, and then the answer would be given as sodium nitroprusside, which is given via light protected infusion set, as I've explained to you, because otherwise you could be having a risk of cyanide toxicity। This is the NEET PG question. If you're an FMG aspirant, you can skip this बीच वाला question। बाकी सारा डेटा ओके है आपके लिए, बट देन ये वाला एक पॉइंट आप छोड़ सकते हो, which like came थोड़ा सा tricky। देखो, I'll say like this, both exams have the same set of questions। It is one is having negative marking, second is not having a negative marking। It is like, it's not that it is too much of detail or very under detail। Examiner randomly कोई भी fact उठा लेता है, or the software like they have taken the questions from all these consultants in various hospitals, and now the computer will randomly pick up questions anywhere, and they have segregated it, 10% have to be non-solvable, 20% have to be like where it's like looks like very controversial, and the remainder ones are gonna be straightforward ones। So people tend to chase those ones where like the rare ones, like the one that I have come here, and then like nicardipine, labetalol, those are like drugs which are evergreen drugs. They'll always be working in all the scenarios. So it is simply that if you are gonna put your heads down, do daily working, and keep on learning facts, because lot of people think that यार ये 4 पॉइंट बस बहुत होते हैं. No, you have to keep on upgrading your knowledge base. जैसे फ्लोराइड वाला गलत किया कई लोगों ने, तो ऐसा नहीं है कि आपको आता नहीं था, जल्दबाजी में किया. और कई चीजें ऐसी होती हैं जो मतलब आपको, एक तो होता है कि भाई ये वाला था ना, ध्यान से नहीं पढ़ा था, दिस इज बिकॉज ध्यान से नहीं पढ़ा था. And then there would be couple of aspects which I might have said, like when I started talking about malignant, so answers were coming as like surgery and all those things, but the surgery would not be done, na? Like we'll not go for any laparoscopic procedures if the surgery, if there is gonna be a distant metastasis present in a patient. So what I've done at the moment is, yes, Saurav, you have a very valid point. You can see that I've dedicated almost 2 pages to summarize the entire pheochromocytoma topic in front of you, and you are supposed to have like complete photographic memory of this entire information. Pheochromocytoma is a non-negotiable. बीपी कॉन्ट्रैक्शन ड्रग, बेटा मैं समझा नहीं, कॉन्ट्रैक्टर ड्रग मतलब, बीपी कॉन्ट्रैक्टर ड्रग का मतलब नहीं समझा बेटा मैं. क्या आप थोड़ा सा इंग्लिश वाले वर्ड्स लिख दो, मैं आई कुड नॉट follow you up. So I'll wait for your comment, beta. And meanwhile, like I'll say, this was a totally like a topic which is non-negotiable and all facts have to be remembered. Okay, Ji. So now we come to Cushing syndrome, much more easier topic and straightforward topic, and the most reliable BP control drug. बीपी कंट्रोल ड्रग फॉर दिस पेशेंट सोडियम नाइट्रोबोसाइड ही तो है ना बेटा. इंट्राऑपरेटिव के लिए सोडियम नाइट्रोबोसाइड है, और प्री ऑप के लिए जो है वो फिनॉक्सीबेंजामिन यूज कर रहे थे. ये तो बीपी कंट्रोल वाले ड्रग्स ही तो है ये. Okay. Coming to Cushing syndrome, we will now focus on like what are the parameters which will help in diagnosis, and one of the key features that will help in diagnosis are these broad striae. You can see on the slide that the patient is having purple color striae or like violet colored striae. So broad means more than 1 centimeter. Purple striae is the most reliable examination finding of this patient. Just like in Graves' disease, I was saying that eye finding is very reliable for diagnosis. Graves' disease will have a thyroid enlargement, but you will also be having like thyroid eye disease present, that is Graves' ophthalmopathy. In the same spirit, in this particular hypertension, बेटा बता दिया ना आपको, hypertension ही तो बता रहा था इसके मैनेजमेंट के लिए. Broad purple striae is the most reliable examination finding of this patient. Along with this, what you will notice is also that there would be a presence of lot of fat behind the neck area of the patient. This is what is called as a buffalo hump or like dorsocervical fat pad. So what I would like to put up as a question to you guys is कि ऐसा क्यों होता है कि Cushing syndrome में fat gets deposited in the central part of the body. आर्म्स की वेस्टिंग हो जाती है एंड मसल्स की वेस्टिंग हो जाती है, और फैट जो होता है वो सेंट्रल पार्ट ऑफ द बॉडी में हो जाता है. व्हाई इज इट लाइक दैट? लाइक व्हाई डू यू गेट लाइक दिस सेंट्रिपेटल ओबेसिटी इन अ पेशेंट या हाइपरकॉर्टिसोलिज्म? Cortisol acts primarily on adipocytes. It causes proliferation of adipocytes, and fat हमारी बॉडी में सेंट्रल पार्ट में प्रेजेंट होता है टू कीप द बॉडी वार्म. Fat, God has given us fat in central parts of the body to keep the vital organs warm, or like the important parts of the body, the central part of the body warm. So adipocytes जो होते हैं, they're reactive to cortisol. Cortisol, when the level will spike, the adipocytes around in the fat area will start proliferating, and you start getting a development of, यार भाई essential hypertension अभी मत टच करो ना. अभी we'll talk about hypertension as the days will progress ना. अभी CKD में भी आएगा hypertension, so we'll talk about it, right? We'll talk about ABCD there. Dorsocervical fat pad. Dorsocervical fat pad is the examination finding that is present here. The logic is adipocytes proliferate in response to hypercortisolism. Fat is present normally also in the central distribution. Now it will proliferate. That's why these features will come. And along with this, in these patients, there would also be a development of moon faces. There would be facial plethora, there would be moon faces that are present. And why these patients will come to you? So most of the common reasons why they come to you is like the person will say that I'm putting very significant amount of weight gain. The question will begin by saying a female, she's coming to the doctor with complaints of weight gain, and when you will physically examine the patient, you will notice that there would be lemon on sticks appearance present in these patients. Lemon is because the patient's central part of the body will go round. लाइक फेस भी हैवी हो गया, टमी भी हैवी हो गया, और बाजू और लेग्स जो हैं बिल्कुल पतले पतले हो जाएंगे. सो लेमन एंड स्टिक्स अपीयरेंस बेसिकली मीन्स लाइक ऑन द टमी देयर इज लाइक लॉट ऑफ स्ट्राई एंड स्ट्रेच मार्क्स दैट आर present, and the legs will become very thin and spindly. That would be muscle wasting is the one that would be present in this patient. It is the muscle wasting that will be present in the patient. Okay, beta, I'll address it. Beta, I'll address it. Move on. Focus. Dorsal cervical fat pad will be there. There would be purple striae that are present, as I said, and then they would be very thin skin with increased bruising. थोड़ा सा भी चोट लग जाएगा, जैसे अगर आपको मुझको इंजरी हो जाए तो कई बार वो ब्रूज बन जाता है ना, तो इसको थोड़ा सा भी इंजरी हो जाए, थोड़ा सा भी इंजरी हो जाए, तो देयर वुड बी अ डेवलपमेंट ऑफ ब्रूजिंग दैट वुड बी प्रेजेंट. सो इंक्रीज फ्रेजिलिटी ऑफ ब्लड वेसल्स, increased fragility of blood vessels. Again, the collagen component gets affected by high cortisol and steroids, so increased fragility of blood vessels would be present. And now comes one of the core issues in this particular patient, hypokalemic alkalosis. क्यों इसको hypokalemic alkalosis होता है? Why do you get hypokalemic alkalosis? Okay, I got a very interesting comment, buffalo hump. आजकल ना, we cannot write the word buffalo hump on the case file. No patient will file a court case saying that you abused me in the case file. You called me an animal? You call me buffalo? Patients nowadays have like patient बोलता है भाई मेरे rights. So dorsocervical fat pad is like what is not used anymore. Buffalo hump is not used anymore. We cannot use those words in the case file anymore. So now coming back to the agenda, guys, cortisol. आज पेशेंट्स बड़े वोकल हो गए भाई, आजकल सोशल मीडिया पे डॉक्टर के धज्जियां उड़ा देते हैं हम लोगों की, है ना. तो मतलब cortisol is elevated. Cortisol will act on the epithelial sodium channel, and the action on the epithelial sodium channel will cause urinary loss of potassium and hydrogen. So cortisol is a hormone which can act on epithelial sodium channel. I hope you're realizing that the main stimulator of epithelial sodium channel is aldosterone, but in this condition it is aldosterone. It is aldosterone, which is, it is not aldosterone, it is cortisol that is acting on the epithelial sodium channel. पड़ोसी के रिसेप्टर को भी एक्टिवेट कर रहा है, अपने रिसेप्टर को तो कर ही रहा है, अपने रिसेप्टर के साथ तो प्रॉब्लम क्रिएट कर ही रहा है, पड़ोसी दैट इज लाइक aldosterone receptor is being activated, and then there would be increased stimulation of sex steroid receptors. So another manifestation that will come up is hirsutism and oligomenorrhea. This female will be having hair in mustache area. She will undergo like cosmetic treatment. वो गई किसी डर्मा के पास में, डरमैट ने बोला 1 लाख रुपया लगेगा, मैं आपकी लेजर ट्रीटमेंट करूंगा मैडम, तो वो ठीक हो जाएंगे बाल, एंड देन इट विल गो कम बैक. Like this patient is literally in tears. She says the dermat took 1 lakh from me, 2 lakh from me, and like my hair came back because there's a hormonal reason. Because there is a hormonal reason that is present, and then because of the hormonal reason which is present, then hirsutism and oligomenorrhea would be coming. Now in this particular patients, now in all of these patients, ACTH levels will begin to spike. And when ACTH levels will begin to spike, then hyperpigmentation of the knuckles, etc. would be coming in these patients. Guys, take it easy, take it easy. I'll focus at the subject. जहाँ पे होगी merit के basis पे answer कर दूंगा. Coming back to the agenda, focus at the job at hand. Cushing syndrome में कुछ conditions में ACTH बढ़ जाता है. The best example I can give you for increase of ACTH is lung cancer. The best example of increase of ACTH is lung cancer. Especially when ACTH will increase because of lung cancer, ACTH has a partial MSH-like action. And because ACTH is having a partial melanocyte stimulating hormone-like action, it will cause hyperpigmentation of the knuckles and interphalangeal joints. This is one of the important examination findings that must not be neglected for the topic of Cushing syndrome, that if he's saying hyperpigmentation knuckles and IP joints, the examiner is indirectly trying to tell you a ectopic source of ACTH production. The examiner by point number 8 is trying to tell you a ectopic source of ACTH production, that is because ACTH behaves like partial, yes, oat cell cancer, it's a partial melanocyte stimulating hormone-like action is present. In the light of this data, the clinical features are very simple. Everybody will be able to understand lemon on stakes, dorsal cervical fat pad. Nobody has a problem in identifying Cushingoid appearance. So please let me know in the chat box which pseudo Cushing appearance is caused by. Pseudo Cushing appearance is caused by. Quick answers, please. Pseudo Cushing appearance is caused by. Pseudo Cushing appearance is caused by. alcohol intake. Pseudo Cushing in appearance is caused by you check out alcoholics, know they drink every day, face will become heavy, empty calories, face will become heavy, neck area, there would be a lot of fat, gynecomastia kind of appearance, belly fat, beer belly would be coming up in a patient. Pseudo Cushing appearance is alcohol intake. Like if you check out alcoholics, now the face is all flushed and red because alcohol causes vasodilation. They tend to have that increased neck circumference. They have a lot of fat in the chest. In male patient, it will cause a gynecomastia kind of an appearance. That's again a MCQ for exam. Pseudo Cushing appearance is caused by, answer is alcohol intake. If I change the question, what is the most common cause of Cushing syndrome? That would be obviously this kind of description given, and then after wasting your time, he will say what is the cause. Your answer will be steroids. The causes can be remembered by a mnemonic by the name of SOAP. So let us now practice the mnemonic by the name of SOAP, by which we can remember how Cushing syndrome manifestations will occur. The first one is steroids. That is iatrogenic. I'll write those terms also. Then is O, port cell cancer of the lung, as somebody had commented earlier, that is ectopic production, lung cancer. The next cause can be a tumor in the second layer of the adrenal gland. This is what I started the class with today. That would be an adrenal adenoma, tumor in the second layer of the gland. The fourth cause for this would be pituitary adenoma. SOAP is a mnemonic जिससे आप Cushing syndrome के manifestations याद कर सकते हो. That is steroids, port cell cancer, adrenal adenoma and a pituitary adenoma. The total of 4 causes of Cushing syndrome, and now comes the technical aspects for each one of them one by one. For steroids, obviously it is like doctors have written steroids to a lady with lupus. So when you give steroids to somebody with lupus daily, prednisolone, Dexona, whatever, it is going to cause a spike of cortisol in the body, and because of the spike of cortisol, there would be suppression of ACTH. So he will give this combination, and he will say that which of the following etiology is appropriate to describe this hormonal profile. If cortisol is more and ACTH is more, then it's going to be a profile of iatrogenic steroids. But when you look at port cell cancer will be causing a ectopic ACTH production. I'm writing ectopic in bracket because he will not write the word ectopic, he will just give you hormonal profile. ACTH will also be more, cortisol will also be more if both arrows are going in same direction. If both arrows are going in same direction, that means it is probably an ectopic cause, and in those circumstances, lung cancer evaluation needs to be done in a patient. If arrows are going opposite, then it is going to be a manifestation of iatrogenic steroids, and if it is going to be going in same direction, then it is oat cell cancer. Now comes the aspect of adrenal adenoma. Adrenal adenoma, the technical word to be noted is autonomous source. Autonomous because this is an autonomous tumor. It is present in the second layer of the gland. As I started the class with, this is a tumor in the second layer, and this will be having is excess production of again cortisol. So the hormone report will come like this. You will notice that the hormone report will be identical to the first report. The tumor will be causing excess of cortisol, but at the same time the ACTH values in the patient will become suppressed. This adrenal adenoma is an autonomous source. It is also called as ACTH independent. इसको independent क्यों बोलते हैं? Because ACTH is less, still cortisol is coming, and ACTH is more, so cortisol is produced. Here ACTH is less, and still cortisol is coming due to autonomous tumor. That is why when I started the class today, I said ACTH independent Cushing syndrome is caused by, your answer would be given as adrenal adenoma. Point number A is one of the most neglected and the frequently asked aspect. Adrenal adenoma, A, autonomous. The hormone profile will be same as that of somebody taking steroids, but you can differentiate by asking the history, and even if history is not clear, do a CT scan, man. CT scan will reveal a tumor. In person taking steroids, obviously CT scan will be normal. Suppose they give you a hormone profile, how will I differentiate CT scan? That is what I started the class with, that it is ACTH independent Cushing syndrome. And now we talk about pituitary adenoma in a patient. In pituitary adenoma, again, the ACTH report will be elevated. It will be just like the report of oat cell cancer, that ACTH will also be more and cortisol will also be more. And therefore, how do we differentiate between the two is of paramount importance. That is a test that we'll discuss subsequently, that is called as high dose dexamethasone suppression test. That is, a test that we'll be doing in this particular condition is called as high dose Dexona. But before I talk about this test, I want to highlight the word endogenous. Endogenous means that it is belonging to the body. Pituitary belongs to the body, and oat cell cancer is like foreign because it's not a normal part of the body. Though, like I think I've clarified, let me know when you do a high dose Dexona that we'll be discussing. I'll write down the interpretation also and has been asked in the exam. Can you tell me which of the two will show no suppression to high dose dexamethasone test? Which of the following will be showing no suppression to the high dose dexamethasone? Waiting for your answers, guys. No suppression. Lung cancer. भाई लंग कैंसर हंस रहा है, तो मुझे डराओगे, हमको धमकाने आए हो, right? He's the real badmash, right? He's the nasty guy. So he says, bro, you come to, like, he's that shooter, like, that they show in Bollywood movies, who says, भाई मुझे डराने आए हो, right? I'm not afraid of death. So oat cell cancer is not gonna be responding to any suppression. Pituitary is a part of body. तो थोड़ा आंखों का शर्म तो होगा ना, when you are a part of, let me say you are a part of a team and you are like, you are like not cooperating with the team, you still say ठीक है यार इनको मारो नहीं, that we will just be supportive. So for pituitary the word is P, partial suppression. P, partial suppression. I'll write down the theory, but because this came up in the chat, so I thought I'll just address that query right now, right here, because sometimes when the questions come in the mind, they should be addressed immediately. I try to answer questions with the merit, on the basis of merit, and I'll try to answer only on the basis of merit from now. Okay, so SOAP is a mnemonic. Steroids, oat cell cancer, adrenal adenoma, and pituitary adenoma. The words are of paramount importance in this particular patient. Now comes, what is the screening test for this condition? So yes, guys, you have to answer here regarding what is the main screening test that you will be doing. Then you will say that the main screening test that I'll be doing in this patient is 24-hour urinary cortisol values. It is a 24-hour urinary cortisol values, which is like the main test that is used for diagnosis of this condition. The usual values of this will be 2x, maybe 3x on normal. Don't answer low dose Dexona. Low dose dexamethasone is given second in the textbook. The first answer is 24-hour urinary cortisol will be 2 times elevated, 3 times elevated. That alone is sufficient. There is no need of low dose Dexona. That can be a supplementary test. Now we go to investigation of choice, which I will rate as one of the most important MCQs here. The current editions of the book say that you should be going to the bedside of the patient at 12 o'clock in the night, midnight. When you will go to the at midnight to the bedside of the patient will be very intrigued. He will say, sir, I mean, doctors come in morning round, you could not even wait. He says, doctor, like you are so hell-bent on taking a round that you came at 12 o'clock in the night. आपसे नींद नहीं आ रहा आपको? So I said, no, bhai, it's not for the round. I have come for taking a sample. So the person extended his arm. कि ले लो sample, खून पीने आ गए, ले लो मेरा खून. So I said, no, today I'm not come to drink your blood. I have come today to take your saliva. And patient is like, are you serious? थूक लेने आए हो, saliva लेने आए हो? Said, yeah, we will check your midnight salivary cortisol. Yes, guys, the updated guidelines are midnight salivary cortisol will be elevated in this particular case. This is because normally cortisol levels are least at 12 o'clock in the night. From the physiology perspective, midnight salivary cortisol best test क्यों होता है? Because cortisol के values रात को 12 बजे सबसे कम हो जाते हैं, लेकिन Cushing syndrome में तो बढ़ जाएंगे. Now comes to endogenous cause versus ectopic source. Endogenous means that it is the problem with the pituitary. Ectopic means that it is a lung cancer, oat cell cancer of the lung, or it can be carcinoid tumor. Especially NEET PG aspirants, please pick up this word very carefully. Carcinoid tumor. He may deliberately not give you a slide of oat cell cancer. He might give you a slide of carcinoid syndrome or carcinoid tumor as a ectopic production. How will you differentiate between the two? I have already said it. I'm going to say it once again. What we will do in the patient is, for both of them, I will be first doing ACTH levels. What I will do in the patient is, मैं उसको बोलूँगा कि आज तेरा blood sample लेंगे, तेरा ACTH check करेंगे. So ACTH will be ultra high, super high in both of them. Ultra high in both of them. Now we will be giving 2 milligram Dexona tablets to these patients on a 8-hourly basis. when I will give 8 hourly Dexona tablets. You don't need to remember the dose, you don't need to remember an 8 hourly thing. The word you need to remember is simply high dose dexamethasone suppression test is being done. You see, I'm giving 2 milligram dexona 8 hourly to the patient. Lung cancer will obviously not get suppressed. Lung cancer is the badmash, he's the shooter. He says, bhai mujhe kaise डराने आ गए? तो ACTH will remain elevated after eating dexona for 2 consecutive days. It is 2 milligram 8 hourly, and we have loaded the patient. Sometimes we use 6 hourly, like 8 milligrams daily. Normally, you eat Dexona, your ACTH will get suppressed. If you and me eat Dexona, our ACTH levels will get suppressed, but lung cancer will not get suppressed. But pituitary being a part of the body, will exhibit a partial suppression. So you can see that this is before eating Dexona tablets. And this is post, that is after eating Dexona tablets. It is before and after Dexona tablets that we are testing. And you can notice that the final output to be remembered by you is simple. If you get a partial suppression of ACTH, ये खुद में ही MCQ में लिखा था that high dose dexamethasone was performed by the physician. There is a partial suppression of ACTH. The word partial suppression P, that means it is a pituitary adenoma, and you will know that this is a Cushing disease. This is what somebody had commented कि सर वो Cushing disease और Cushing syndrome में कैसे differentiate करते हैं. This is the statement for you, man. But Cushing disease is a technical term for pituitary adenoma. This is the word Cushing disease, the term for pituitary adenoma. P for pituitary adenoma, P for partial suppression of ACTH. But if I change the question and say which of the following will be having non-suppression of ACTH, then I think everybody has already answered me this question. Non-suppression of ACTH, lung cancer तो भाई मानने वाला नहीं है. So oat cell cancer and carcinoid will be showing no response to this. This is like one of the ectopic source that I have currently highlighted before you. So the final output to be remembered is like this. If he says the word Cushing disease, please mark the statement. If he says the word Cushing disease in the question, then it is partial suppression. P for pituitary adenoma, P for partial suppression. If he says the word no suppression, then your answer is it is a ectopic source. This is the most important MCQ of this entire topic that I discussed before you. Endogenous versus ectopic source. A large number of questions revolve around only this much point only. The next question is for all NEET PG aspirants. All NEET PG aspirants, please comment in the chat box. Look at this slide. I'm calling it A. Can you tell me the tumor here? It is an ectopic source. It is an ectopic source of Cushing syndrome. The patient came to the hospital with elevated blood sugar, hypertension, hypokalemic alkalosis, hirsutism. All the data given. Look at the slide. I think everybody can pick up the salt and pepper chromatin. आपको दिख रहा है ना, जैसे salt सफेद होता है और pepper black होता है, तो कुछ एरिया पे dark दिखाई दे रहा है. If I zoom in, I think resolution is okay. You can see this area. You can see in this particular area, like the black thing that I can say is the pepper. The black is the pepper. The black is the pepper. The white area is the salt that is present. So the salt and pepper chromatin is what is present here. So they gave a slide like this, that the workup of the patient was done and like what is the evaluation that would be done. What is the cause of the reason for development of Cushing syndrome? Considering that it is a salt and a pepper chromatin which is present, the answer of yours would be given as carcinoid tumor. If you move on to slide number B, you can see ciliated columnar epithelium, that tells you it is lungs. And if you look at the extreme right hand side in this particular patient, you will be noticing in a person for slide number B, the nuclei are crushed. It is crushed nuclei. Because there is limited space and the cells are multiplying very, very fast. So the right slide that I mentioned here before you, where the nuclei are flattened, flattened nuclei are present, this would be oat cell cancer of the lungs. So we just need to identify the cause of Cushing syndrome. Both of them that I mentioned at the moment before you are ectopic causes. Both of them are ectopic sources. When you read the topic of Cushing syndrome, what you are supposed to main focus on is the ectopic causes, because they are like, more frequently asked in the exam. Obviously, like the whole thing has to be studied. They can give you any of the two slides, slide A versus slide B, but both of them indicate ectopic causes which are being highlighted. Carcinoid tumor versus oat cell cancer. Yeah, crushed nuclei, absolutely. Now, I also want to bring to your attention some aspects from this slide also. What do I mean by the word ACTH dependent is that ACTH is high. If ACTH is high, if he uses this phrase, what is the first best investigation? If it is ACTH dependent Cushing syndrome, your answer would be given as MRI pituitary is the main test that would be done in the patient. MRI pituitary. When I started the class today, I started with this statement: independent. Independent means that this is going to be a case of adrenal adenoma. So what investigation will be done? It is a CT abdomen. There are two standard questions that I have covered at the moment from the imaging perspective. From the imaging perspective, not hormone perspective, is ACTH dependent word written, thought process, pituitary adenoma. Independent here, dependency here, dependency here, independency here, dependency in the brain, pituitary adenoma, MRI head, independent in the tummy, that is the adrenal adenoma. That's a difference that I basically, yeah, carcinoid will be in the bronchus. Carcinoid will be in the bronchus. Other tests that can be used for evaluation are like CRS test, and then even high dose Dexona, inferior petrosal sinuses, inferior petrosal sinus sampling. They are like more specific tests that can be done. But like if you get the data that are currently highlighted right, then you are like on your way to understanding the topic of Cushing syndrome. If I go back in the slide, this is a very dense slide, I can say, where I have clubbed the clinical features, 4 boxes only. When you revise this, it's 4 boxes only. It is like the visual interpretation from the perspective of clinical domain. What are the important causes which are responsible, and like what is the common workup aspects which are to be remembered here. This is like 1-page core summary for the topic of Cushing syndrome with few additional bits added in the next slide from the perspective of a hematological slide, from the perspective of a biopsy slide, or like I mentioned the term dependent and independent again. The treatment for this condition is cause specific. The treatment for this condition is cause specific. And if they change the question and don't ask you all of this, if he says, what is the earliest manifestation of Cushing syndrome? He doesn't want to hear any one of this data. Suppose he changes the question and says, what is the earliest manifestation of Cushing syndrome? Your answer will be, it is loss of diurnal variation of cortisol production. What I've done at the moment is I've shown normal cortisol variation. It is below a certain threshold. Cortisol levels in you and me keep on fluctuating all through the day. In person having Cushing syndrome, what will happen is that the values of cortisol will be elevated all through the day, and there is no diurnal variation that is happening. Like in you and me, the cortisol values will become the least at 12 o'clock in the night. In you and me, the cortisol values will become least at 12 o'clock in the night. In these patients, they would be all elevated. So sometimes he will not ask you all this tam jam. He will just say, what is the earliest manifestation of Cushing syndrome? If the word written is earliest manifestation, then don't get into the hassle of all these manifestations. Then it is loss of diurnal variation. If it specifies the word loss of diurnal variation of cortisol production, this is going to be answered by you as the earliest manifestation of Cushing syndrome. This graphical representation that I've given here before you has been again given in the paper. Like he showed that he also mentioned that 12 o'clock in the night, the values of the hormone are getting reduced, and this hormone affects blood sugar also significantly. So considering sugar being controlled, either it will be growth hormone. Growth hormone levels tend to show a different curve, which I would like you to read up from yourself from the physiology domain. But for this hormone, the least levels are seen at 12 o'clock in the night. The levels drop and then begin to rise. Loss or diurnal variation of cortisol production is like the core thing that you need to remember for this particular topic. And then, like I mentioned, the tests for this condition, including tests like CRH, high dose Dexona that I've already explained. CRH test is again used to confirm the diagnosis of. Please hit the comment button. Why do you do a CRH test? Options are differentiating. Okay, I should not have said differentiating. Okay, can somebody comment here quickly? Why do you do a CRH test, please? What is the rationale behind doing a CRH test? क्यों करते हैं इसको? What is the rationale behind CRH test? CRH देने से क्या करेंगे? ACTH बढ़ा देंगे ना, तो ACTH तो नॉर्मल में भी बढ़ता है और पिट्यूटरी एडिनोमा में भी बढ़ता है, पर पिट्यूटरी एडिनोमा में ज्यादा बढ़ेगा ना. Guys, the rationale behind doing CRH test is, listen to me carefully. If pituitary is showing a tumor, is it a guarantee it is a ACTH producing tumor? I taught you the most common tumor of the pituitary is non-functioning adenoma. Most common tumor of the pituitary is non-functioning adenoma. If MRI is showing a pituitary adenoma, that is not a guarantee that it is always going to be ACTH producing adenoma. It can be non-functioning adenoma also. It could be incidentally present in a patient. If I want to prove what is the tumor, what is the hormone produced by the tumor, if I want to prove what is the tumor, what is the hormone produced by the tumor, the test I will be doing in the patient is called as CRH test. CRH test is used to determine the hormone produced by the tumor. मैं फिर से बोलता हूँ, हिंदी में बोल रहा हूँ, एमआरआई पिट्यूटरी से आपको ट्यूमर मिला, वो तो नॉन फंक्शनिंग एडिनोमा भी हो सकता है. कोई ट्यूमर अपने लिखा थोड़ी ना ट्यूमर के ऊपर में कि आई एम अ corticotroph producing corticotroph adenoma, I am gonna produce ACTH. It can be non-functioning adenoma also. So to know which hormone is being produced, the test done is called as CRH test in a patient. So I hope it is clear. CRH test is done to diagnose a pituitary. Technical answer क्या होगा? It is done to demonstrate a pituitary corticotroph adenoma, because when I say corticotroph cells बढ़ रहे हैं, only then in the patient ACTH would be elevated. CRH will cause more release of ACTH higher than what will occur in normal patient. In you and me also, CRH injection will cause a rise of ACTH. लेकिन यहाँ पे the rise will be much higher because it's a tumor. I hope I made a point there, guys. If I give CRH injection to a normal person, ACTH will rise. What will happen to the rise in this patient? More than 40% is the value that is given. Even if you don't remember that 40% chalega, but what I want you to be remembering is the rationale for the CRH test demonstrating a pituitary corticotroph adenoma. Otherwise, तो non-functioning भी हो सकता है. So CRH proves that it's a hormonal source which is present there. Okay, जी. So these are details for tumor, important one. Let's look at now a couple of more easier things. Okay, disorders of calcium metabolism is what I'm going to talk about next. And at this moment, one, you can see carpopedal spasm present. You can see carpopedal spasm present. That is a feature of tetany in a person. This image, I'll use a different contrast, not visible. Okay, now visible. What you can see here is a presence of carpopedal spasm in the patient. This is occurring due to tetany and is called as Trossius sign. This is a feature of hypocalcemia. The second manifestation that is seen here is called as Chvostok sign. For Chvostok sign, you will be tapping on the anterior border of the parotid gland. When you tap on the anterior border of the parotid gland, you are trying to irritate the facial nerve. In a normal person, when you irritate the facial nerve, you will not have any contraction of muscles. But in hypocalcemia, the nerves become irritable. So you want to demonstrate the presence of facial nerve irritability. Chvostok sign में हम क्या करते हैं? We want to demonstrate the facial nerve irritability, and that means that when you tap on the anterior border of the parotid gland, it will cause here twitching. It will cause the twitching. So twitching of the corners of the mouth can be seen in this patient, which is very characteristic Chvostok sign. Both indicate tetany. The drug of choice for management of tetany is IV 10% calcium gluconate. The drug of choice for tetany is IV 10% calcium gluconate. That is like one of the main ways by which we are gonna save the life of this patient. Otherwise, this person can die also. So most of the time they give you a situation where patient underwent parathyroid surgery and then hypocalcemia will occur. 10% calcium gluconate is the drug of choice for hyperkalemia and also for hypocalcemia. Can you tell me the leading cause of hypocalcemia? The leading cause of hypocalcemia would be inadvertent removal of the parathyroid gland during total thyroidectomy. कि जब cancer has infiltrated into the parathyroid glands of the patient. If the cancer has infiltrated into the parathyroid glands of the patient, it's gonna contribute to, like, like the gland is totally infiltrated by cancer. I can't keep a cancer in the body. You have to remove it, and that's the bad news. But the second cause is what you answered very rightly, that is autoimmunity. So there are two important reasons for tetany. One is autoimmunity, and then the second one is inadvertent removal surgically. Then he has asked, what is the drug of choice of surgically induced hypoparathyroidism? So we need to give a hormone which is a PTH based derivative. This PTH based derivative is called as teriparatide. The advantage of doing this molecule or giving this molecule will be that you will be able to do a hormone replacement. You see, I'll say like this, just like you're comfortable with the fact that for type 1 diabetes, we need to give insulin. Similarly, here we need to give teriparatide injections on subcutaneously, maybe on a weekly, 2 weekly, something weekly or 2 weekly basis, depending on case to case, and this would help you in like preventing. It will help you in taking care of the bone health of the patient and preventing the development of tetany. Now, what I will do is I'll talk about an important question where calcium and phosphate values are always given. Remember, yeah, we cannot give calcium gluconate daily now. Calcium gluconate is to be given intravenously, and since you asked that question, can't we give calcium gluconate? If you give calcium gluconate daily, it can cause systolic arrest. No, because when you give it fast, it will cause cardiac arrest. So, can I give calcium gluconate daily? No. It is, and if you say orally, oral will not be sufficient. Hormone के बदले हार्मोन, खून के बदले खून, hormone के बदले hormone, teriparatide. Okay. Calcium and phosphate have a inverse relation, and serum alkaline phosphatase is a marker of bone turnover. So we will do an important table here. Primary hyperparathyroidism means that there will be a tumor in one of the parathyroid glands. The person is having a big tumor. This tumor is very small. It may not be visible on a routine CT scan or MRI, but it is producing excess of PTH, and PTH causes bone resorption. It removes calcium from the bone. So the calcium in the body will rise. The rationale for why the calcium is rising is क्योंकि यहाँ पे bone resorption हो रहा है. The PTH is removing calcium from the bone. Calcium and phosphate have an inverse relation. So phosphate in the body will be lost. Phosphaturia via the proximal tubule. PTH proximal tubule पे असर करके phosphate का loss करा देता है. तो PTH में when we will use this patient, the phosphate values will get reduced. Because bone turnover is increased in the patient, the serum alkaline phosphatase level will be elevated. At the moment, let me complete the table, then we'll talk about scans also. There would be a hypercalcemia with hypophosphatemia. This is the report of primary hyperparathyroidism. And now we will know rule of 10 is not accurate now. Rule of 10 for FAO is not accurate. That is why I did not talk about 10% malignant. Sometimes it is written 15% malignant. So rule of 10 is for only old books. The surgeon would have said rule of 10, it's outdated. I am also saying the same. Rule of 10 is outdated. Some parameters are 15%, some parameters are 20%. So it is not a very accurate data. That is why I did not speak about it. Secondary hyperparathyroidism. Secondary hyperparathyroidism occurs due to chronic kidney disease in a patient. कि अगर किसी का किडनी खराब हो गया तो किडनी का काम होता है विटामिन डी सिंथेसिस. If vitamin D will not be produced, calcium will also be less, and calcium and phosphate have an inverse relation present. The leading cause for secondary hyperparathyroidism is CKD, and because calcium and phosphate have an inverse relation, the phosphate levels will rise and bone turnover is more. So again, the serum alkaline phosphatase would be elevated. The key thing I want you to pick up for this question is hyperphosphatemia is developing. This is itself a question. Which condition causes hyperphosphatemia? Chronic kidney disease / secondary hyperparathyroidism. Must know MCQ. What condition causes hyperparathyroidism? It is chronic kidney disease. I'll say the rationale again. When kidney is damaged, vitamin D कम हो जाएगा. When vitamin D will be less, calcium will be less, and calcium and phosphate have an inverse relation, so phosphate levels will begin to rise. Now comes hypoparathyroidism. The reason for development of hypoparathyroidism can be like autoimmunity. The autoimmunity part is causing destruction of the glands, and therefore all the 4 glands are affected and PTH levels are beginning to fall. If PTH will begin to fall, calcium will also be less, because PTH का काम होता है calcium निकालना bone से. Now it cannot remove calcium, so calcium will be less, and calcium and phosphate have an inverse relation. You will notice that the report of hypoparathyroidism at the moment is looking almost identical to that of secondary hyperparathyroidism, where I put a thick marker marking also. What is the difference? The difference is bone turnover is not affected in hypoparathyroidism. If PTH becomes more, then bone turnover becomes more, but if it becomes less, then don't use English and say bone turnover is less. I repeat that. Bone turnover is increased by increased PTH, agreed. But bone turnover does not become lesser with a decreased PTH. It still remains normal. So therefore, serum alkaline phosphatase in this patient will be normal. A common mistake that people do here is they answer SAP as low. No, don't fall in the trap. Don't answer serum alkaline phosphatase to be reduced in hypoparathyroidism. It is normal. The bone turnover becomes more with PTH but does not become less with less PTH. That's the learning point from physiology perspective. Now comes the word pseudo-hypoparathyroidism. Pseudo-hypoparathyroidism is a condition in which PTH तो है पर उसका जो रिसेप्टर है ना वो खराब हो गया है. जैसे टाइप 2 डायबिटीज में इंसुलिन का रिसेप्टर खराब हो जाता है, वैसे यहाँ पे इंसुलिन का रिसेप्टर खराब हो गया है. व्हेन यू विल चेक द पीटीएच लेवल्स ऑफ द पेशेंट, पीटीएच यहाँ बढ़ा हुआ मिलेगा. क्यों बढ़ा हुआ मिलेगा? क्योंकि हार्मोन is not being able to act on the receptor. The basic rule of endocrine system is if a hormone is not able to act on the receptor, the hormone levels rise. In type 2 diabetes, insulin is more. Still, it is not able to act on the receptor. Just like in type 2 diabetes, insulin is more and it is not able to act on the receptor. Here it is high PTH, लेकिन वो असर नहीं कर पाता है, असर नहीं कर पाता. If it is not able to act, the calcium will be low. Phosphate will be elevated due to inverse relation, and bone turnover will also be normal. You can see the report is the same. Because the report is the same, that is why the word is pseudo hypoparathyroidism. Pseudo word क्यों बोलते हैं? That is because the report is the same, but how will you differentiate? The differentiation is on the basis of the PTH level. In the first entry which I made in blue, the PTH levels will be less because there is autoimmune destruction, but in the second report that I mentioned before you, PTH levels will be elevated. Why? Because it is a receptor problem. I hope it is clear, guys. Please let me know. Can you just comment in the chat box yes versus no if this is clear? Hypoparathyroidism versus pseudo hypoparathyroidism. If you want me to repeat, don't ask after 5 minutes. Let me know right now. Is it clear, guys? Hypo is damage to the gland, so PTH will be low, and pseudo hypoparathyroidism is an endocrine problem. The topic that I'm describing here is pseudo. The word pseudo is what I tried to explain. It is a problem not of the hormone. It is a problem of the receptor. And in those circumstances, the values would be elevated. एक बार फिर से कर लेते हैं. Quick 30 seconds into it. Hypoparathyroidism में तो gland destroyed. तो PTH कम हो गया. The report is in front of you. Less calcium, PTH less, calcium is less. Inverse relation, phosphate is more, and report is normal. अब आता है सूडो हाइपोपैराथायरॉयडिज्म. ये रिसेप्टर की खराबी है. जैसे एक होता है टाइप 1 डायबिटीज और टाइप 2 डायबिटीज, वैसे ही सोचो. हाइपोपैराथायरॉयडिज्म इज अकिन टू टाइप 1 डायबिटीज. इंसुलिन का कमी हो गया, यहाँ पे पीटीएच का कमी हो गया. और टाइप 2 डायबिटीज में क्या होता है? रिसेप्टर खराब हो जाता है ना. और वो रिसेप्टर का जो अगर रिसेप्टर खराब हो जाए तो हार्मोन को क्या होता है? उसका लेवल बढ़ जाता है, क्योंकि कंज्यूम ही नहीं हो रहा ना. हार्मोन इज नॉट गेटिंग कंज्यूम, सो द वैल्यूज विल राइज. द पॉइंट टू बी अंडरस्टूड इज कि वो आपको रिपोर्ट देगा लो कैल्शियम, मोर फॉस्फेट, नॉर्मल सीरम एल्कालाइन फॉस्फेटेज. ये रिपोर्ट देके बोलेगा इज इट हाइपोपैराथायरॉयडिज्म, इज इट सूडो हाइपोपैराथायरॉयडिज्म. आपको रिपोर्ट में आगे क्या चेक करना है? पीटीएच वैल्यूज. If this is the report that is given to you in the paper, guys, if this is the report that is given to you in the paper, it's identical report as you can see. How will you differentiate that is it hypo or is it pseudo hypoparathyroidism? PTH का level check कर लो. If PTH levels is low, hypoparathyroidism. If it is high, then it's not hyper. It is receptor का खराबी, pseudo hypoparathyroidism. So I think that's the final explanation that I basically explained for this table. Again, important one for calcium metabolism. And अब आप लोगों ने कमेंटिंग करनी है आगे. आप मुझे बताओ कि like I am giving teriparatide for this particular patient for like suppose it was surgically induced. So I have given teriparatide injection and the patient is doing well. His calcium values are stabilizing. I want everybody to participate. मुझे बताओ सूडो हाइपोपैराथायरॉयडिज्म में अगर teriparatide injection देंगे, will it work? If you give teriparatide injection to pseudo hypoparathyroidism patient where receptor is kharab, then you will not be able to stimulate the receptor in the patient, and in those circumstances, well, you can't do much in the patient. Like there's no definitive treatment available. तो इसका कोई treatment ही नहीं है. For secondary hyperparathyroidism in a patient, you will have to give calcium supplements in a patient. I mean, where do we give calcium supplements? Calcium and vitamin D3 supplements would be given for a person who is having CKD. And there's one more drug which I would like to mention for like the treatment part here. I will not give an explanation. I will give explanation for this medicine in the kidney topic. Cinacalcet is used for inhibiting PTH release. I'll not go further into explanation for cinacalcet in this patient. डेली थोड़ी ना आईवी दे देंगे, डेली थोड़ी ना आईवी दे दो किसी को रोज बुला के. और मान लो दिया और तुमने कार्डियक अरेस्ट हो गया, तो मेडिको लीगल कौन झेलेगा? कह रहे हो ना कैल्शियम ग्लूकोनेट दे दो पेशेंट को. यू आर बीइंग काइंड ऑन द पेशेंट. पेशेंट तो कह रहा है हाँ ठीक है ना, मैं तो केस करूंगा, देखो है ना कि मेरे को एरिथमिया हो गया, घबराहट हो गई, डॉक्टर साहब ने इंजेक्शन लगाया. या cinacalcet, I'll not speak more at the moment. I'll speak about in the kidney section. Now I come to the extreme left hand side, that is primary hyperparathyroidism in a patient. In primary, it's a tumor, so tumor will require surgery. Before surgery, I will have to stabilize calcium levels in the patient. I will teach you how to stabilize those calcium levels also. But at this moment, I want to say that for primary hyperparathyroidism, first I need to demonstrate there is a tumor. For the demonstration of tumor in this particular case, there is a special scan. And the scan name needs to be remembered, that is technetium, because surgeon needs to know now left, right side parathyroid gland, up and down. There are four parathyroid glands. Where is the tumor located? So the scan that you do in this patient is called as technetium 99 system EB. SPECT CT. That's the complete data to be remembered, guys. Another scan has been added to your vocabulary, just like you guys were earlier studying gallium 68 dotated PET CT scan. At the moment, it is technetium 99 system AB SPECT CT scan that would be used for evaluation of these patients. This is a tumor, that this is a scan that is used for evaluation of a person having a parathyroid adenoma. Since I got good comments there, I would like you guys to also let me know. Technetium 99 per TechNet scan is used for evaluation of. Technetium 99 per TechNet scan is used for evaluation of. Another scan that I'm talking about is a Technetium 99 stress system EB scan. I would expect you guys to give me quick answers for the questions that I've highlighted. Technetium 99 per TechNet scan, Technetium 99 stress system EB scan. Yes, guys. Waiting. Technetium 99 per TechNet scan is for Meckel's diverticulum. Technetium 99 per TechNet scan is used for Meckel's diverticulum, and that has the rule of 2. And then is Technetium 99 stress system EB scan that is used for evaluation of. Yes, guys, let me know the answer for the next one. I'll wait for a few more seconds. I'm going to give you more opportunity. Stress system EB scan. The guy is walking on a treadmill. Yes, what is the condition that we're talking about? The guy is walking on a treadmill. Yes, guys. This is not a difficult one. You just had radiology recently. Yeah, myocardial perfusion imaging. What is the medical condition? English version of this is MPI only, no? It is myocardial perfusion imaging. Beta, I'm asking you which medical condition? Okay, Tabrez is pretty close. He is the first one to being at least close to the topic that I'm asking. Not MI. Come on. Do you think MI के patient को आप stress दोगे? I think everybody needs lunch now. भूख लगी है. Yeah, your answer is chronic stable angina. भाई मुझे पता है तुम्हें भूख लगी है ना? मतलब ये ऐसा भी नहीं है ना, ऐसा भी आंसर मत दो कि मैं बोलूँ ओके नाउ इट इज ब्रेक टाइम. Chronic stable angina, guys. Yeah, hibernating myocardium is a good answer there. Chronic stable angina, that is blockages. भाई जिसको MI में थोड़ी ना ट्रेडमिल पे चलाते हैं यार, जिसको ब्लॉकेजेस इन द कॉर्नरी आर्टरी होती है तो ब्लॉक पता करने के लिए पता लगाते हैं. इसको क्या बोलते हैं? क्रॉनिक स्टेबल एंजाइना. नो वी डोंट यूज फॉर वेरिएंट एंजाइना. वहाँ एंजियोग्राफी करेंगे ना स्पैज्म के लिए. तो और एथ्रोस्क्लेरोटिक नैरोइंग. सो समबडी सेड एथ्रोस्क्लेरोसिस, गुड आंसर. समबडी सेड कॉर्नरी आर्टरी डिजीज, गुड आंसर. लेकिन यार वो तो स्पेसिफिक टर्म्स पूछता है ना. ही विल आस्क यू कैड, ही विल से क्रॉनिक स्टेबल एंजाइना. सो कैड इज अ वेरी ब्रॉड टर्म. स्पेसिफिक आंसर इज chronic stable angina where the blockage is in the coronary artery. But scans are like super important. All radiological investigations should be written in 1 to 2 pages and it's over now. Not too much to remember. Like investigation choice for each condition, try to write down the names for all of them and you'll be like sorted. And now I'm going to talk about a man who came with stones, moans, groans and stones, bones, moans and psychic moans. Primary hyperparathyroidism, the guy was having a tumor in the parathyroid gland, as I've explained to you. So he will give you these images of a SPECT scan or on a plain CT scan in a patient. Like here you can see it's a SPECT CT. No, this is functional imaging. No, this functional imaging is SPECT. This is the CT scan. So he will give both of them together. That is a SPECT CT scan that is given in a patient. And along with SPECT CT scan, then they will also give you an image of the hands of the patient, where the person ki radial side pe most of the time you will able to notice the subperiosteal reabsorption of the phalanges. That stones, bones, moans and psychic moans are very clear. But in these patients, it is a subperiosteal. reabsorption of the phalanges. And where will you be checking for this subperiosteal reabsorption of the phalanges? It will be usually on the radial side. They occur on both sides, but is predominantly more visible on the radial side. So subperiosteal reabsorption of phalanges is gonna be like one of the radiological findings given in this condition. For primary hyperparathyroidism, the question will begin by describing patient having kidney stones, that is renal stones coming up, renal colic. He will say कि उसको बार बार hospitalization होती है renal colic की वजह से. That's because the person would be having painful hematuria, the stones edges are jagged and they'll cause passage of blood in the urine. PTH will remove calcium from the bone, तो हड्डियां कमजोर हो जाती हैं. PTH will remove calcium from the bone, तो हड्डियां कमजोर हो जाती हैं. The bones tend to become weaker. What is that weakening of the bone called as? That is not called as osteoporosis. It is called as osteitis cystica fibrosa. What is this weakening of the bones called as? It is called as osteitis cystica fibrosa. It is not called as osteoporosis. The PTH will be causing reabsorption of calcium from the bones. तो हड्डियां कमजोर होती हैं and because यहाँ पे bone में cyst बन जाते हैं तो bleeding हो जाती है. Because of the bleeding in the bone, they would be like because of the formation of cyst in the bone, they can be bleeding. And because of this bleeding, the hemoglobin will degenerate to produce hemosiderin. And hemosiderin is not red in color, it is brown in color. So he will write a term which is a misnomer. It is not a tumor. It gives the tumor appearance, that is brown tumor. I'll say the facts once again. PTH ने bones में cyst कर दिया, calcium निकाल दिया, हड्डी कमजोर हो गया. उन cyst में bleeding हो जाएगा. Hemoglobin is not red in color. It breaks down to produce hemosiderin, which is brown to black in color. So that brown tumor is a misnomer, but it indicates that bones that are occurring in this bone pain that is occurring in this patient, then the bones are because of constipation. Very severe constipation will occur in this patient because high calcium will cause spasm of the sphincters of the intestine. Because of the spasm of the sphincters of the intestine, the patient will be having constipation, which will be refractory to laxatives. If you ever read constipation in endocrine topic, तो दो बार ही हमेशा constipation होती है. एक hypothyroidism and second is gonna be hyperparathyroidism. Hyperparathyroidism and hypothyroidism. Thyroid का problem T4 कम हो जाए और उसके साथ में ब्रैकेट में लिख रहा हूँ. Whenever you read about hypothyroidism, constipation will be given. Hyperparathyroidism it would be given. And because the person will be having pain all the time, सारा टाइम उसको pain रहने वाला है, तो उसको psychosis हो जाएगा. Psychic moans are present. This is the image-based description of the same aspects which I had said on the previous slide, and I need to go for a location of the tumor and then the surgical resection of the adenoma will be done in this patient. Now I will repeat the opposite aspect of it, that is hypercalcemia. You guys can let me know two important aspects before we go for a lunch break. What is the leading cause of hypercalcemia in hospitalized patients? Leading cause of hypercalcemia in hospitalized patients. Malignancy. Which malignancy, guys? Is it small cell cancer? Is it squamous cell cancer? Is it small cell cancer? Is it squamous cell cancer? Yes, it is squamous cell cancer of the lung. The commonest malignancy which can contribute to this is squamous cell cancer of the lung. The squamous cell cancer of the lung will produce a hormone by the name of PTH-RP, that is PTH related peptide, and this PTH related peptide will cause calcium level to rise. Obviously, he can talk about breast cancer in a lady also, but most of the time the questions will revolve around a lung cancer patient. He will say a known case of lung cancer. He will say known case of lung cancer. He is a smoker also. He had weight loss, hemoptysis. So first he will like describe lung cancer, and then he will say today the patient has come to the hospital with development of confusion, disorientation, and the person is not recognizing family members, altered mentation. A person having lung cancer has today come to the hospital with confusion, altered mentation. On examination, evidence of dehydration can be present. On examination, evidence of dehydration can be present. Because of dehydration, pulse can be more and BP can be slightly low. Not a crashing blood pressure, but yeah, dehydration evidence is there, confusion and altered mentation is present. The doctor on duty, because this guy is having lung cancer also and is already aware that this guy is having squamous cell cancer, he got a baseline ECG done. In ECG, the QT interval always has a inverse relation. The QT interval always has a inverse relation with the value of calcium. So the question in this particular case will mention QT shortening was noted. The doctor has also ordered electrolytes. In electrolytes, there's a possibility that he will give you the report sodium is less, potassium is less. That would be just a distractor, because any dehydrated patient can be having like sodium and can be having potassium less, and then we'll say calcium in this patient is elevated. That's the main point that I want you to pick up, that you get a question of lung cancer, confusion, disorientation, dehydration, and then gives you the labs. These labs will deliberately have hyponatremia, hypokalemia, and any dehydrated patient it can happen. But hypercalcemia is the main thing that we need to understand, because cancer is producing PTHRP. It is not PTH, it is PTH related peptide. It looks like PTH, it will drive calcium levels. Now he will say, how will you medically manage the patient? The calcium value is 12.5. If calcium level will go more than 13, then there is a risk of cardiac arrest in a patient. If calcium values will go more than 13, there is a risk of development of cardiac arrest in this patient. There is a risk of systolic cardiac arrest. Whether you are an FMG student, whether you are a NEET PG aspirant, this question always comes in the exam. He will always build up a theory aspect like this. Obviously, he will not write risk of systolic cardiac arrest. He will say, what will you do for management of this patient? Your answer will be, I will be giving normal saline. Add to the bottle of normal saline, you will add furosemide, because loop diuretics lose calcium, and loop diuretics will lose calcium. Loop diuretics will lose calcium. The calcium values will stabilize in the patient. It will decrease from normal saline, will cause the values to decrease from 12.5 to 12.4, 12.3 because of the dilution effect. And then simultaneously, furosemide loop diuretics will lose calcium. Loop diuretics lose calcium. So I will be able to reduce the calcium values of the patient, after which I will start the patient on drug of choice. The drug of choice for hypercalcemia, whether you are a NEET PG aspirant, FMG aspirant, they always ask this question. So please pay attention here. I know you are tired, but you need to listen to this carefully. It will just take 2 minutes of your time. The drug of choice for this condition is same as the drug of choice of osteoporosis. Bisphosphonates. Bisphosphonates will drive calcium into the bone. It's more in the blood. If I drive it in the bone, the blood calcium values will stabilize. So the intravenous management for this particular patient would be bisphosphonate. What is that bisphosphonate that can be given intravenously? It is like ibandronate or zoledronate that would be given to this patient. So bisphosphonates will be used for medical management of this patient to drive the calcium into the bone and stabilize the calcium values. The next medicine that we will be using for this patient is nasal spray of calcitonin. Calcitonin has an in word in it, by which you can remember it is also sending calcium in the bones. See, technically what calcitonin does is that it inhibits osteoclastic activity. If they ask you technical, then what is the technical answer is that osteoclast will inhibit osteoclastic activity. If you inhibit osteoclastic activity, calcium will not rise further, because osteoclasts remove calcium from the bone. But the easier way to remember this would be calcitonin में inward लिखा हुआ है, so in tells you it inhibits osteoclastic activity, or I can put a easier unofficial way, it will send calcium in the bone, and therefore if you inhibit or if you send calcium in the bone, calcium values will stabilize. A query from doctors is, sir, why this is not the drug of choice? If it can be given in form of nasal spray, it's easy to give now, so it should be the drug of choice. It is a very easily administrable drug, but the problem with this is tolerance, that is tachyphylaxis. It is the tachyphylaxis part, that tolerance occurs very, very soon. That is why we don't call this as the drug of choice, because of the risk of tolerance. The fourth drug we can use in this patient is a monoclonal antibody that is used in osteoporosis, that is denosumab. The fifth medicine that I can use for this patient is oral. Once the patient will stabilize bit, I can give oral phosphate. Though there is a disadvantage also that calcium will combine with phosphate to form stones. But at the moment I'm ready for anything. You see, if you compare systolic arrest, somebody will die. Yeah, versus stone, I'm ready to take the risk of stone. So at the moment I can give oral phosphate to the patient. And if he says that the person is having refractory, that is in spite of the management, like nothing is working, then I don't have an option. Then because the person can die, I will also plan hemodialysis in this patient. Hypercalcemic crisis is the most frequently asked endocrine emergency nowadays in NEET PG and FMG exam. Last times NEET PG had a question on hypercalcemic crisis. So when you will study endocrine topic, I want you to start from reading this topic first. Every line that I've said can be put up as a question for you. I repeat my statement, whether NEET PG or FMG, when you read endocrine topic, don't start from the first page and waste your time with diabetes. You know diabetes. You know basic things. Start with hypercalcemic crisis, and that would be the best one. Yeah, K2, but yeah, not effective at the moment. And like you will be able to stabilize your patients very well. The next question is for all NEET PG aspirants. No, drug of choice is not denosumab. The drug of choice for this patient is ibandronate. This is the drug of choice. Now, इसके बाद lunch break है. 2 क्वेश्चन आपके लिए for all NEET PG aspirants. Quick answers now, right? The question says that ये जो patient है इसे sarcoidosis की वजह से hypercalcemia हो गया. If sarcoidosis क्या करता है? Sarcoidosis causes विटामिन डी प्रोडक्शन. जो उसके नॉन केजेटिंग ग्रेनुलोमास होते हैं, वो नॉन केजेटिंग ग्रेनुलोमास विटामिन डी का प्रोडक्शन करते हैं, तो कैल्शियम का जो लेवल होता है वो बढ़ जाता है, और कैल्शियम बढ़ेगा तो कार्डियक अरेस्ट का रिस्क हो जाता है. तो सार्कोइडोसिस के पेशेंट में हम हाइपरकैल्सीमिया कैसे ट्रीट करेंगे? Then your answer will be that I will give steroids to the patient, because drug of choice for sarcoidosis is steroids. When we will give steroids to the patient, what will happen is that it will treat those lymph nodes which are having those granulomas. When those lymph nodes having granulomas will melt away, when will disappear, hypercalcemia will also disappear. So for sarcoidosis, it is steroids that would be used. Steroid responsive hypercalcemia. Next is a guy, he's a bodybuilder. He goes to gym every day, and his coach found that he was a soft target and he gets easily influenced. So his coach told him that I will give you some special supplement. इतने का आता है लोकल सप्लीमेंट का. वो सप्लीमेंट उसको बेच दिया महंगे पैसे में, और बोला कि तू ये खाएगा बॉडी बिल्डिंग ज़्यादा हो जाएगी, मतलब ज़्यादा हो जाएगी. And these local supplements have like outrageous amounts of vitamins also present. I mean, obviously we should eat more vitamins when we are doing bodybuilding, and we should eat more proteins when we're doing bodybuilding, but like outrageous amounts of vitamin D can cause again damage in the body. They can cause vitamin D intoxication. So he will create some kind of story where the person went to a gym and like he was doing too much of supplements. Then vitamin D intoxication will again cause hypercalcemia, and what will be used in this patient will again be steroids. The next entry that I want you to make is for what somebody has already commented, multiple myeloma. Multiple myeloma will have features of CRAB. Madam ने बताया CRAB, hypercalcemia, renal failure, anemia, and bony lytic lesions. Hypercalcemia, renal failure, anemia, and bony lytic lesions are feature of hypercalcemia. At least everybody knows bonolytic lesions are present. So bony lytic lesions will cause hypercalcemia again, and the calcium levels in this patient will begin to spike. So he will say, how will you control that? You will again be giving steroids to the patient, like Dexona or dexamethasone can be used in this patient. What I wanted to bring to your attention is steroid responsive hypercalcemia. What I wanted to bring to your attention is, what are those conditions where you have steroid responsive hypercalcemia? There are 3 situations that I have created for you. Steroid responsive hypercalcemia will be sarcoidosis, vitamin D intoxication, and the third one is multiple myeloma. These are steroid responsive hypercalcemia. I did not speak about steroids superiorly because not all cases are having these manifestations. So lung cancer में तो steroid का rule नहीं रहने. But like for specific these conditions, steroids would definitely be working in the patient. Yes, Polishri, you're perfectly spot on for this. So with this, we can go for a lunch break, right? And we can start a little later. I think we can take a 40-minute break today. So it would be 3:40 that I'll be starting again. The starting time of the next session, I'm writing for just in case the relay is a little delayed, is 3:40. Okay, guys. Take care, and I'll see you again. Please join the online live session. Okay, so I think everybody has joined in. What we'll discuss next is respiratory system. I'll talk about aspects related to pulmonology next up, and first we will be handling issues related to the ABG. You will also notice that when you scroll through the document, there are a couple of scenarios which are given in red. So if you're an FMG student, you can drop out at the left time when I discuss 1.2. Though I want you to sit, but that's optional. If you say that I'm a little exhausted and want to take a break, then 1.1 and 1.2 are where you can take it a little easy. But for the remaining part of the discussion, obviously, like you have to be up on your toes and keep on answering about all the questions that are fired towards you. And okay, let me check if the app relays perfectly okay, and then we can get started. Page number. Page number is 110. 110. Okay, perfecto. So the topic that we're discussing at this particular moment is respiratory system. I'll talk about important aspects like pneumothorax, non-invasive ventilation, pneumomediastinum, and first and foremost, we will talk about how to analyze ABG questions in under 30 seconds. This is an important part of the discussion, highly neglected by people, but high yield in my opinion. In all questions, though they will give it in jumbled format, भाई नजर मत लगाओ. In all questions, nazar mat lagao. In all questions of the ABG, they might be given in any jumbled format. You first have to look at pH, then look at PCO2, and then look at bicarbonate. That bicarbonate value is 22 to 26, as I've told you already. PCO2 is 35 to 45, and pH is 7.35 to 7.45. Now, the first and the foremost thing is thing to be taken care of was first check out the pH and then check out PCO2. Don't even focus at the moment that pH is less and PCO2 is less. I am saying that if pH and PCO2 are going in same direction, mark my words there. If pH and PCO2 are going in same direction, that means that the problem of the patient is metabolic, and in a metabolic problem, the deciding factor will be bicarbonate. I mean, how do we decide whether person is having metabolic acidosis, metabolic alkalosis? Then the main deciding factor to be taken off is bicarbonate, because bicarbonate is consumed. खत्म हो जाता है bicarbonate. So final point is कि metabolic acidosis के जितने भी questions होंगे उन सब में pH, PCO2 और bicarbonate less और less हो रहे होंगे. फिर से बोल रहा हूँ, मेटाबॉलिक एसिडोसिस के सारे सवालों में पीएच पीसीओ2 बाइकार्बोनेट लेस होगा. क्यों पीसीओ2 लेस हो जाता है? बिकॉज यू हैव स्मॉल ब्रीदिंग, और क्योंकि यहाँ पे स्मॉल ब्रीदिंग होती है तो हाइपर वेंटिलेशन से CO2 वॉश आउट हो जाता है, CO2 वॉश आउट हो जाता है. अब इसका उल्टा देखते हैं. सपोज दे गिव मी अ क्वेश्चन इन विच पीएच एंड PCO2 आर गोइंग इन सेम डायरेक्शन. At this moment, don't focus on whether both are more. All I'm saying is the direction of the arrows is same. So when direction of arrows of 1 and 2, what is P1, what is 1 pH, what is 2 PCO2, never jumble them. First pH, then PCO2, it is a metabolic problem. And now if bicarbonate is also more, then you will say that the person will be having metabolic alkalosis. So first and foremost, the rule to be remembered is if the direction of arrows of 1 and 2 are same, metabolic problem. How do you decide acidosis or alkalosis? Bicarbonate value. Now I will change the values. अभी लिखते हैं, अभी नॉर्मल वैल्यू पे डालेंगे. अभी आप मैथ्स पे फोकस करो. Focus on mathematics. Suppose they give you a question in which pH and PCO2 are going उल्टा. अभी आपको मैथमेटिकल वैल्यू भी नहीं पता. अगर एरोस उल्टा जाएंगे, एक कम हो गया एक ज्यादा हो गया, Then the interpretation to be taken is respiratory problem. In a respiratory problem, आपको देखने का जरूरत ही नहीं है what is the bicarbonate. Don't even give a damn to the value of bicarbonate. कुछ भी लिखियो. If pH of the patient is less, you will say it is respiratory acidosis. In respiratory acidosis value or respiratory acidosis MCQ, don't even give a damn to the value of bicarbonate, guys. If you just look at pH is less, it is respiratory acidosis. Though for completion's sake, I will give a direction to it. But at this moment, the main hack to be remembered is that in all respiratory problems, pH और PCO2 उल्टा चलते हैं और मेटाबॉलिक में pH और PCO2 सेम सेम डायरेक्शन में चलते हैं. जैसे सपोज एक सवाल आया जिसमें pH ज़्यादा है और PCO2 कम है, तो बिकॉज एरोज उल्टा उल्टा चल रहे हैं तो बोलेंगे पेशेंट को रेस्पिरेटरी प्रॉब्लम है. अब एसिडोसिस बोलना है या अल्कोलोसिस बोलना है, तो यहाँ डिसाइडिंग फैक्टर pH ही होता है. इट इज सो सिंपल दैट सिंपली आपको ये देखना है कि pH 7.45 से ज़्यादा है तो दिस विल बिकम रेस्पिरेटरी अल्कोलोसिस. नॉर्मल वैल्यूज मैंने मॉर्निंग सेशन में मेंशन भी करी थी, फिर से बोल रहा हूँ. नॉर्मल pH वैल्यूज वुड बी a pH value of 7.35 to 7.45. Normal PCO2 value is between 35 to 45, were discussed even in the morning in when diabetes was talked. And bicarbonate values 22 से 26 milliequivalent. Anything less than 22 is acidosis, anything more than 26 is alkalosis. The first and the foremost thing is never change the rule. It is 7.35 to 45, 35 to 45 millimeter of mercury, obviously millimeter of mercury, and the bicarbonate values are 22 to 26 milliequivalents. The rule to be remembered in all of these questions is Rome. The rule to be remembered is Rome. What do you mean by Rome is, in all respiratory problems, the pH and PCO2 of the patient will progress in opposite direction. What you have to check is one pH, then is PCO2. They progress in opposite directions in respiratory problem. In metabolic problem, what you will notice is that they will be going in same direction. Now, obviously that Rome, if I say same, it will not fit in the mnemonic. So you will say equivalent. Equivalent मतलब कि same direction में जाएंगे. Again pH and PCO2. Rome is a mnemonic by which you can easily solve a question under 15 seconds. मैं तो बोलूँगा 5 सेकंड में सॉल्व हो जाता है. सिर्फ इतना ही तो देखना होता है कि pH और PCO2 की वैल्यू अगर दोनों ही कम हो गई, जैसे कि आप इस फर्स्ट एंट्री में देख रहे हो कि अगर pH 7.35 से कम है और PCO2 35 से कम है तो मेटाबॉलिक प्रॉब्लम हो गया. और अगर pH और PCO2 उल्टा जा रहे हैं, then on those circumstances you will say that this is a metabolic problem in the patient because it is going in same side. Opposite जा रहा है respiratory और same जा रहा है तो metabolic. So most of these questions are like, very straightforward, very easy to interpret. All I will give a direction to the value of bicarbonate in this question also, but even if you don't give a direction chalega. What you basically need to remember is the facts what I have currently explained to you. Once this thing is settled in your mind, now I will talk about a bit of छोटा सा chemistry का concept. The छोटा सा chemistry concept is that CO2 is suppose like this is a chemistry equation जो 8वीं 10वीं क्लास से पढ़ते आए हैं कि carbon dioxide combines with water to form carbonic acid, and this carbonic acid will then break down to produce protons and bicarbonate. This is the basic chemistry equation that I have currently highlighted that we study in class 8 and 12th and then in medical college as well. Now what I am saying is, suppose a person is having carbon dioxide retention. The best example of carbon dioxide retention can be status asthmaticus, which is also called as silent chest. If an asthmatic patient is having an attack which is so severe that bronchospasm इतना severe हो गया कि कार्बन डाइऑक्साइड का retention हो जाएगा, तो कार्बन डाइऑक्साइड in excess will combine with water to form carbonic acid, and when this carbonic acid will be formed, it will break down to produce protons. So one I want to say कि carbon dioxide is a acidic molecule. This is the second concept after Rome. कार्बन डाइऑक्साइड एक एसिडिक मॉलिक्यूल है. जब भी इसकी वैल्यू बढ़ती है तो ये बाइकार्बोनेट बनाता है उसका. जब भी इसकी वैल्यू बढ़ती है तो ये कार्बोनिक एसिड बनाता है. कार्बोनिक एसिड वर्ड टेल्स अस दैट इट्स an acidic molecule. It will generate protons and therefore the pH of the patient because of protons in excess will begin to fall. You can see here what I'm trying to explain is that why did I say that in respiratory problem the arrows of pH and PCO2 will go in opposite direction? Chemistry. When CO2 will rise, it will combine with water to form carbonic acid. Carbonic acid will generate more protons and the protons will be causing the pH of the patient to fall. This is like a class 8th or class 10th chemistry class, chemistry equation that I've written here before you, but I wanted to give justification. Or why is it like when I was describing respiratory problem to you, respiratory acidosis to be precise, I had said you can check out on the board right now. In the upper part of the board, CO2 value is given, pH कम हो रहा है और CO2 rise कर रहा है. So though I have written the word status systematicus, even if I remove that word, you have to remember that if these two arrows go in opposite direction, first pH then PCO2, it is a respiratory problem. The words I will write on the case file is what I just emphasized. This is a case of respiratory acidosis anytime there is a carbon dioxide buildup in the body. Now comes the more critical aspect, more dynamic aspect. More dynamic aspect is that the body will have to fight back against this. You know, we always have compensation because respiratory acidosis will damage the blood-brain barrier. It will cause the patient to become drowsy, altered sensorium. He will not be recognizing family members. So the body is sending out a panic call. This panic call is given to which organ of the body? The call is going to the kidney. Lungs and kidneys are two brothers. They're two bros. And if one is in problem, the other one says, brother, I'm going to help you. At the moment, the panic distress call went from the lungs. Buddy, I'm having a problem. I'm not able to work. CO2 is rising. Kidney said, bro, मैं हूं ना. Now let's look at what the kidney will do. Kidney का जो proximal converter tubule होता है, kidney का जो proximal tubule होता है, उसमें जो ultrafiltrate होता है, that ultrafiltrate is rich in various electrolytes like sodium, potassium, chloride, bicarbonate. So the kidney says, okay, buddy, I'm gonna give you more bicarbonate so that you can fight these bad guys, you can fight these protons. किडनी क्या करेगा, प्रॉक्सिमल टिब्यूल का जो अल्ट्राफिल्ट्रेट है वहां से बाइकार्बोनेट का जो रीअब्जॉर्प्शन है, बाइकार्बोनेट का जो रीअब्जॉर्प्शन है वो इंक्रीज हो जाएगा. और जब बाइकार्बोनेट का रीअब्जॉर्प्शन को आप अपग्रेड कर दोगे तो आई पुट अ डॉटेड डॉटेड एरोस टू शो दैट बाइकार्बोनेट इज राइजिंग. दिस राइज द बाइकार्बोनेट विल न्यूट्रलाइज द प्रोटॉन्स. And by thankfully, I can say grace of God, because God ensured lungs and kidneys are going to help each other. The pH will begin to stabilize because hydrogen and bicarbonate will now cancel each other. They will neutralize each other. What is the compensation of respiratory acidosis? आप देखिए यहाँ पे kidney is playing a role. So I'm putting the word metabolic. And what is the kidney doing? It is raising the bicarbonate. It is elevating the bicarbonate. So what is the kidney doing? The rise of bicarbonate is called as metabolic alkalosis. The compensation of respiratory acidosis is metabolic alkalosis. In the exam, you don't need to do so much of thinking. This is an academic class, so that is why I went into all of this. In reality, आपको इंग्लिश लगा के उल्टा करना है. रेस्पिरेटरी का वर्ड स्वैप कर देना मेटाबॉलिक और एसिडोसिस का वर्ड स्वैप कर देना एल्कोलोसिस. कॉम्पेंसेशन निकालने में ज्यादा दिमाग नहीं लगाना है. In compensation, you don't need to get into so much of logic. You just need to use English and invert the language. To see that you got me, please comment in the chat box. What is the compensation of metabolic acidosis? You will say, I will use English, and for metabolic acidosis, compensation will be respiratory alkalosis. Like I told you here, compensation of respiratory acidosis is metabolic alkalosis. I changed my question to what is the compensation of metabolic acidosis? तो आप respiratory alkalosis कर देना, बस इतना ही करना. कॉम्पेंसेशन निकालना कोई बड़ी बात नहीं है, वो तो 5 सेकंड का काम है. एक 8वीं 10वीं क्लास के बच्चे को भी बता दो ना कि भी उल्टा कर दे तो कॉम्पेंसेशन एवरीबडी कैन कैलकुलेट. योर रोल एज एन एमबीबीएस डॉक्टर इज टू डिटरमाइन द प्राइमरी चेंज. व्हाट आई मीन बाय द प्राइमरी चेंज इज कि एक्चुअली में उसको दिक्कत क्या है, वो दिक्कत कैसे पता लगाते हैं. हाउ डू यू फाइंड द प्राइमरी चेंज? द प्राइमरी चेंज दैट आई एम गिविंग टू यू एट दिस पर्टिकुलर मोमेंट इज ऑन द बेसिस ऑफ द प्राइमरी चेंज दैट आई एम गिविंग टू यू एट दिस पर्टिकुलर मोमेंट इज ऑन द बेसिस ऑफ दिस टेबल. एंड द टेबल इज गोना बी व्हाट इज आई डिस्कस्ड एट द मोमेंट बिफोर यू. दिस टेबल is designed to pick up the primary change in the patient. The rule I will say once again, if pH and PCO2 go in same direction, then it is a metabolic problem. Deciding factor is bicarbonate. And if they go in opposite direction, then it is a respiratory problem and pH is the deciding factor. Metabolic में कैसे डिसाइड करते हैं एसिडोसिस एल्कोलोसिस? बाइकार्बोनेट की वैल्यू पे. रेस्पिरेटरी में बाइकार्बोनेट को डैम भी नहीं देना है. डोंट इवन लुक एट इट, जस्ट फोकस ऑन द पीएच वैल्यूज एंड यू आर सॉर्टेड. इनफैक्ट रेस्पिरेटरी तो सो सिंपल है दैट पीएच एंड पीसीओ2 विल बी गोइंग ऑपोजिट. यू नो रेस्पिरेटरी, बस इतना देख लेना पीएच लेस है या पीएच मोर है एंड यू गेट द प्राइमरी चेंज इन द पेशेंट एंड देन यू इन्वर्ट द इंफॉर्मेशन देयर. नाउ कम्स द एस्पेक्ट ऑफ कार्बन डाइऑक्साइड. इसको मैथमेटिक्स को सिर्फ एक बार सुन लेना और फिर उसके बाद में चाहे भूल जाना. कार्बन डाइऑक्साइड अगर 10 पॉइंट बढ़ती है सपोज कार्बन डाइऑक्साइड 30 से 40 होती है, 40 से 50 होती है, वट एवर, तो बाइकार्बोनेट कितना पॉइंट बढ़ना चाहिए, तो इट शुड राइज बाय 1 मिलीक्यूरेंट। इसको कॉम्पेंसेशन बोलते हैं, कॉम्पेंसेशन का रूल बोलते हैं। पहले तो मैंने एक बेसिक तरीका बताया ना, कॉम्पेंसेशन इज ऑलवेज ऑपोजिट। So if the compensation is always opposite, then it is like pretty straightforward. You just use English and invert the data, but I'm not telling you a mathematical rule. If this rule is satisfied, we say it is a compensated disorder, and if it is not satisfied, we say it is a mixed disorder. Then we say it's a mixed disorder. Now, once you get this basic data right of like 10:1 ka rule, we'll put this into practice, and I will be giving you certain scenarios that you need to remember for working out the information. Like, this is a COPD patient. The COPD patient was very drowsy and he was like, not recognizing family members. So they brought him to the hospital right now. When you check out the report, first you look at pH, then you look at PCO2. The pH and PCO2 is going opposite. If pH and PCO2 is going opposite, it is a respiratory problem in this patient. So that's the first word I'm writing. Because the pH of the patient is less, that means the patient is having respiratory acidosis. Now, in respiratory acidosis, what should happen in bicarbonate is bicarbonate should rise. I told you the 10:1 ka rule. If the kidney is supposed to neutralize the protons, the meaning of respiratory acidosis is that there is more protons in the system. If you have more protons in the system, what should the body do? It should raise bicarbonate to neutralize. Lekin if the bicarbonate at the moment is normal, that means that the kidneys have still not started the compensation process. Kidney कह रहा भाई रुको जरा, मदद करता हूँ। एकदम से कैसे करूँ, जरा 2 सेकंड यार भाई, सांस तो ले लेते। तूने मैसेज भेजा है, मैं तेरी मदद करूंगा ब्रो, तू मेरा भाई है, मैं तेरी मदद करूंगा, पर गिव मी अ ब्रीदर। When the patient will come early, the bicarbonate report can be normal. Because the bicarbonate report is normal, that is why you will say the word uncompensated. At the moment, the English word is uncompensated. Why will you say uncompensated? Because अभी kidneys ने मदद करना शुरू नहीं किया है. So the word is uncompensated respiratory acidosis. देखो रेस्पिरेटरी एसिडोसिस तो निकाल लोगे, सीओपीडी लिखा होगा, पीएच और पीसीओ2 उल्टा चल रहे होंगे, CO2 से एसिडिक मॉलिक्यूल्स और प्रोटॉन्स बन रहे। सिर्फ इतना देखना है कि इज द बाइकार्बोनेट वैल्यू ऑफ द पेशेंट नॉर्मल और इज इट राइजिंग। अगर वो नॉर्मल है तो हम बोलेंगे पेशेंट को अनकॉम्पेंसेटेड रेस्पिरेटरी एसिडोसिस है। नाउ आई हैव स्टार्टेड ट्रीटमेंट ऑफ दिस गाय, तो लेट मी एनालाइज दिस रिपोर्ट वंस अगेन। पीएच इज 7.22, इट इज लेस। PCO2 is 58, it is elevated. I hope everybody agrees arrows are going in opposite direction, so even this is a case of respiratory acidosis. Respiratory acidosis means protons are being generated in the body, and these protons are dangerous because they can damage the blood-brain barrier, so the kidney has now to act. The kidney will start increasing the bicarbonate in the body। सिर्फ 2 पॉइंट का इंक्रीमेंट हुआ है, सिर्फ 2 पॉइंट का इंक्रीमेंट हुआ है फ्रॉम 26 to 28, बट क्योंकि बाइकार्बोनेट बढ़ना शुरू हो गया, बिकॉज बाइकार्बोनेट हैज स्टार्टेड टू राइज एट दिस पॉइंट ऑफ टाइम, आई विल से दैट आई एम डीलिंग विद अ केस ऑफ पार्शियली कॉम्पेंसेटेड। आई विल से दिस इज पार्शियली कॉम्पेंसेटेड रेस्पिरेटरी एसिडोसिस। कैसे पता लगाना है अनकॉम्पेंसेटेड या पार्शियली कॉम्पेंसेटेड इन रेस्पिरेटरी एसिडोसिस? क्वेश्चन बाइकार्बोनेट की वैल्यू देख लेना, नॉर्मल होगी तो अनकॉम्पेंसेटेड बोल देना, अगर स्लाइटली एलिवेटेड हो जाए तो पार्शियली कॉम्पेंसेटेड बोल लेना। इफ यू आर दैट मैथमेटिक्स ओरिएंटेड, इफ यू आर अ मैथमेटिक्स स्टूडेंट, तो थोड़ी मैथमेटिक्स प्रैक्टिस करा देता हूँ। इफ यू आर अ मैथमेटिक्स स्टूडेंट, हियर मी आउट। मान लो नॉर्मल PCO2 होता है 35 से 45, एवरेज लगा लो 40 होता है। एवरेज कार्बन डाइऑक्साइड इन बॉडी इज 35 to 45, टेकन एवरेज ऑफ 40। पेशेंट की वैल्यू बढ़ के हो गई थी 40 से 60, दैट इज अ इंक्रीमेंट ऑफ 20 पॉइंट्स ना, दिस इज अ इंक्रीमेंट ऑफ 20 पॉइंट्स। Normal PCO2 is 40, it is upgraded to, let me say, 60, that is an increment of 20 points that is happening here. Now I will apply the 10:1 rule. For 10-point rise of carbon dioxide, bicarbonate should rise by 1 point. I want you to comment in the chat box. If carbon dioxide rises by 10 points, bicarbonate should rise by 1 point. If carbon dioxide rises by 20 points, तो bicarbonate को कितना पॉइंट बढ़ना चाहिए यहाँ पे? I'll repeat my question. If carbon dioxide 10:1 के रेशो पे इंक्रीज करती है, कार्बन डाइऑक्साइड 10 मिलीलीटर बढ़ती है, बाइकार्बोनेट 1 मिलीक्यूलेंट। If CO2 will rise by 20 point, bicarbonate will rise by how many points? Yes, only 2 points. So is mathematics of 10:1 rule is getting satisfied. If this rule is satisfied, we say compensation occurring in this particular patient. So the most important thing that I want you to remember is how do you differentiate in a respiratory acidosis component whether it is uncompensated, partially compensated, bicarbonate का value. आपको 10:1 का रूल याद ना भी हो चलेगा. अगर आपको 10:1 का रूल याद ना भी हो चलेगा, लेकिन आपको ये जरूर पकड़ना है कि नॉर्मल थी या राइज करना शुरू कर दी थी. वैल्यू याद कर लो तो अच्छी बात है, बट आई एम सेइंग अगर नॉर्मल थी तो अनकॉम्पेंसेटेड बोलना, और अगर वो बढ़ गई तो बोलना पार्शियली कॉम्पेंसेटेड. नाउ आई एम टेकिंग केयर ऑफ द सेम पेशेंट. सो 24 आवर्स के बाद मैंने एबीजी फिर से किया. After 24 hours, when I've done the ABG of the patient, thankfully, by the grace of God, the pH of the patient has turned normal. CO2 अभी भी बढ़ा हुआ है तो खतरा तो बना हुआ है. You know CO2 is an acidic molecule, it generates carbonic acid, so खतरा अभी भी है. His son told me, sir, will you send my father home? I said no. We will keep him in ICU for maybe 1 more day or at least in the hospital for 1 day. मेरा सर पीएच नॉर्मल हो गया ना डॉक्टर साहब, आप भेज दो घर पे. मैंने कहा नहीं यार, खतरा अभी भी बना हुआ है. CO2 आपके डैड का अभी भी बढ़ा हुआ है. थोड़ा पढ़ा लिखा था, समझदार था. कहता सर ये फिर पीएच नॉर्मल कैसे होगी? आप कहते हो खतरा है, कार्बन डाइऑक्साइड इज मोर, प्रोटॉन्स आर बीइंग जनरेटेड, देन हाउ ऑन अर्थ द पीएच बिकम नॉर्मल? योर रिपोर्ट इज रॉन्ग सर. आई सेड नो रिपोर्ट इज नॉट रॉन्ग बडी, द किडनी इज वर्किंग मोर देन नॉर्मल ना. किडनी कल से 24 घंटे से काम कर रही है, सो किडनी हैज कॉस्ट अ मोर राइज ऑफ बाइकार्बोनेट थैंक्स टू द सपोर्ट ऑफ द किडनी. Thanks to the support of kidney, this particular patient is alive and his pH has stabilized. अभी भी मैं रिपोर्ट में क्या लिखूंगा? रेस्पिरेटरी एसिडोसिस. इस पे बड़े सारे स्टूडेंट्स की क्वेरी होती है, अरे सर पीएच नॉर्मल हो गया, आपने कैसे लिख दिया रेस्पिरेटरी एसिडोसिस? क्योंकि PCO2 बढ़ा हुआ है, प्रोटॉन्स तो बन रहे हैं ना, वो तो मैथमेटिकल वैल्यू अपरेंटली नॉर्मल हो गई है. द पीएच वैल्यू हैज अपरेंटली टर्न्ड नॉर्मल, बट द CO2 ऑफ द गाय इज स्टिल सुपर एलिवेटेड. 50 इज नॉट अ नॉर्मल वैल्यू. प्रोटॉन्स आर स्टिल बीइंग जनरेटेड, बट द पीएच बिकेम अपरेंटली नॉर्मल थैंक्स टू द किडनी. Therefore the word I will write here is, क्योंकि pH नॉर्मल हो गया, the word I will write here is fully compensated respiratory acidosis. Guys, all of these questions would basically be revolving around these 3 words. Uncompensated when bicarbonate is normal. When the 10:1 rule is getting satisfied, I will say partially compensated. And when the kidney is working more and more and more and more, then I will say fully compensated respiratory acidosis occurring in a patient. In the exam, most of the time, he will not give you fully compensated. कि पूछेगा क्या भाई, pH नॉर्मल हो गया, CO2 बढ़ा हुआ है, तो वैसे ही बोल दोगे ना रेस्पिरेटरी प्रॉब्लम है, CO2 का बढ़ता है, रेस्पिरेटरी प्रॉब्लम है, और साथ में तो बता ही दोगे CO2 is acidic molecule, तो वैसे ही बता दोगे रेस्पिरेटरी एसिडोसिस. Most of the time in the question, they will ask you regarding whether, yeah, pH should be normal. Fully compensated is when the pH is normal. In most of the questions, they will be asking you regarding uncompensated versus partially compensated. If the pH of the patient turns out to be, if the pH of the patient is less, PCO2 is more, that is opposite respiratory problem. Check out the bicarbonate. अगर normal है तो uncompensated, बढ़ गया तो partially compensated. Now what I have done for you guys is कि मैंने तो आपके लिए easy already कर दिया. I would not want you to make any changes in the notes. I don't want you to scroll the notes. I just want you to stop doing whatever you are and just focus on the screen at the moment. I'm bringing that screen once again in front of you. I want you to look at respiratory acidosis question because COPD scenarios are given. The pH is less, PCO2 is normal. Don't make any modifications. Hear me out here. Suppose I say to you, the doctor at the moment, the bicarbonate of respiratory acidosis patient, you can see pH is less, PCO2 is more, respiratory acidosis, bicarbonate value is normal. Because bicarbonate is normal, hit the comment button. What would you like to say? Kidney saying रुको जरा, मदद करता हूँ भाई, 2 मिनट सांस तो लेने दे भाई, मैं तेरी मदद कर रहा हूँ, मैं तेरे साथ हूँ. Please hit the comment button. Would you like to write the word UC uncompensated or partially? Comment in the chat box, guys. Is it uncompensated or is it partially compensated? Yes, it is uncompensated because the kidney is saying, bro, I need some time, give me some breathing space, I will do job for you. Perfectly right, it is uncompensated. But if I will repeat the ABG of this patient after 1 hour, 2 hour, 3 hour, 4 hour, the kidney is having 3-4 hours is a good time. So after 3-4 hours, what will happen is कि kidney क्या करेगी, वो bicarbonate को बढ़ाना शुरू कर देगी, and when the bicarbonate values will begin to rise in the patient, this rise of bicarbonate in the body of this patient will help in stabilizing. And if this is the report given, I will prefix the word partially compensated respiratory acidosis. What I want you to now do is, for all of you, you have to note now, आपने जो टेबल बनाया है मेरे साथ में, मैंने आपको ऑलरेडी एक रेडीमेड सोल्यूशन दिया है. ऑल द एंट्रीज इन दिस टेबल आर दोज ऑफ पार्शियली कॉम्पेंसेटेड वैल्यूज. क्योंकि एग्जाम में या तो वो आपसे पूछेगा अनकॉम्पेंसेटेड या बोलेगा पार्शियली कॉम्पेंसेटेड. तो आपने सॉल्व कैसे करना है, अगर ये वैल्यूज, अगर ये रूल्स सेटिस्फाई हो जाएं तो आप बोल देना पार्शियली कॉम्पेंसेटेड फॉर एनी ऑफ द सिनेरियोज दैट यू वर्क आउट इन द क्वेश्चन. So I will make you do more mathematical examples. If these rules are satisfied, to decrease the load in the exam, because in exam I have 30 seconds, sometimes even lesser than that, sometimes he might be ABG interpretation may not be a part of it, it may be a part of the diagnostic algorithm. So you are having 15 to 30 seconds to solve. So what will you do? If they give you a question in which all three values are less, pH, PCO2, all three less, you will say partially compensated metabolic acidosis. If they give you the report that I discussed right now for respiratory acidosis, obviously you would be able to work out the data. Now, I want you to again pause, not the video, pause doing whatever you are and hear me out again. No activity, no noting at the moment. I hope everybody has discussed at the moment. देखो यार, मैंने पहले ही बोला था, अभी लाइक यू नो आप बीच में फ्लो डिस्टर्ब करोगे कोई मतलब नहीं है. मैंने बोला ना मिक्स डिसऑर्डर्स नीट पीजी के लिए आगे डिस्कस होंगे ना यार, मैंने बोला तो था अभी, राइट. ओके, नाउ कमिंग बैक टू द एजेंडा. इन मेटाबॉलिक एसिडोसिस इन अ पेशेंट देयर विल ऑलवेज बी कुस्मॉल ब्रीदिंग. बाय डिफॉल्ट metabolic acidosis is a scenario where there will be a Kussmaul breathing in a patient. Kussmaul breathing will cause hyperventilation. Hyperventilation, CO2 washout will be occurring from the body. I would like to modify the report. Don't modify, just look at the report here. The modification is, suppose I give you a question where pH is less, so you will know it is acidosis. Bicarbonate is low, it is acidosis, which is metabolic acidosis only. Can't be respiratory because for respiratory CO2 is more. If you look at the first entry that I have just modified, the interpretation is metabolic acidosis, but अभी lungs ने hyperventilation start नहीं करी है. Lungs are saying रुको जरा, कुछ 2 मिनट का सांस दो मुझे, अभी करता हूँ, एकदम से नहीं कर पाऊंगा बॉस, मुझे थोड़ा सा टाइम दे दो. I want everybody to comment in the chat box if this report is given, which I'm marking at the moment before you, ये metabolic acidosis वाली जिसमें Kussmaul breathing start नहीं हुई है, CO2 is normal. What would you like to say? Is it uncompensated or partially compensated? I want to check out your reflexes. Very good. Pyali, Shreyash, everybody. Yes, it would be uncompensated scenario that would be worked out in that particular case. So at the moment lungs have not started working. But इसी पेशेंट में अगर 1 घंटे के बाद में, suppose after the end of 1 hour, if I will repeat the ABG again, I will restore status quo. जब वो आदमी तेज तेज सांस लेगा तो कुस्मॉल ब्रीदिंग की वजह से कार्बन डाइऑक्साइड निकल जाएगी. And this is the report that is given to you that all three are less. Now it will become what is already on the slide, partially compensated metabolic acidosis. मैंने अभी 2 एसिडोसिस को हैंडल किया है. I've handled only 2, respiratory and metabolic. What I've said is in respiratory acidosis, to evaluate uncompensated and partially compensated, check out the bicarbonate value. The kidney is supposed to work. And in metabolic acidosis, it is the lungs that are supposed to work. The lungs are supposed to work much more than normal. That is Kussmaul breathing, acidotic hyperventilation as you call it, and the CO2 washout would be happening. So at this moment, I've tried to touch on phase 1 of this particular discussion. That is specifically, this report should never go wrong, guys. Uncompensated respiratory acidosis and partially compensated respiratory acidosis, and the usual trigger for this condition is acute exacerbation of COPD, or instead of acute exacerbation of COPD, he will be mentioning regarding status asthmaticus. 2 critically grave sick patients of respiratory system with rising CO2 is what I'm describing at the moment before you. So I would like to at this particular moment also ask you, what will be the treatment for these patients who are having acute exacerbation of COPD? How do you treat the respiratory acidosis? How will you remove this extra carbon dioxide from the body? Can I have quick answers, please? This is the usual reports for these 2 particular patients. I'm waiting for your answer for what is the treatment for acute exacerbation of chronic obstructive pulmonary disease. treatment or choice? Yes, guys. The main treatment for acute exacerbation of COPD will be, you will be putting the patient on NIV, that is non-invasive ventilation. You will be using a BiPAP machine, and by which you will be able to remove carbon dioxide from the body. Three indications for non-invasive ventilation that I have said earlier, and I'm repeating at the moment, are to never be forgotten: A, B, and C. Alphabet A will stand for acute heart failure and acute pulmonary edema. When I was teaching you acute heart failure, I was saying BiPAP machine will be used, and that will stabilize the status of the patient. Then is right now chronic bronchitis, acute exacerbation. The acute word is because obviously the patient is sick. So acute exacerbation of chronic bronchitis, or you may not write chronic bronchitis, you may write COPD as well. And as far as C is concerned, that is COVID-19. The last time you would have seen, like, NIV in the wards, in the newspapers, everywhere, that would be COVID-19 pneumonia of the severe variety. Like pneumonia is also having grading for COVID, though COVID is not valid anymore, but still for historical reasons, severe COVID-19 ABC non-invasive ventilation was being used. On the basis of this information, I would now like to move on to the next part of our discussion, which is scenario number 1. In this particular scenario, the pH of the patient is 7.2 and PCO2 is 25. Both are listless. Both arrows are going in same direction. If both arrows will go in same direction, the first word that you will deduce for this person will be metabolic. You first look at pH, then look at PCO2, so it is metabolic. You can also check out that in this patient, the value of bicarbonate is low. So this means that the person is having metabolic acidosis. The interpretation at this moment is this is metabolic acidosis. You guys are also commenting very rightly that the guy is having small breathing, obviously, because I have already sensitized you to the fact that the CO2 of the patient is working out, and therefore I need to figure out that is this a compensatory disorder or not. Though initially I told you a rule by which you are able to work out, because CO2 is lesser, so obviously CO2 lesser will be because of compensation, that is like the hyperventilation that is occurring. But actually you see there is a rule that is to be remembered called as Winter's formula. कैसे पता लगाते हैं कि कॉम्पेंसेशन हो भी रहा है कि नहीं? अभी तो मैंने बोला था ना कि भाई CO2 कम हो गया तो कॉम्पेंसेशन हो गया, वो तो एक सिंपल तरीका था समझने का कि कॉम्पेंसेशन क्या होती है, लेकिन एक्चुअली में आप सबका आंसर सही है. एवरीबडी हुज आंसर्ड दिस करेक्टली एट द मोमेंट, यू आर सेइंग वेरी राइटली दिस इज पार्शियली कॉम्पेंसेटेड मेटाबॉलिक एसिडोसिस, परफेक्टली ओके. बट इफ यू आर लाइक अ नीट पीजी एस्पिरेंट और इनिस्टेट एस्पिरेंट, you need to listen to me with more care. FMG aspirants, you are all right, partially compensated metabolic acidosis, perfectly right interpretation. But specifically for those situations where, like, NEET PG questions are gonna be there, they're gonna be slightly tricky, तो आपको अब mathematical rule को सुनना है. So NEET PG aspirants, इनिशिएट aspirants, be ultra careful at this moment. आपने करना क्या होता है, मेटाबॉलिक एसिडोसिस तो निकाल ही लोगे, ऑल 3 arrows गोइंग डाउन डाउन डाउन. आपने उसके बाद में अपने माइंड में कैलकुलेशन करनी होती है, जिसको बोलते हैं मॉडिफाइड विंटर फॉर्मूला. In modified Winter's formula, expected PCO2 is to be calculated. Expected PCO2. How will you calculate the expected PCO2? You will be adding 15 to the value of the bicarbonate that is given in the question. जैसे इस particular question में bicarbonate की जो value दे रखी है वो है 10, और अगर 10 में आप 15 ऐड करते हो तो जो वैल्यू निकल के आती है वो है 25 मिलीमीटर ऑफ मर्करी, विच इज परफेक्टली मैचिंग विद द एक्चुअल PCO2 ऑफ द पेशेंट. जो एक्चुअल वैल्यू है PCO2 की, ह्यूमन बॉडी ऑपरेट्स ऑन प्योर मैथमेटिक्स. The actual PCO2 of the patient and the expected PCO2 of the patient is matching if both values are matching. अगर expected PCO2 की जो mathematical value अपने formula से calculate करी है, what is the formula? Bicarbonate plus 15. This is a formula for working out whether compensation is there or mixed disorder there. Differentiate कैसे करते हैं? This formula is used, and if the values will do matching, expected and the actual values of PCO2 are matching, you will say yes, it is compensation. This is compensation that is working. This is not a mixed disorder, and therefore I have revalidated that my patient is having partially compensated metabolic acidosis. पहले तो मैंने बोल ही दिया था कि यार वो तो एक अनऑफिशियल तरीका था आपको समझाने का कि दिस इज partially compensated metabolic acidosis, but at this moment I wanted to re-emphasize on you that what is the mathematical rule that operates in this particular case. The mathematical rule is expected, the mathematical
mathematical rule is modified Winters formula, and this is partially compensated metabolic acidosis. Perfectly spot on and correct. इफ यू आर एन एफएमजी स्टूडेंट तो आपने ये कैलकुलेशन में नहीं जाना है, आपने वो जो रूल्स मैंने बताए उतना कर लो, दैट इज मोर देन सफिशिएंट। वो सिंपल बोलता है मेटाबॉलिक एसिडोसिस, एल्कोलोसिस, वो मिक्स्ड डिसऑर्डर में नहीं जाता। बट इन नीट पीजी क्वेश्चंस व्हाट ही विल डू इज दैट ऑब्वियसली बिकॉज इट्स अ मेरिट बेस्ड क्वेश्चन जिसमें वो आपको रैंक दे रहा है, राइट, एवरीबडी इज ऑफ द सेम कैलिबर। नाउ इट इज लाइक आपका दिमाग उस टाइम पे कितना चला इज गोना डिसाइड लाइक योर फेट ना। वन क्वेश्चन रॉन्ग 1000 रैंक गिर जाती नीचे। 10 क्वेश्चन का खेल है सर, 10 क्वेश्चन सही हो गए, आपका रैंक जो है वो 10,000, और उसके बाद में तो मतलब देखो टॉप 1000 का ना आईक्यू लेवल सेम सेम सा होता है। इफ इट इज योर डे तो आप 5000 में जाओगे, इफ इट्स रियली योर लकी डे देन यू गोइंग टू टॉप 1000। उसमें 3-4 एमसीक्यूज का डिफरेंस होता है, आप रैंकिंग देख लेना, राइट, यू नोटिस एवरीबडी इज ऑलमोस्ट एट द सेम स्कोर, और 100 नंबर में तो गेम ही खत्म हो जाती है, सिलेक्शन गेट्स ओवर, राइट। सो फॉर दैट कॉम्पिटिटिव एनवायरमेंट, नाउ what I'm going to discuss before you is a question of NEET PG that is coming up on the screen at the moment. That is scenario number 1.1. This is a NEET PG MCQ that I'm describing at the moment, where मैं स्टूडेंट से बोला कि सर वो pH was less, PCO2 was also less, bicarbonate was less, तो आपने बोला था कि तीनों लेस हो जाए तो मेटाबॉलिक एसिडोसिस है। एंड मैंने क्वेश्चन में मार्क करने लगा पार्शियली कॉम्पेंसेटेड मेटाबॉलिक एसिडोसिस, लेकिन मैं 1 सेकंड के लिए रुक गया। निकला क्यों रुका? कह रहा सर मैं इसलिए रुक गया क्योंकि आपने बोला था कि फार्मूला लगाना होता है, दैट इज मॉडिफाइड विंटर्स फार्मूला, तो इसलिए मैं मॉडिफाइड विंटर्स फार्मूला लगाया। मैं कहा अच्छा ठीक है, बता क्या क्या वैल्यूज थी। सो दिस गाय ही गॉट अ वेरी डिसेंट रैंक, लाइक ही वाज डिस्कसिंग द पेपर विद मी आफ्टर लाइक द पेपर वाज कंडक्टेड। क्वेश्चंस तो नॉन डिस्क्लोजर होता है तो सारे तो डिस्कस नहीं कर सकते है ना, ओपन है न्यूज पेपर रूटीन में यार, फोन पे तो डिस्कस कर ही सकते हैं ना, मतलब तो ठीक है कि एनडीए होता है, नॉन डिस्क्लोजर होता है, बट क्लोज लोगों में, फ्रेंड्स में तो डिस्कस करोगे ना यार ये क्वेश्चन आया था मेरा गलत हुआ या सही हुआ, है ना। ये अपने मेंटर से तो डिस्कस करोगे ना कि बॉस मैं ये क्वेश्चन करके आया, सही है या नहीं है। ओके, सो यहाँ पे अब मैंने फॉर्मूला लगाया। सो दिस गाय स्टूडेंट ऑफ माइन, वो कहता है सर ऑल वैल्यूज वर लेस लेस लेस। सो आई थॉट कि मैं बोल दूं पार्शियली कॉम्पेंसेटेड मेटाबॉलिक एसिडोसिस खत्म। फिर कहता सर मेरा जस्ट एक अलार्म बेल सी बजी कि आपने बोला था कि फॉर्मूला जरूर लगाना है, उसके बिना नहीं करना है, तो मैंने वो फॉर्मूला लगा लिया और मैं बच गया। तो आई रियलाइज कि हाँ ये ठीक करके आया। तो in this particular question the formula is that to the value bicarbonate you would need to add 15। अब इसकी bicarbonate 10 और वैल्यू ऐड करी 15, तो जो निकला एक्सपेक्टेड PCO2 वो है 25 मिलीमीटर मर्करी, एंड सैडली इट इज नॉट मैचिंग विद द एक्चुअल PCO2 वैल्यू। यू कैन नोटिस एक्चुअल PCO2 वैल्यू तो 30 है। आई टोल्ड यू ह्यूमन बॉडी ऑपरेट्स ऑन प्योर मैथमेटिक्स। नाउ दैट मैथमेटिक्स इज नॉट गेटिंग सेटिस्फाइड, उसका डायफ्राम जो है ना, डायफ्राम को कार्बन डाइऑक्साइड, डायफ्राम को कितनी मेहनत करनी थी तब तक कि कार्बन डाइऑक्साइड 25 ना हो जाए, तब हम बोलेंगे कॉम्पेंसेशन इज वर्किंग, बट नाउ द डायफ्राम कुड नॉट वर्क। Why the diaphragm did not work? Probably hypokalemia, because in diabetic ketoacidosis patient is vomiting, so अगर पोटेशियम की कमी होगी तो डायफ्राम मेहनत नहीं कर पाएगा। That is why the PCO2 is higher than what it should have been. Let me write down the data here. In this particular question, the values are not matching. Now it's not 25, it is like 30 and 25. The actual PCO2 of the patient is more than the expected PCO2 of the patient. I'll use a black color for expected, so just give me a second. The actual PCO2 of the patient is more than the expected PCO2 of the patient, because the values are not matching. Now you will say the guy is having a mixed disorder. What I mean by mixed disorder is because the PCO2 is higher, you will say person is having respiratory acidosis, and the moment I say that, the comment box got filled up कि sir respiratory acidosis कैसे हो गया, PCO2 should be more than 45। यार मैं कोई प्राइमरी चेंज की बात नहीं कर रहा हूँ। I want you to understand in this patient the diaphragm ने मेहनत नहीं करी, so PCO2 value is higher than what it should be, because I said higher, that means it is generating protons, and therefore this is two types of acidosis in a patient. This is a question on mixed disorder, that is respiratory acidosis and metabolic acidosis. This is not a question of partially compensated metabolic acidosis. So you can see that the values have to match ideally for that scenario of compensation. If the values don't match, you say okay, this is a mixed disorder. Now when I describe this, I'm usually met with unbelief. द क्वेरी ऑफ स्टूडेंट्स इज ठीक है सर, आप कह रहे हो तो हम आपकी इज्जत करते हैं, तो सही कह रहे होगे, है ना, गलत कैसे हो जाएगा? पर सर समझ नहीं आया सर, ऐसे कैसे हो गया सर जी कि देयर आर टू टाइप्स ऑफ एसिडोसिस? सो हियर मी आउट फॉर वन मोर मिनट एंड यू विल अंडरस्टैंड हाउ ऑन अर्थ इज इट पॉसिबल। आई विल एक्सप्लेन टू यू नेक्स्ट 1 मिनट हाउ ऑन अर्थ इज इट पॉसिबल कि एक आदमी को दो दो प्रकार का एसिडोसिस हो सकता है। राइट नाउ कोड ब्लू, राइट नाउ यू वर इन द वर्ड, यू वर द इंटर्न, अब आप दोपहर का टाइम हो गया, आपको घर जाने का टाइम हो गया, अनफॉर्चुनेटली एक पेशेंट कोलैप्स कर गया, तो यू डिसाइडेड टू स्टे बैक। अ पेशेंट इज राइट नाउ गॉन इनटू कार्डियो रेस्पिरेटरी अरेस्ट, एंड बिकॉज द कार्डियक अरेस्ट हो जाता है तो पेशेंट विल गो इनटू सर्कुलेटरी फेलियर, एंड बिकॉज द पर्सन विल गो इनटू शॉक, द हार्ट इज ऑब्वियसली नॉट वर्किंग। If person will go into shock, then the cells will not get oxygen and they will switch to anaerobic mode of respiration. Lactic acid will be produced. I want to say that if somebody will go into cardiac arrest right now, right here, then cardiac arrest will trigger metabolic acidosis क्योंकि circulation zero हो जाती है. If you don't get oxygen to the tissues, there would be bicarbonate generation that will cause metabolic acidosis in a patient. What is the compensation of metabolic acidosis? Please, everybody comment in the chat box. What is the compensation of metabolic acidosis? Yes, guys, can I have quick answers here? The guy is gone into cardiorespiratory arrest. The heart is not working, the lungs are not working. What is the compensation of metabolic acidosis? It is respiratory alkalosis, the compensation. But यहाँ पे compensation हो ही नहीं सकती है. The guy is in respiratory arrest. सोच के देखो, अगर किसी को respiratory arrest है तो क्या वो तेज तेज सांस ले पाएगा? Can the patient do small breathing? Can any patient who's having respiratory arrest, diaphragmatic arrest, do small breathing? No. If the guy will have respiratory arrest, what will happen? CO2 in the body will rise. And when CO2 in the body will rise, it will cause bicarbonate being produced, H2CO3 being produced, and that will cause protons in excess. And therefore, क्योंकि अब सांस नहीं लेगा, CO2 बन गया, hydrogen बन गया, the person will be developing respiratory acidosis. Guys, I hope I've been successful in explaining to you that in cardiorespiratory arrest, you cannot have compensation. In cardiorespiratory arrest, you cannot have compensation. If a compensation will occur in people like you and me जिनका सांस चल रहा है. If a person is on a deathbed, then you will be having two types of acidosis in a patient. You can have metabolic acidosis also, and you will be having respiratory acidosis also. This is obviously a mixed disorder that I've currently explained to you. I've tried to give rationale why in the above ABG the values were not matching because the guy is going into respiratory arrest. एकदम से तो देखो कई बार सांस नहीं रुकती है ना, गैस्पिंग रेस्पिरेशन होती है, आपने देखा होगा ना, टर्मिनल ब्रीदिंग होती है. The terminal breathing is उखड़ी उखड़ी सांसें आना, and then the person goes into, like, lots of time you will notice that person will start having bradycardia, तो heart slow होता जाएगा. It's not that always a straight line. It becomes bradycardia, then a cardiac arrest. It becomes terminal breathing and then a apnea. So while the person is dying, जब आप ABG कर रहे हो, a dying person's body cannot compensate and you will have a mixed disorder present, that is metabolic acidosis with respiratory acidosis. This is the reason for the above report. This is a critically sick patient. And that is why in your NEET PG उसने ये क्वेश्चन दिया जिसमें मेरा स्टूडेंट ने बोला कि सर तीनों लेस थे, मैं आंसर करने वाला था पार्शियली कॉम्पेंसेटेड मेटाबॉलिक एसिडोसिस, जो आपने बोला था कि वो इंटरप्रिटेशन है, पर अभी मैंने एक एडिशनल पॉइंट बोला है कि अगर आप NEET PG या इनिसेट एस्पिरेंट है तो बिफोर यू मार्क ऑन दैट वर्ड पार्शियली कॉम्पेंसेटेड मेटाबॉलिक एसिडोसिस, अप्लाई मैथमेटिकल रूल. If the values will match, you will say compensation. But if actual PCO2 of the patient, if the actual PCO2 of the patient is relatively more, then we will say expected PCO2 से ज़्यादा है, then we will say it is a mixed disorder in the patient. आपने बोला metabolic acidosis is there. Why metabolic acidosis there? Cardiac arrest में circulatory failure, सांस नहीं चल रहा, हार्ट भी नहीं चल रहा. If you are not gonna be breathing and you are not gonna be having oxygen in the body, the heart will also suffer ventricular fibrillation ना. Suppose somebody is not breathing, respiratory arrest हो गया उसको जिस भी रीजन से, ड्रग ओवरडोसेज मान लो, किसी भी रीजन से हो गया. If oxygen is not there, the heart will go into arrhythmia. If heart will not work, circulatory failure. Shock causes always acidosis, no? If cells will not get oxygen, how will they survive? Anaerobic mode of respiration, and that anaerobic mode of respiration will cause metabolic acidosis to occur in a patient. So at the moment, the data is with respect to this particular report that I have currently described here before you of a mixed disorder, that is scenario number 1.1 at the moment. Now, yeah, absolutely. Lavesh, you said CO2 value is normal here. So how to say respiratory acidosis in a patient? That's the point I'm trying to tell you. मैंने आपने सुना ही नहीं मेरे को, रिवाइंड करके सुनना दोबारा से, लाइव क्लास में दोबारा नहीं बताता हूँ, फेस टू फेस क्लास में नहीं बताता, ये तो रिकॉर्डेड है ना, तो आई कैन सी योर कमेंट, तो इस वजह से मैं जवाब दे रहा हूँ. रूटीन वी डोंट डिस्कस दिस अगेन. सर यू डिड नॉट लिसन टू मी केयरफुली. मैंने बोला CO2 इज हायर. आई डिड नॉट से, मैंने पॉइंट यही बोला था कि सबसे पहले आप क्या बोलोगे, सर रेस्पिरेटरी में तो PCO2 शुड बी मोर देन 45, ये तो 30 LS है, फिर भी रेस्पिरेटरी एसिडोसिस बोल रहे हो. हाँ जी, क्यों बोल रहे हैं? बिकॉज डायफ्राम डिड नॉट वर्क एफिशिएंटली. If diaphragm will not work, respiratory problem, and did not work efficiently, so protons are still be oxed in the patient. So the point to be understood is respiratory acidosis is in a relative sense in a patient. इसको actually में respiratory acidosis क्यों बोल रहे हैं? क्योंकि CO2 की वैल्यू 30 है, होनी कितनी चाहिए थी? 25. तो ज्यादा है ना, 5 पॉइंट ज्यादा है, तो 5 पॉइंट ज्यादा से प्रोटॉन्स बनाएगी, उसकी वजह से respiratory acidosis बोलेंगे इसको. So this is a NEET PG question that I currently discussed for scenario 1.1 at this moment before you. Definitely optional. ऊपर वाला नहीं मिस करना. This is obviously the routine scenario, partially compensated metabolic acidosis where there's a respiratory alkalosis and small breathing, and mathematics is being satisfied. Mathematics is being satisfied. Okay, ji. No, you skip that for FMG exam. Let's do one more. Again, scenario number 1.2 in red. So not to be worked out for FMG exam, but yeah, for remaining guys, let's do it once again. I don't think so for this particular question. Partially compensated metabolic acidosis is 1.0 वाली जो रिपोर्ट है वो partially compensated. प्रणब अपने PDF में ऊपर मूव करो तो वो partially compensated वाली metabolic acidosis. 1.1 is the mixed disorder. Okay. Now is 7.1, 16 and 6. All three values are less. Yes, respiratory acidosis is relative. That's the point. All three values are less. So again, I will say patient is having metabolic acidosis. All three values are less. So this is again metabolic acidosis in the patient. Now you need to pick up in your mind that is it a mixed disorder or is it a compensation disorder? So once again, I will write how in few seconds are supposed to work out compensation versus mixed disorder. You will once again apply the modified Winters formula. In modified Winters formula, you will be doing the same activity as I did earlier. 15 add kar dena to the value of bicarbonate. Expected PCO to the patient is bicarbonate plus 15. This time the value of bicarbonate is 6. So the expected PCO2 is turning out to be, mathematics is 21 milliequivalents. The values are not matching at the moment. The values are not matching. Yes, 21 millimeter of mercury. Now comes the core issue. In this particular case, the expected PCO2 of the patient or actual PCO2 को mathematically compare करना है. Expected PCO2 को और actual PCO2 को compare करना है. The expected PCO2 of the patient should be 21. Expected PCO2 the value is 21. It is more than the actual PCO2 of the patient. पिछली बार तो उल्टा हो रहा था ना, देखो जरा. I'll move my slide. Last time it was actual value that was more. Actual was 30 and calculated was 25. 30 and 25, that is actual was more than the expected. But in this particular patient, it is expected value which is more than the actual PCO2 of the patient. That means compensation normal से ज़्यादा हो गई है, वो तो अच्छी बात है ना. It is overcompensation. Very good, Khan Nida. You're spot on. It is good. I am happy if the body is doing more compensation. If body is doing less compensation, stress. Say respiratory acidosis. In this particular patient, what will happen is that the guy's body is doing a extra hyperventilation. So please hit in the comment button. What would you like to answer for this question? Is it a mixed disorder? Or is that compensation? I have already given the hint. Some people have already commented. Would you like to say mixed disorder or would you like to say compensation, that is overcompensation? Yes, it is a overcompensation that is occurring in a patient. So this particular report is compensation. Yes, this is a compensation that is occurring in this patient. Very good, guys. This is overcompensation that is occurring. So the final interpretation in this question is this report is also of partially compensated metabolic acidosis. चाहे आप लिखो पार्शियली कॉम्पेंसेटेड मेटाबॉलिक एसिडोसिस, फिर से लिख रहा हूं, चाहे आप लिखो पार्शियली कॉम्पेंसेटेड मेटाबॉलिक एसिडोसिस या मैं ऐसे लिख दूं मेटाबॉलिक एसिडोसिस विद कॉम्पेंसेटेड ऑब्वियसली अगर बहुत इजी करना है तो ऐसे लिख देगा विद कॉम्पेंसेटरी the word written will be metabolic acidosis with compensatory respiratory alkalosis. इंग्लिश लगा के उल्टा ही तो करना होता है कॉम्पेंसेशन वाले को, उसमें तो कोई बिग डील है नहीं है, ये दोनों का मतलब एक साथ ही है, both of them basically mean the same. The final issue that I hope I've been able to explain to you, and I will write it here. In all questions of metabolic acidosis, what are you supposed to do? In all questions of metabolic acidosis, आपने modified Winters formula लगाना है. What is modified Winters formula? The mathematical value is being practiced once again. बाइकार्बोनेट की वैल्यू में 15 जोड़ देना और जो निकलेगा इसको बोलते हैं expected PCO2. Now, if the expected PCO2 और actual PCO2 की वैल्यू इक्वल आती है, if expected PCO2 और actual PCO2 की वैल्यू इक्वल आती है तो बोलेंगे compensation is working. If the expected PCO2 को जो वैल्यू है, जैसे कि इस क्वेश्चन में हुआ कि जो expected PCO2 की वैल्यू है that is more than the actual PCO2. actual PCO2 तो जो निकला था वो जो था, मैं actual फिर से दिखा देता हूँ. The actual of this patient was only 16, right? And the expected that you had calculated was 21. So you can see a huge difference which is occurring here. So if this value that is expected is equal to or more, you say that the person is suffering from compensation. But if in a question you work out that the actual PCO2, जो मैंने 30 वाला एग्जांपल देके बोला था उसको फिर से लिख रहा हूँ. If you work out in a question that the actual PCO2 of the patient जो कि आपने निकाला था that was higher than the expected PCO2 of the patient, then you will say it is a mixed disorder in the patient. This is the basic rule that I want you to remember. Obviously जब आप इसको दोबारा से करोगे, दोबारा से सुनोगे तो things will become relatively better. But this data that I've highlighted 1.1 and 1.2 is only for NEET PG and INISET aspirants. If you're an FMG aspirant, you just need to follow the basic table that I mentioned. And obviously इसके बाद जो बोलूँगा that will be uniform for both kind of exams. But specifically metabolic acidosis questions where they expect you to calculate on the basis of जो traditional winter formula होता है ना, उसका मैं formula लिख रहा हूँ. आप अगर उससे भी करोगे, जैसे बहुत सारी जो apps है ना वो आपको मॉडिफाइड विंटर फार्मूला से करवाएंगे. मैं इसलिए बोल रहा हूँ क्योंकि आप बोलोगे सर आपने बताया नहीं था, हमें पता नहीं था, तो इसलिए मैं अभी से क्लैरिफाई कर रहा हूँ कि जो एप्स वाली कैलकुलेशन है ना वो इस तरीके से 1.5 इंटू बाइकार्बोनेट प्लस 8 प्लस माइनस 2. तो यार मेरी तो मैथ्स कमजोर है, अगर आप मुझे बोलो 30 सेकंड में पहले मल्टीप्लाई कर, फिर ऐड कर, फिर सब्ट्रैक्ट प्लस माइनस कर, तो मैं तो मतलब आई विल लूज इट, राइट. मैं बोलूँगा भाई नहीं हो सकता, मैं छोड़ दूंगा क्वेश्चन को. सो इनिशियली व्हेन आई वाज अ स्टूडेंट आई यूज्ड टू यूज this typical Winters formula. Never worked out for me. So I mean apps are given an explanation, so I will leave this on the board. I leave it on the board. But in my opinion, just to one step addition. Matching in a patient, then you will say na, obviously वो तो relative sense में ना, partially compensated, or when I say the word overcompensated, that is okay. Overcompensated कोई word नहीं होता, ओवर कॉम्पेंसेट नहीं होता, वो तो हमने बनाया था समझने के लिए. अवर के लिए इट्स ऑलवेज पार्शियल कॉम्पेंसेशन ओनली. पीएच बिकम्स नॉर्मल फुली कॉम्पेंसेटेड. पीएच बिकम्स नॉर्मल फुली कॉम्पेंसेटेड. प्रणव आपने जो पॉइंट बोला ना उसके लिए मैं ये बोलूंगा कि भाई देखो, अगर तो ये ओवर कॉम्पेंसेटेड कोई वर्ड नहीं होता, इधर इट इज कॉम्पेंसेशन, और कॉम्पेंसेशन हमेशा कैसी होती है, पीसी वाली, पार्शियली कॉम्पेंसेटेड. फुली कॉम्पेंसेटेड में पीएच नॉर्मल हो जाता है पेशेंट. तो अल्टीमेटली याद ये करना है कि अगर आपने विंटर्स फॉर्मूला लगाया और जो वैल्यू निकल के आती है एक्चुअल PCO2 वो एक्सपेक्टेड से ऊपर आती है तो मिक्स्ड आंसर करके आना. आई इन्वेस्टेड टाइम इनटू 1.1 एंड 1.2 स्पेसिफिकली गाइस. मैंने इस पे मैथमेटिक्स पे वर्कअप किया है बिकॉज दिस इज व्हाट दे आस्क इन नीट पीजी इन इनिसेट एग्जाम. एंड नाउ वी आर गोना टेक इट अ लिटिल इजी एंड लेट्स लुक एट अ कपल ऑफ क्वेश्चंस. Compensation, there is an increase in breathing, CO2 gets washed out. Okay, patient comes with breathe. No, yes, I will say body will never overcompensate. Body will follow only, like हम वेंटिलेटर पे डाल देते हैं ना, तो वेंटिलेटर की वजह से ओवर कॉम्पेंसेशन हो गया. डॉक्टर नेता आपका डाउट आई कुड नॉट रियली फॉलो अप, सो मे बी ड्रॉपिंग अ yes, it never overshoots the normal pH. Overcompensation never happens. We put the patient on ventilator, na? We do bagging of the patient. That causes that that PCO2 values to become lesser. Chalo guys, let's do a questionnaire. Everybody on the same page with me. pH is less, PCO2 is elevated, so it's going opposite. 10:1 rule to be applied here. For metabolic acidosis, it is bicarbonate plus 15. Here 10:1 rule to be applied. You can see that this is a question of respiratory acidosis as applied already. And because bicarbonate is beginning to rise, that means thankfully it is trying to work. The kidneys are trying to work. They're trying to bring bicarbonate back to normal. Yes, guys, I'm waiting for more people. Is it uncompensated? Or have the kidneys started working? Exactly. The kidneys have started working in this case. So this is partially अगर यार यहाँ पे bicarbonate normal होता तो मैं uncompensated बोल देता. The kidneys have started working in this case, so the word would be partially compensated respiratory acidosis in this acute exacerbation of chronic bronchitis. The PO2 of the patient at the moment is doing 90, so that means saturation wise, oxygen wise, he is doing fine. Problem in this patient is mainly the CO2 value, and this causes carbon dioxide narcosis. That is why I was emphasizing that CO2 is like a toxic gas. It can cause asterixis. It can cause unconsciousness. It can cause metabolic encephalopathy in a patient. The words to be remembered at this moment is, it is not oxygen saturation that is dropping which is the concern of this patient. It is the buildup of carbon dioxide which is the cause of this particular patient. Yeah, if it is 27, I will still be saying it is partially compensated. If it is 26, I'll say uncompensated. It's a dynamic phase, na? I measured it after a few hours. If I measured it at 1.5 hour, it will be 27. Then if 1.5 hour ago, it might be 26.5. It keeps on changing. It's at a static point that you're seeing, na? That is why you compare two ABGs. In real practice, we don't rely and diagnose on basis of a single ABG report. It's a multiple ABG reports that we analyze. But if I give me a single cross-sectional view, then yeah, if somebody said bicarbonate is 27, I'll still say partial compensation on. If it is normal, that means compensation are not started in a patient. At this moment, my question to you guys is, because a patient of COPD has gone into this kind of an exacerbation and is deteriorating, this guy should not have deteriorated. So my question to you guys is, what buffer should I have been starting this patient on so that this patient does not deteriorate? Like, I would have liked to put this guy already on long acting beta 2 agonist LABA, and that would have ensured that the airways remained open and therefore carbon dioxide would not have accumulated. So can you tell me from your knowledge of pharmacology, longest acting beta 2 agonist? Can you tell me the longest acting beta 2 agonist? Which beta 2 agonist will work for 24 hours? Option चाहिए, salbutamol, salmeterol, formoterol, इतने सारे हैं ना, indacaterol. Yes guys, which is gonna work for 24 hours? Yes, more people please. Longest acting beta 2 agonist is indacaterol. The longest acting beta 2 agonist is indacaterol. So ideally this patient should have been put on LABA as well as LAMA, and had this patient been on these medicines with compliance, chances of him deteriorating would have been relatively lesser. Obviously viral infections cause issue, but then indacaterol is perfectly spot on. No बच्चा यशिका, it is not formoterol, वो तो 12 घंटे असर करते हैं ना. Indacaterol is 24 घंटे असर करने वाली. So you need to remember the indacaterol. LAMA का नाम बताइए please, commonest LAMA that would be prescribed to this patient. Yes, the answer is indacaterol, man. For the longest acting, there are obviously so many beta blockers, there's so many beta 2 agonists. No? The LAMA that should be given in this patient is, the LAMA that we should be giving in this patient is tiotropium. Salmeterol 8 घंटे असर करता है यार. Salmeterol is gonna be working for 8 hours only. So it is LABA, LAMA and inhaled corticosteroids that should be used in this patient so that we can prevent deterioration. Apart from this, long-term oxygen therapy also I will be working out or will be discussing with you separately. But this patient was non-compliant. Most patients are not very regular with their medications. We will talk about gold classification in the later part of the discussion today, but I wanted to give you a reason. Yeah, I will teach you LTOT also when the time comes, but at this moment I wanted to explain that these patients are non-compliant with medication, plus they have recurrent respiratory tract infections, so they can deteriorate, and therefore you need to remove carbon dioxide from the body. How do you remove carbon dioxide from the body? Right in front of you. You will be using a tight fitting face mask. Non-invasive ventilation is the main management for this guy having respiratory acidosis, which is partially compensated. Either I will say respiratory acidosis, or I will say respiratory acidosis with compensatory metabolic alkalosis. But then the point is, main aspect is that bicarbonate was rising thankfully, and that it tells me that it's a partially compensated one. Can you tell me contraindications to non-invasive ventilation? Can you tell me contraindications to non-invasive ventilation? Yeah, target SpO2 should always be kept. We want residual hypoxia. So LTOT I'll touch upon separately. Unconscious. Exactly. If the person is unconscious, then don't answer. Then answer intubation. If the person is unconscious, unresponsive, then do not answer tight fitting face mask, because you can understand if the person is unconscious, unresponsive, he will vomit, then everything will go in the lungs of this patient. So unconscious, unresponsive, comatose, I would not like to go ahead with this. Then is like maxillofacial trauma, then is hemodynamic instability. For hemodynamic instability, he can mention cardiogenic shock, he can say post-MI patient, he can mention extensive GI bleeding. Like this is a known case of peptic ulcer disease. He had extensive GI bleeding and now the BP is unrecordable. So obviously the patient will not be in senses. And then obviously, like if it is very severe maxillofacial trauma, then in maxillofacial trauma also, like non-invasive ventilation is the one that would be like, not used in a patient. So contraindications to non-invasive ventilation, specifically point number 1 is what is to be remembered. So you will get questions in which he will give pH, PCO2 opposite, especially PCO2 will be very grossly high, 70, 80, and the guy would be unconscious, unresponsive. He will say, what will you do? Then don't answer NIV, then the answer will change over to elective intubation of the patient. I will intubate and put the patient on positive pressure ventilation. Be less than 30 minutes, not to be given matlab. हाँ, burns, upper airway burns, yeah, maxillofacial trauma and upper airway burns. Exactly. Maxillofacial trauma, upper airway burns. So you can't put the mask there. Yes. So these are like contraindications that I have highlighted. Now we will change the focus slightly and look at another scenario where the person is having COVID and this guy was having pneumonia. So the person was breathing very, very fast. In any patient, whenever there is hyperventilation, in any patient, whenever there is a hyperventilation, due to hyperventilation, there will be a carbon dioxide washout from the body. And by default, you will notice that whether it is panic attacks, anxiety, post-MI cardiogenic shock, post-MI cardiogenic shock हो जाता ना, post-MI extensive interval MI से cardiogenic shock में चला गया था. If you look at this report, pH and PCO2 are going in opposite direction. If pH is more and PCO2 is less, because the arrows are opposite, you will say person is having respiratory problem. In a respiratory problem, the deciding factor is the pH, and the pH in this case is elevated. So you will say that the person is having respiratory alkalosis. By default, anybody having fast breathing, CS is cardiogenic shock. CS is cardiogenic shock. Respiratory alkalosis is the interpretation for this question. Now I would like you to stop commenting and listen to my words and answer me here. In a patient of respiratory alkalosis, bicarbonate की value normal नहीं है. Normal bicarbonate value is 22 to 26. अगर वो value normal होती तो I would have said kidneys were saying रुको जरा मदद करता हूँ. At the moment they have lost bicarbonate. Alkalosis में तो kidneys will lose bicarbonate. So in this particular patient, if there is like bicarbonate that is decreasing, so please comment in the chat box here. If the bicarbonate of the patient is beginning to fall, what will be the interpretation? Will you still say uncompensated or would you say partially compensated? I would like your inputs here. Yes guys. Yeah, compensation is metabolic acidosis. वो तो ठीक है. मुझे बताओ कि uncompensated है या partially compensated? Yes. क्योंकि ये वैल्यू यहाँ पर इस टाइम पे कम हो गई है तो बोलोगे this is partially compensated respiratory alkalosis in a patient. I'm writing with a different color now. Suppose in this multiple choice question, normal value क्योंकि आपको पता है, so I'm erasing the normal value. Suppose in the same MCQ bicarbonate value was normal. If bicarbonate is normal, then I would have read uncompensated because bicarbonate values have not changed. Uncompensated respiratory alkalosis. So I have tried to incorporate two questions in the same mathematical values that have been highlighted here before you. The basic rule is still the same. चाहे रेस्पिरेटरी एसिडोसिस हो या रेस्पिरेटरी अल्कलोसिस हो, आपको बाइकार्बोनेट को देखना है. अब तो मैं ये भी नहीं कह रहा कि वेदर यू हैव टू सी द राइज एंड द फॉल, मैं कह रहा हूँ नॉर्मल हो तो अनकॉम्पेंसेटेड बोल देना और चेंज हो जाए तो बोल देना कि वो पार्शियली कॉम्पेंसेटेड. अर्लियर तो मैं इंक्रीज डिक्रीज की बात कर रहा था ना. आई होप इट इज क्लियर. मैं यहाँ पे फिर से लिखता हूँ. आई राइट दिस अगेन एंड आई होप यू आर एबल टू फॉलो दिस. Respiratory acidosis means CO2 in the body is more, so the body will try to compensate with help of bicarbonate. If bicarbonate is normal, you will say uncompensated. If the bicarbonate values will change, you will say it is partially compensated. If it is normal, it is uncompensated. If it will change, it is partially compensated. Same you can write for respiratory alkalosis question. यार थोड़ा बहुत तो एग्जाम्पल से भी कर लोगे ना. COPD अस्थमा लिखा होगा तो रेस्पिरेटरी एसिडोसिस तो है. इतना ही तो देखना है कि बाइकार्बोनेट नॉर्मल है या चेंज हो रहा है. और अगर मैं बोलूँ किसी को निमोनिया हो गया, ARDS हो गया, पल्मरी एम्बोलिज्म हो गया, रेस्पिरेटरी अल्कोलोसिस, अगेन यू हैव टू डू द सेम थिंग. pH is bicarbonate is normal or it is changing. If it is normal, uncompensated. If it is changing, it is partially compensated. Guys, I had understood, sir, from couple of people. If anybody wants me to repeat the data, please let me know, because otherwise it will become difficult later. So I hope it is understood. Compensation is decided with respect to the lower limit or upper limit or average value of the value of bicarbonate. For like if it is rising, then we take the upper limit, and if it is falling, then we take the lower limit. अगर rise कर रहा है तो upper limit, and if it is falling, then not the average value. Upper limit and lower limits are taken. Okay. रेस्पिरेटरी एसिडोसिस में इतना तो निकाल लोगे ना, pH और PCO2 ऑपोजिट जा रहा है. इतना तो कर लोगे ना कि pH एंड PCO2 आर गोइंग इन ऑपोजिट डायरेक्शन इन अ पेशेंट. नहीं, यहाँ पे नहीं लगाते. विंटर्स फार्मूला जो होता है वो सिर्फ मेटाबॉलिक प्रॉब्लम्स के लिए होता है. विंटर्स फार्मूला इज ओनली फॉर मेटाबॉलिक प्रॉब्लम, नॉट फॉर रेस्पिरेटरी प्रॉब्लम्स. व्हाई पार्शियली कॉम्पेंसेटेड, व्हाई बाइकार्बोनेट इज लेस? बिकॉज द किडनी लॉस्ट बाइकार्बोनेट ना. चलो आप लोग बताओ मुझे, अगर किसी को मतलब केमिस्ट्री नहीं पढ़ी है, अगर किसी को रेस्पिरेटरी अल्कोलोसिस है तो बाइकार्बोनेट मोर है ना. प्लीज कमेंट इन द चैट बॉक्स, मैं एक एक करके एड्रेस करूंगा. अगर किसी को रेस्पिरेटरी अल्कोलोसिस हो तो किडनी को क्या करना चाहिए? शुड यू रिटेन बाइकार्बोनेट, शुड यू किक आउट बाइकार्बोनेट? कमेंट इन द चैट बॉक्स रिटेन वर्सेस किकिंग आउट. द वर्ड इज, अगर किसी को रेस्पिरेटरी अल्कोलोसिस है, केमिस्ट्री रेस्पिरेटरी अल्कोलोसिस का क्या मतलब होता है? बाइकार्बोनेट की मात्रा बढ़ रही है ना. अल्कोलोसिस का केमिस्ट्री मतलब क्या होता है? बाइकार्बोनेट जाता है. तो किडनी को क्या करना चाहिए? शुड यू रिटेन और शुड यू किक आउट बाइकार्बोनेट? किक आउट, एग्जैक्टली. अभी तो बाइकार्बोनेट फॉल कर रहा है. मैंने बोला अगर रेस्पिरेटरी अल्कोलोसिस है, किक आउट द वैल्यू ऑफ बाइकार्बोनेट. व्हेन यू किक आउट द बाइकार्बोनेट, दैट इज व्हाई इन दिस मैथमेटिकल एग्जांपल बाइकार्बोनेट की वैल्यू कम होगी. If you kick out the bicarbonate value is becoming lesser in the patient. अगर किक आउट नहीं किया होता तो अनकॉम्पेंसेटेड बोल देते. रेस्पिरेटरी एसिडोसिस और रेस्पिरेटरी अल्कोलोसिस दोनों के सवाल में इतना ही देखना होता है कि बाइकार्बोनेट की जो वैल्यू है वो नॉर्मल है या चेंज होगी, जिसके बेसिस पे हम अनकॉम्पेंसेटेड या पार्शियली कॉम्पेंसेटेड को वर्कआउट करते हैं. अभी समरी फिर से दूंगा इसकी एक बारी. विल वर्कआउट द समरी ऑफ ऑल दीज चेंजेस सब्सिक्वेंटली वंस अगेन. बट लेट्स लुक एट अनदर एग्जांपल. दिस टाइम इट इज अ पेशेंट ऑफ, या तो कॉम्पेंसेशन ऑफ रेस्पिरेटरी अल्कोलोसिस इज मेटाबॉलिक एसिडोसिस. वो तो बच्चों वाली बात होगी ना यार. आपसे एग्जाम में ये नहीं पूछेगा कि व्हाट इज कॉम्पेंसेशन रेस्पिरेटरी अल्कोलोसिस. अगर ऐसे होता तो मैं डिस्कस ही नहीं करता. मैं बोलता याद कर लो रेस्पिरेटरी अल्कोलोसिस मेटाबॉलिक एसिडोसिस, खत्म डिस्कशन. मैं आपको मैथमेटिक्स में जाके बता रहा हूँ बिकॉज ऑफ द फैक्ट कि भाई अल्टीमेटली दे आर आस्किंग यू यूसी वर्सेस द पीसी कंपोनेंट. अदरवाइज तो मैं बोलता कि भाई रट लो यार, इसका उल्टा होता है, बस खत्म होगी बात. ओके. The next question is on chronic vomiting in a CHPS patient. यहाँ पे मेरे स्टूडेंट्स कहते हैं कि सर हम तो मैथ्स में जाते ही नहीं है जब वॉमिटिंग लिखा होता है. तो स्टूडेंट्स सर ये जब वॉमिटिंग होता है ना तो मैं मैथ्स वैस नहीं करता जो आप बताते हो. ठीक है, क्यों नहीं करता? कह रहे सर आसान है ना, वॉमिटिंग का मतलब है लॉस ऑफ एसिड फ्रॉम द बॉडी. क्वेश्चन सॉल्व होना चाहिए. इन अ गाय विद कंजेनिटल हाइपरट्रॉफिक पाइलोरिक स्टेनोसिस is having loss of acid from the body. If somebody will lose acid from the body, what will you develop? Metabolic alkalosis. उल्टी करा तो एसिड निकल गया ना शरीर से, तो मेटाबॉलिक एल्कोलोसिस. एंड इफ यू आर मैथमेटिकली ओरिएंटेड तो मैथमेटिक कर लेते हैं. pH इज एलिवेटेड. PCO2 इज अपर लिमिट और नॉर्मल, तो मैंने जानबूझ के नॉर्मल दे दिया, मैं चाहता तो मैं एलिवेटेड भी दे सकता था इजी करने के लिए, बट आई होप एवरीबॉडी वुड एग्री टू द फैक्ट दैट दिस गाय इज हैविंग एल्कोलोसिस। इतना तो लिख लूं मैं, एल्कोलोसिस है, pH is 7.5. Now alkalosis is of two varieties, either it is a respiratory problem or it is a metabolic problem, and it cannot be respiratory because PCO2 is 45 now. I'm not saying it is less. For respiratory alkalosis PCO2 should be less, yeah, so it cannot be respiratory, so I'm left with only one metabolic. And how do I know metabolic? Bicarbonate is more now, normal limit is 22 to 26 millicoulomns. The first interpretation is metabolic alkalosis, you can either solve it mathematically or you can solve it non-mathematically. Loss of acid from the body, metabolic alkalosis will occur in the patient. Now let me know, at the moment PCO2 of the patient is normal है ना, PCO2 लंग्स ने बोला भाई रुको जरा मदद करता हूं, चेंज नहीं हुआ है, बड़ा नहीं है, नॉर्मल है, क्या बोलोगे? वेरी गुड, अनकॉम्पेंसेटेड। नाउ अगर आप नोट कर रहे हो तो यूज अ डिफरेंट कलर पेन and add the word, like suppose it is elevated, suppose it starts going up, you know, bicarbonate is also going up, like suppose in this patient I say bicarbonate went up to 33, कोई बात नहीं, CO2 is also rising na, like corresponding to bicarbonate PCO2 will also begin to rise. So if I change the value slightly and now I say to you that now all three values are more, pH is also more, PCO2 is also more, bicarbonate is also more, then if I change the data, if all three values are more, I have already drawn the table before you that if change hona shuru ho jata hai, then you will say partially compensated metabolic alkalosis in a patient. Whereas the same rule now, if any value is normal, you will say uncompensated. If it starts working, you will say partially compensated in the patient. The highlight is that now when bicarbonate will rise, uske proportional CO2 bhi rise hona shuru ho gaya. So I'm saying partially compensated in a patient. So those rules that I have highlighted before you are the ones which are to be revisited again. But before we do that, we have one more interesting fact to discuss here. This particular patient is having loss of acid from the body, so understandably metabolic alkalosis. Apart from this particular child will also be having loss of potassium because in the GI secretions potassium is present, so hypokalemia will be occurring. He is also having loss of hydrochloric acid, so I'm writing chloride will be lost from the body, chloride will be lost from the body, so hypochloremic, hypokalemic, metabolic alkalosis. I'll say the theory again, hypochloremic, hypokalemic, metabolic alkalosis is occurring in this child with congenital hypertrophic pyloric stenosis. He is vomiting again and again, तो dehydration भी हो जाएगी. The child is dehydrated. If you lose, अगर उल्टी होता है किसी को बार बार तो शरीर में पानी का कमी हो जाता है ना यार, आपको कभी लाइफ में फूड पॉइजनिंग हुआ, वॉमिटिंग हो, तो भाई यू फील थर्स्टी, यू लूज वाटर फ्रॉम द बॉडी. सो डिहाइड्रेशन की वजह से यहाँ पे एल्डोस्टेरोन वैल्यूज विल बिगिन टू राइज व्हेनेवर वी गेट डिहाइड्रेटेड. The RAS system kicks in, and when you are dehydrated, the RAS system kicks in, aldosterone begins to rise. When aldosterone will rise, it will act on the epithelial sodium channel, and by acting on the epithelial sodium channel, what it will do is that it will try to get the salt and water back in the body, and at the same time, it will also be kicking out potassium and hydrogen. If the person is dehydrated in this patient, then in those patients you will notice that if salt and water will come in, potassium will be kicked out and hydrogen will also be kicked out. Now I want everybody to comment here. The guy is having metabolic alkalosis, so what should the kidney do? Should the kidney be retaining bicarbonate or should you kick out bicarbonate? Metabolic alkalosis का मतलब तो यही होता है ना कि bicarbonate in the body is more. So in this particular patient, what should happen is the body should kick out bicarbonate. But what is it losing? Is it losing bicarbonate or is it losing hydrogen? Please look at the board here and tell me. Read, everybody has answered rightly. Body should kick out bicarbonate, but what is the body doing? Is it kicking bicarbonate or is it kicking out hydrogen? It is kicking out hydrogen now. That is why the word here is paradoxical aciduria. You see, in any patient of metabolic acidosis, what should ordinarily happen is, in any patient of metabolic acidosis, what should ordinarily happen is that you should be losing bicarbonate from the body, but here instead of losing bicarbonate, it is hydrogen that is getting lost from the patient. So the word is paradoxical aciduria for this patient. This is a specific term that I basically wanted to introduce for a patient of CHPS, that is congenital hypertrophic pyloric stenosis that ideally the body should be losing bicarbonate, but you're losing hydrogen. To summarize the aspect of CHPS, what I'll do is I'll use a different slide. So I want you to just sit back, relax. If you want, you can do this with me, and you can come to slide number 133. That's the vacant site 133, and do this activity with me. Otherwise, sit back, relax, and listen to my words here, which will make your life a little easier for the topic of congenital hypertrophic pyloric stenosis slash idiopathic hypertrophic pyloric stenosis. Though it's a surgical topic, I'll touch on the medicine part here. In this patient, there is a vomiting that is happening, and in vomiting, you are losing salt and water from the body. When you are puking, you are losing salt and water from the body. So this child will be developing hyponatremic, hypokalemic again because he's puking again and again. Intestinal secretions contain potassium. So he's puking again and again. So hypokalemic. The stomach acid is having hydrochloric acid, because hydrochloric acid is the one which is getting affected. So chloride will also be less. So hypokalemic. Metabolic alkalosis with paradoxical aciduria. Guys, I've tried to put effort. I've tried to put my heart and soul into teaching you of why this phrase is there. Hyponatremic, hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria. These are the metabolic derangements that they ask. They jumble them up and they ask which is correct and which is wrong. I hope it is clear, guys. I'll try to explain once again. उल्टी करेगा तो salt भी निकल जाएगा, सोडियम भी, पानी भी निकल गया, पोटेशियम भी निकल गया, हाइड्रोक्लोरिक एसिड में क्लोराइड निकल गया, and then is the metabolic alkalosis. Sir, secretions, na? Intestinal secretions have sodium also, na? All body secretions are rich in sodium, na? So hyponatremic in this patient. There is hyponatremic, hypokalemic, hypochloremic, metabolic alkalosis. All intestinal secretions tend to have sodium also present. Since you asked me that question of why hyponatremia, though I've already answered you, I want to ask a counter question to all of you. Which is the first electrolyte to be corrected? Which is the first electrolyte imbalance to be corrected of a patient of CHPS? Yes, guys. First electrolyte to be corrected. Okay, Arjun is commenting. No, aldosterone is not able to compensate. Not able to. It is trying. That is why patient became sick. Yeah, guys, you have had surgery class. I think he has told this in a surgery class. First to be corrected is not potassium. Sir, it is present in your surgery notes. This is given in your surgery notes. First to be corrected is sodium. And I say that why to make it so rocket science? Fluid of choice is normal saline, na? Fluid of choice for this patient is normal saline. First to be corrected is dehydration. Salt and water की जो कमी है. First to be corrected for this condition is hyponatremia. It is the dehydration part that needs to be corrected for this patient. Dehydration means salt and water deficiency in the body. Na? So first to be corrected is hyponatremia. That is why in the another year in the paper he said, what is the fluid of choice for this patient? So we will give normal saline. And to the bottle of normal saline, what we will also give is KCl. We can add KCl and that will basically help you in stabilizing the potassium value of this patient. But CHPS is one, arrhythmias will not occur usually in these patients, right? I mean, they can occur. Obviously, any electrolyte imbalance can cause VT or can cause a torsade as G point test. But we can add KCl to the bottle normal saline and we can manage the patient effectively. Congenital hypertrophic pyloric stenosis is common in firstborn boy baby. The question will begin by saying firstborn boy. Which antibiotic was consumed by the mother of this baby in the first trimester which caused this defect in the child? Normally in first trimester we ask women to avoid even paracetamol. I agree paracetamol is not teratogenic, but all medicines can cause potential to harm to the baby, have potential to cause harm to the baby. Yep. More people please. Yeah, erythromycin. The mother of this child, she was having URTI in the first trimester and she herself took erythromycin. If erythromycin intake is there, that is why the baby can have this association present in CHPS. So the question will begin by saying firstborn boy baby, and then this child will be having complaints of कि ये दूध गिराता है। छोटे बच्चे तो दूध गिराते ही है ना, दूध गिराना मतलब यू पुट हिम टू द शोल्डर, ही विल जस्ट puke ओवर योर शोल्डर, खूब सारा वॉमिटिंग करेगा curdled milk का। So the mother is saying that the child is having projectile vomiting, that is like effortless vomiting without a warning. So initially I thought that the baby is having aerophagia. You know, baby drinks milk very fast, aerophagia component. So I told her to bulk the child and everything. But yeah, I mean, like she has done everything, and the child will be having projectile vomiting. The next question is for FMG students. What is the age of presentation? Options were 3 days, 3 weeks, 3 months, and 3 years. 3 days, 3 weeks, 3 months, 3 years. The age of presentation will be 2nd to 3rd week of life with projectile vomiting. Next question is again for FMG students. What is the most reliable sign for demonstration of this condition? There are two options. One is visible peristalsis and the second one is epigastric lump. Which is the most reliable sign for this condition? Epigastric lump, projectile vomiting. Visible peristalsis. Can I have quick answers please? Okay. Yeah. यार वो जो लंप होता है ना वो बहुत बार फील नहीं होता है, बिकॉज अगर आप ठंडे हाथ लगाओगे बच्चा अपना पेट का एब्डोमिनल वॉल टाइट कर लेगा, और छोटा भी होता है लंप तो बहुत बार फील भी नहीं होता है. तो व्हाट यू विल डू इज यू विल फर्स्ट चेक फॉर विजिबल पेरिस्टालसिस, that is you will ask the mother to feed the child. So visible peristalsis is good way to identify, and if palpable then it will be a olive shaped lump. Olive shaped lump may be sometimes very small and may be difficult to palpate in the epigastrium. So it is not that you're wrong, but like I have written what is more reliable of finding initially, that is visible peristalsis, because stomach is working against a resistance, and then is olive shaped lump in the epigastrium that can be evaluated in this patient, and then we will be getting electrolytes, we will be getting a workup of this patient done. What is the imaging modality of choice of this condition? Answer is ultrasound. And what is the radiological finding in ultrasound please? What is the investigation ultrasound में what is the radiological finding? क्लॉ साइन, अरे नहीं क्लॉ साइन तो उसमें होता है ना इंटरसेप्शन या डोनट साइन. इट इज कॉल्ड एज टारगेट साइन और डोनट साइन. गाइस आई कुड हैव सेड कि इसको सर्जरी से पढ़ लेना, बट आई एम डिस्कसिंग दिस टॉपिक बिकॉज ये हमेशा एग्जाम में आता है, दो दिस इज टोटली आउट ऑफ माय लीग एंड टोटली आउट ऑफ माय डोमेन. बट द रीजन आई एम डिस्कसिंग दिस टॉपिक इज बिकॉज ऑफ द क्रिटिकलिटी ऑफ द टॉपिक, और इसमें अगर एक भी पॉइंट आपका गलत हो रहा है तो वो नहीं होना चाहिए. Then you will be getting electrolytes of this patient done. Electrolyte report I've already explained to you. So in this particular patient, you will be having sodium that is lesser. No, only seen in this condition, paradoxical aciduria, aldosterone that is increased in the patient, right? Otherwise, so we will be having bicarbonate compensation occurring because multiple electrolyte imbalances are happening. Sodium, potassium, chloride, bicarbonate in the patient. That would sodium potassium chloride will be less. Question for you guys: what will happen to calcium in this body? I'm writing the ABG report. pH will be more, PCO2 will be more, bicarbonate will be more. That means it is partially compensated. Metabolic alkalosis in a patient, if PSO2 normal de deta, then it would be uncompensated. What will happen to calcium levels in the body of this patient? High. Okay. High answer aa raha hai. No guys. Metabolic alkalosis causes redistribution of calcium. Calcium in our body lives in two forms. One, the calcium in our body is bound form. The bound form of calcium is called as to serum albumin, and then we have ionized calcium. The ionized calcium is in the free form. Metabolic alkalosis में क्या होता है कि redistribution होता है, that is the ionized calcium will become lesser. In metabolic alkalosis there is the redistribution of calcium, and ionized calcium will become relatively lesser, and when ionized calcium will be less in the patient, ये calcium की मात्रा कम होती है. So that is what they asked. How will you treat the hypocalcemia of the patient? Your answer is still the same, normal saline. He said, how will you handle hypocalcemia of this patient? Your answer is not calcium gluconate. Why the answer is not calcium gluconate? Because I want you to comment in the chat box. This patient is having loss of calcium from the body, or is it a redistribution of calcium? Is this patient having loss of calcium from the body? Or is this patient having a redistribution of calcium? Yes, guys, waiting for your answers. Very good. Redistribution of calcium. It is the redistribution which is the cause. So we will not give calcium gluconate for this patient of CHPS. We will be giving to this patient again normal saline. They will basically ask you these electrolyte wala aspects. You need to stabilize the patient. At this moment, I also want to say that lots of times surgeons and orthopedicians, they ask you to fudge and make fake reports of electrolytes and hemoglobin so that they can operate on patients. We love the aggression of surgeons. We love that they are like super aggressive. But this particular case, and at least when you know as a doctor potassium is less, never make a fake lab report ever. Don't ever ensure a fake report just because you want to be at good terms with the resident, because this guy will never ever come to, this patient will not come out of anesthesia. This patient will not come out of anesthesia. You see, surgeons, they are like rough and tough. Orthopedicians are rough and tough. We want them to be rough and tough. But at the same time, you will notice anesthesia guys are conservative. Medicine people are conservative. Why are we balancing act? We लड़ लेंगे. नहीं अभी करने को तो सब कुछ हर कोई कर लेता है अभी कूल आई मीन एवरीबॉडी वांट्स टू बी कूल डूड. अभी भी पोटेशियम का रिपोर्ट कभी भी आपको अगर 3.5 के नीचे है, इट्स अ नो टू सर्जरी. द डायफ्राम ऑफ द पेशेंट विल नॉट रिकवर. द डायफ्राम ऑफ द पेशेंट विल नेवर रिकवर सर. पेशेंट विल नॉट कम आउट ऑफ एनेस्थीसिया. सो वी नेवर आर सपोज टू फज एनी रिपोर्ट ऑब्वियसली. तो वो ठीक है कि वो हेमोग्लोबिन में कभी कभी जैसे कम होता है तो पेन से चेंज कर देते हैं, राइट. आजकल तो कंप्यूटराइज रिपोर्ट होती है, पहले वो हैंड रिटन आती थी, वो हाथ से चेंज कर देते थे एंड पीएससी फिटनेस हो गया एंड समथिंग लाइक दैट. तो ब्लड आई अंडरस्टैंड विद hemoglobin you can take a chance, but you can take a chance with electrolytes, man. It's a disaster that is happening in this case. And for the management of this patient, obviously Ramstead operation will be done. मैं चाहूँगा कि you guys read about this topic from surgery also. एंड देन इधर लाइक जो सर्जन के पॉइंट्स है या तो ऐड ऑन कर लेना यहाँ पे मेरे वाले में, या मेरे वाले पॉइंट्स अगर एक्स्ट्रा कुछ मिले हो कैल्शियम वेल्शियम वाला तो वो सर्जन के नोट्स में ऐड कर लेना. CHPS शुड बी एट वन प्लेस and it's a super important topic that always comes and will always be with respect to metabolic alkalosis situation in a patient. I will also mention a mnemonic here quickly, which is by the name of cult for metabolic acidosis questions. Though I have explained to you metabolic acidosis, all MCQs of this topic will always say pH is less, PCO2 is less, and bicarbonate is less. That would be the routine scenario for partially compensated metabolic acidosis, but always deploy Winter's formula just in case that if the expected PCO2 is higher, like we discussed to 30 and 25 wala question, that would be a mixed disorder. The mnemonic is cult. Alphabet K stands for ketoacidosis. If a person is having ketoacidosis either due to starvation, like this politician went on a strike, like Arvind Kejriwal when he started Aam Aadmi Party, he went on a hunger strike and everybody in India was amazed because it was a genuine hunger strike. Then he became corrupt and he started following all other politicians. But Aam Aadmi Party was like a revolution in India because first time a genuinely a person had done fasting. All these politicians are a sham. No, they don't do that fasting. They are like doing fasting by turn. 6 hours, 6 hours, everybody. This particular guy, like Kejriwal, he for 7 days, sir, he did not take food and water. He went into ketoacidosis. So the Supreme Court sent in the Delhi police and they got him and they force fed him and everything. But like Indians were like zapped at when this Aam Aadmi movement started, that, is it possible that some politician for us will, not stop taking food and water? And then obviously that all politicians are of the same league. So you also got corrupted. You are known by the kind of company that you keep. So when you stay with corrupt people, you are bound to get affected. But I wanted to give this example here, the starvation component, and then like diabetes mellitus anyway for ketoacidosis. Alphabet U would stand for uremia. He was not a politician then. He was from IT. He's an IT guy. He's an IT guy. Okay, fine. Next, moving ahead. Then is uremia. भाई सारे politician एक जैसे ही, ठीक है. Alphabet L is uremia. U is for uremia, and then L, right? So L is for the lactic acidosis one. L is for lactic acidosis. For lactic acidosis, there can be two situations, A versus B. For lactic acidosis, there would be two situations, type A and type B. All types of circulatory failure, all types of shock would always contribute to development of type A lactic acidosis. Cardiogenic shock, all types of cardiogenic shock, distributed shock, hypovolemic shock, every time there is shock. ये किसी ने पहले भी पूछा था, मैं फिर से clarify कर रहा हूँ. If somebody is having shock, then there is underperfusion of tissues. Underperfusion of tissues will cause lactic acid production, and then underperfusion of tissues, when it will generate bicarbonate, when underperfusion will occur, it will cause metabolic acidosis. And that, I mean, why the acidosis is because cells are switching to anaerobic mode of respiration. Anaerobic mode of respiration. Now we talk about type B lactic acidosis. That's gonna be metformin. If he says diabetes mellitus, not diabetic ketoacidosis, if he says diabetes mellitus, if he says metformin, then it is type B lactic acidosis in the patient. Lactic acidosis of any variety, type A and type B, he will give you ABG report, all three values will be less, and then comes the issue of toxins. The commonest toxin that they would like to ask you is that fake alcohol, methanol poisoning, methyl alcohol poisoning, which in forensic medicine is also called as Hooch tragedy. Hooch tragedy would mean, Hooch tragedy, H-O-O-C-H, Hooch tragedy would mean that couple of people have consumed alcohol from a local vend which was not authorized by the government. You would be anyway shocked to know that almost more than 70% of GST and 70% of the taxes of government of India come from sale of alcohol. That is why हर गली में एक वेंड खोल दिया उन्होंने. Irrespective of the government, right? Irrespective of the government. Anywhere and everywhere. It's like the same situation. Methyl alcohol poisoning is Hooch tragedy. This methanol is metabolized by the same alcohol to generate formaldehyde. It is metabolized by the same enzyme alcohol dehydrogenase. And when alcohol dehydrogenase will be working, then formaldehyde will be produced, and this formaldehyde, when it is metabolized further, it will generate formic acid, which is a very strong acid that will cause encephalopathy. Formic acid has a pH of almost nearing 1, and as a result of this, it will damage the blood-brain barrier, and the damage to the blood-brain barrier will then result in encephalopathy. Even a single drink is sufficient. The question in your paper said a person had consumed alcohol from a local vend, and after that the person is having snow vision. The reason for snow vision is that the formaldehyde is toxic to the retina. जैसे snowstorm हो रहा है, तो in a snowstorm, like you would not be able to see anything. So the question said the person went to a local vending shop, he consumed a locally made alcohol, and after that the person developed snow vision. He is not able to see anything and he became unconscious. I think you would be aware that almost 15 to 30 ml single drink, जो एक पैक होता है, 1 pack is sufficient to kill a patient of methanol poisoning, and as a result of this, like, this guy can die. So they said, what is the antidote that you will be using in this particular patient for management purposes? So the main antidote that we use for this patient is fomepizole, because fomepizole will inhibit the degradation of methanol into formaldehyde by inhibiting the enzyme alcohol dehydrogenase, and we use fomepizole for this patient. It is fomepizole which is the main drug which is useful for management. Along with that, we will use a vitamin also. So a question is open to everybody. I would like everybody to comment. I have almost 700 plus students today, so I expect answers here. Which vitamin will you give here? Answer options are vitamin B1. You have to comment on the vitamin to be given. Vitamin B1, B3, B6 and B9. Quick answers for this one. Which vitamin would you be given in this patient? I will come to ethanol also. We can give ethanol also. Yes, guys, I am waiting for more people to comment here. I'll wait for another few seconds. I think this is a very standard and an easy question that I'm asking you here. This is a PYQ, has been asked in all kinds of exams all over the country. Whenever they're going to be dealing with an alcoholic, methanol poisoning, they will ask you which vitamin will you be giving. The answer to this particular question is not vitamin B1. I think most of you are wrong. Is this a case of Wernicke's encephalopathy? Am I discussing a case of Wernicke's encephalopathy? No, na. I never described Goa. That Wernicke's encephalopathy I've discussed with you already. Guys, this is not a case of Wernicke's encephalopathy. Okay, now a couple of people are commenting correct. The answer is not vitamin B6. Answer is not vitamin B6. Yes, more people please. Answer is not vitamin B6. I'm still waiting for people. Yeah. The answer is vitamin B9. Guys, we give folic acid. Folic acid क्या करता है? It will break down formic acid. Folic acid will help in breakdown of formic acid into two components, water and carbon dioxide. It will help in breaking down the formic acid into two components, that is water and carbon dioxide. The answer is two F's which are used for this condition. This is again a very common mistake that people do कि जल्दबाजी में गलत होता है. It is just an overconfidence that results in errors there. The answer is fomepizole and folic acid for management of this patient. When I was a student your age, then obviously all these facility of fomepizole was not available, so we used to give ethanol to the patient. In earlier times, it was ethanol only. Now, obviously, we don't use ethanol for this particular condition. Suppose you have to give ethanol, you're working in periphery, then how will you give ethanol? If you have to give ethanol, you can't put it in a glass, no, and say, sir, your drink, sir, your drink. We are not running a discotheque and a service industry, it's a hospital. So how will we give? IV. Okay. See, if IV ethanol is allowed, ठेका पे कैसे जाएंगे? ठेके से तो लेके आएंगे ना. IV कैसे दोगे? अगर IV इथेनॉल दे दिया तो मुझे तुम्हें पढ़ाने की जरूरत नहीं है और तुम्हें इतना पढ़ने की जरूरत नहीं है. आपने घर पे बैठो, just mention that you are a medical student, a doctor, and you know how to put a IV line. At 7 o'clock in the morning, people will come and knock on your door and say, Doctor Saab, please put cannula. I want my fix today. If IV alcohol is allowed, rectal is also allowed. Then people will, even rectal दोगे ना तब भी आ जाएंगे लोग. If IV is allowed, such is the addiction. IV तो क्या rectal के लिए भी आ जाएंगे. डॉक्टर साहब लगा दो अल्कोहल, चढ़ा दो, बस नशा चाहिए हमारे को. ना मुझे इतनी मेहनत करनी थी और ना तुम्हारे को इतनी ना पढ़ाई करनी पड़ती. क्या मतलब अपनी जिंदगी इतनी खराब कर रहे हैं, राइट? सो इथेनॉल कैसे देंगे? तो सर एनजी ट्यूब से देते हैं. व्हेन आई वाज अ रेजिडेंट एट योर एज, तब पेशेंट जैसे आया तो फिर मैंने पेशेंट के रिलेटिव को बोला कि अल्कोहल चाहिए. वो कहता मैं तुम्हारी कंप्लेंट करूंगा, तुम ड्यूटी पे पी रहे हो. उस लाइक है, कह रहा तुम ड्यूटी पे पी रहे हो, तुम मुझसे शराब मांग रहे हो. मैंने कहा भाई मेरे लिए नहीं चाहिए, तुम्हारे बंदे के लिए चाहिए. तो फाइनली तो पहले तो ही वाज लाइक दीज पीपल वर लाइक आई विल गो टू द मेडिकल सुपरिटेंडेंट, आई विल कंप्लेन, यू गाइस आर डूइंग, यू आर ड्रिंकिंग अल्कोहल इन द हॉस्पिटल. एंड आई वाज लाइक पागल है क्या, मतलब भाई पेशेंट के लिए चाहिए. तो फाइनली दे गॉट द अल्कोहल. कहता कौन सा ब्रांड लो? तो पहले तो यार ब्रांड का भी इतना ज़्यादा समझ नहीं होती है अभी कौन सा वाला मंगवाना है. तो फाइनली पता चला मैकडोवल्स आता है, तो हमने मैकडोवल ब्रांड बोलते हैं. अब सोडा का पता था, मैकडोवल्स बोलते हैं. अभी तो इंडिया में बड़े सारे ब्रांड आ गए ना, जैसे पहले तो ऐसे कोई अल्कोहल वल्कोहल होता नहीं था पता इतना ज़्यादा. So finally, like these relatives, they got the alcohol, and then I gave that bottle to the nurse, and she was like, no, ची ये क्या दे दिया मेरे को. तो finally मैंने बोला ठीक है, give me the IV fluid का bottle. So I transferred that alcohol into that IV fluid bottle. I hung it upside down, and then I gave it via NG tube to this patient. But you will understand that if you wanna give this, yeah, you guys are familiar with good brands. They're strong ones, right? Old Monk and everything, right? Teachers and Black Dog and everything. राइट, पहले अमेरिकन आती नहीं थी इंडिया में. तो इथेनॉल इज लाइक गिवन वाया एनजी ट्यूब टू द पेशेंट, बट द एब्जॉर्प्शन इन दिस केस वुड बी वेरी वेरी इराटिक. सो नाउ व्हाट वी डू इन दिस पेशेंट इज वी गिव IV फॉर्मेपिजोल एंड फोलिक एसिड फॉर मैनेजमेंट ऑफ दिस पेशेंट्स. सो दिस इज एट दिस मोमेंट व्हाट आई वांटेड टू ब्रिंग टू यू. या इंद्री इज द इंडियन ब्रांड, एंड आई थिंक इंद्री के बारे में मैं कुछ नहीं बोलूंगा भाई, जेल नहीं जाना. ओके, मूविंग टू द नेक्स्ट एस्पेक्ट. इन मध्य प्रदेश in last year, children had died after eating contaminated cough syrup. Last year in Madhya Pradesh, children had consumed contaminated cough syrup and they died. They went into metabolic acidosis. Even the doctor saab from the primary health center who consumed that contaminated cough syrup, when patient's relative came with a complaint that, oh, this cough syrup is making our children sick, this doctor saab, he was not aware that this cough syrup is contaminated. To prove to the family members, in ego, he drank 2 bottles and he said, see, kuch nahi hua. And after a few hours, this guy was unconscious in his car. His wife was calling, he was not picking up the call, and he went into renal failure. Luckily, he was saved and he was fine. but this is a very, very unfortunate scenario. Contaminated cough syrup intake again will cause it. So another toxin where ABG report will be given is pH is less, PCO2 is less, and PC bicarbonate is less. The component which is present here is called as ethylene glycol poisoning. In cough syrup they put glycerine to make it thick, to make increase consistency, to cause a soothing effect in the alcohol, and then is ethylene glycol which is present in excess instead of glycerine as a low cost agent that will cause trouble. Ethylene glycol, if in excess, what it will do is it will cause production of calcium oxalate crystals. This is what they've asked in the exam, that how does ethylene glycol contribute to renal failure and cause metabolic acidosis. Ethylene glycol causes calcium oxalate crystal precipitation. And when calcium oxalate crystals will be precipitated, it will block the tubules of the kidney and they will be causing acute tubular necrosis, and there would be a renal shutdown in a patient. And whenever you have renal shutdown, then there would be inability, car freeze also. The same component is used in the brake fluid also, in the car freeze also, but car freeze is like India is a hot country, so we don't use the car freeze much, no. So it is a cough syrup contamination. Same, it's an industrial solvent. Ethylene glycol is an industrial solvent. It is present in the car brake fluid, it is present in the car freeze, it's present in the car coolant, and also in the cough syrup. Inability to excrete hydrogen. Inability to excrete hydrogen and inability to excrete potassium will cause hyperkalemic metabolic acidosis in this patient. Shockingly, the doctor had given or prescribed this cough syrup to children. He's in jail today. They put up a non-bailable warrant against him. The politician who owns that pharma company is still out and he has not been arrested. The owners of the company are going scot-free. It is the doctor who was against whom non-bailable warrants were issued, and nobody from our fraternity supported the doctor, which is very, very sad, guys. Crazy things happening in India. And then they gave an advisory: doctors must verify before they prescribe. I mean, can you beat that? I mean, like, you have to be responsible for the brand of cough syrup you are prescribing. I mean, there's nothing in good faith. Drug control authority, nothing is working. They're putting, I mean, we should be running testing labs now. Crazy. Yes. IV fomepizole is the main treatment that we'll be using in this patient. Apart from the coaching part, I just want you to be aware of how things are outside. It's a crazy world out there. So you need to be able to protect yourself. You should be knowing theories, and obviously you need to know the laws. And yeah, sir. देखो सर, पुलिस वालों के पास में ना सबका डेटा होता है. जब उठाना होता है ना तो कहीं से भी उठा लेते हैं, राइट? Everybody's mobile can be tapped immediately, right? They have the Pegasus. They can hack into anybody's mobile at any point of time. That is the release system that they have. They want to pick up anybody, they can do it any point of time. But obviously somebody is in power, they won't do that, and the doctor at the bottom of the food chain is the one who's being penalized, which is really, really sad. It has happened in Uzbekistan. Yes, it is. This has happened in Zambia, Uzbekistan. Indian companies cough syrup, the people have ultimately suffered. So I wanted to introduce a mnemonic before you by the name of CULT: ketoacidosis, uremia, lactic acidosis, and toxins. And from this mnemonic, I want you to remember that in all of these conditions, the pH will be less, PCO2 will be less, so the load becomes lesser, that you know that it is metabolic acidosis. Now you just need to know whether PCO2 is normal, whether it is less, and apply the Winter's formula. The objective of the doing the hard work is to explain to you that the load in the mathematical part goes lesser. Then the load in the exam becomes lesser. That is why we're doing the heavy duty lifting at this particular point of time. So I'll come back to the original discussion, guys. I've described various scenarios, and this is going to continue. I mean, this is part and parcel of our life that we keep on handling. Yeah, absolutely. There has to be something to check. Okay, guys. Now we come to a very interesting question. Again, this is purely NEET PG oriented. They gave a MCQ in which pH was normal. Somebody was asking about it right in the beginning. कि sir pH normal हुआ तो एक तो fully compensated है. PCO2 was normal and bicarbonate was also normal. So one of my students said one option was normal report. But then he said, sir, कि I decided to just have the question evaluated again before I say normal. So sodium and chloride were also given, and therefore what I decided to do was calculate the anion gap. This report is factitiously normal. I will give you the reason why. What is the hint in the question? The hint in the question is the anion gap. The formula for anion gap is sodium minus. Keep your eyes on the board, guys. Anion gap formula is sodium, that is positive charges. From there, subtract the negative charges, chloride and bicarbonate. The anion gap in a normal person, I will first calculate anion gap for you and me, and then I will do for this person. Normal anion gap for you and me is 140 minus chloride value is 80, bicarbonate value is 24. So if I'm gonna do this activity, that mathematically, if you look at it, the anion, okay, I calculate for this patient. I'll do for you and me first. I'll do for you and me first. Give me a second. In a normal person, sodium is 135 to 144, 135 to 145. I'll take an average of 140. Chloride average value in you and me is 106. And bicarbonate is 20 to 26. I'll take an average of 24. So if you look at the mathematics here, normal anion gap in you and me will be 140 minus 130. That will be a value of 10. Normal anion gap is a range of 6 to 12 millicoulombs. Normal anion gap is a range of 6 to 12 millicoulombs. This is normal. This is for normal people. Now what I will do is I will calculate for this person also. I'll use a different color pen just for introducing the contrast. The sodium in this patient is 130. The chloride value given in this question is 80. And the bicarbonate value given is 24. So it is very, very high. For this patient, the value is turning out to be almost like 26. I wrote that in bold to highlight that the anion gap of this patient is elevated. That is a hint that this particular question, the ABG report, is actually falsely normal. If you get a question in which everything is normal, and then sodium electrolytes are also given. If electrolyte etc. was nothing given and only this report was given, they said, what is your interpretation? Answer, it is normal, not a problem. But they had given sodium, chloride and all those things. So they were like trying to probe you that will you go and select and try by yourself calculating the anion gap. And the anion gap is really elevated. This means that this is a pseudo report. And now I will work logic. The logic is like this. In chronic kidney disease in a patient, there will be inability to excrete hydrogen and potassium. Therefore, by default, whenever kidney is at fault, there would be a hyperkalemic metabolic acidosis. The word is metabolic acidosis. And I have already explained to you that this particular patient is having vomiting also. The vomiting will be causing loss of acid from the body. Now I want to put that to the perspective. Guys, this is actually a mixed disorder. This is the most shocking report that I'm telling you. This shocking report is actually having metabolic acidosis because of kidney damage. And the patient is also having metabolic alkalosis because of vomiting, but because the two processes will cancel each other, the ABG report in this condition is factitiously normal, This particular question that I have discussed is a INISET MCQ. This is word to word picked up from Harrison, where is given only this example where he said everything is normal, anion gap was elevated. He was describing a case there, and then he said that we stumbled on the fact that the guy was having deranged anion gap, and then surprisingly, like when we looked at the clinicals, the patient's ABG was not normal, it was factitiously normal. This is a mixed disorder of metabolic acidosis and metabolic alkalosis. The most shocking of all the reports that I have currently explained to you is because two types of acidosis. Earlier I was teaching you acidosis. Now I'm teaching you acidosis and alkalosis cancelling each other. That cancelling each other is the point which is to be understood here. So like if you can remember scenario 5, 1.1 and 1.2 cool. For FMG exam, you just neglect 1.1, 1.2 and 5. But for rest of you have to remember all the details that are present here. So what we will do next is we'll do 4-5 more MCQs and then we go for a tea break. So answers I want spot on. What is the fluid of choice for metabolic alkalosis? Fluid of choice for metabolic acidosis is Ringer lactate. Fluid of choice for metabolic acidosis was deliberately not asked in the exam because he knows that you will answer that very easily. Ringer lactate. If he says what is the fluid of choice for metabolic alkalosis, your answer is normal saline. Exactly. Alkalosis is normal saline. Just like you guys are comfortable that metabolic acidosis, Ringer lactate, similarly for metabolic alkalosis, normal saline corrects the dehydration and treats the metabolic alkalosis component. Now tell me, why do you have lactate in Ringer lactate? I mean, how does it help in metabolic acidosis? If you have Ringer lactate में lactate होता है, उससे फायदा क्या? क्यों डाला lactate आपने? What is the big deal? Lactate will be metabolized by the liver. And when lactates will be metabolized by the liver, it will cause a bicarbonate generation. And the good news is this bicarbonate will then neutralize the protons. We need somebody against hydrogen ions. Na? Metabolic acidosis means hydrogen excess. तो आपको हाइड्रोजन से लड़ाई करने के लिए कोई तो चाहिए. क्या चाहिए? बाइकार्बोनेट. तो बाइकार्बोनेट बनाएंगे. सो द बाइकार्बोनेट विच इज अ बाई प्रोडक्ट ऑफ द लिवर, विच इज lactate gets metabolized by the liver and causes bicarbonate generation. These two will fight with each other now, and when I want the fighting to happen, because when they both will fight, they will cancel each other. pH of the patient will begin to stabilize. The next question is, what is the side effect of excess of normal saline? Normal saline, when you give too much, you are giving like sodium and chloride. Sodium chloride in excess is being given to a patient. The biggest side effect of excess of normal saline is, though there is a rationale for it also, but like one of my students, he solved by English. He said, sir, आपने बोला था कि fluid of choice for metabolic alkalosis is normal saline. That means it is neutralizing alkalosis. How will it neutralize alkalosis? By causing acidosis. So the side effect of excess of normal saline is metabolic acidosis. I will repeat the data once again, how my student approached it, and then I will teach you the theory component rationale also. My student said, boss, you said metabolic alkalosis, fluid of choice is normal saline. That means it must be an antidote. What is the antidote of metabolic alkalosis? Something that causes acidosis. So he said excess of normal saline will cause metabolic acidosis, and he was able to solve the question. I said, perfecto, man, perfecto. Very great logic. Now, I'm gonna do the rationale here also. The rationale is that you are giving 0.9% NaCl to the patient. You are giving 0.9% NaCl. When you are gonna give NaCl to a patient, chloride is gonna go in the body in excess. Negative charges in the body are rising. If you give too much of normal saline, the chloride in the body will be more. So to maintain, the theory is that if chloride in the body is more, to maintain the electroneutrality. See, the basic function of the human body is to maintain balance between positive charges and negative charges. To maintain the electroneutrality, the body will tell the chloride, please ma'am, please go inside the cells. Please go inside the cells. So what will happen is chloride will say, no, I am not going. I am the guest. To maintain electroneutrality, negative charges are more now. So the body requested chloride, ma'am, please, you go inside the cells. Ma'am, you are too much, and you are causing problem. You are causing electrolyte. You are causing different. You are causing charge imbalance in the body. Positive, negative should be equal. Ma'am, you are causing problem. So you please go inside the cell. Chloride ने मना कर दिया. बोला, I am the guest यार. मुझे guest जो आता है घर पे, वो मतलब उसको बोलो यार तू यहाँ मत बैठ बुरा मनाता है. तो क्लोराइड बुरा मान गई, कह रही मैं नहीं जा रही. तो बॉडी ने फिर रिक्वेस्ट करी बाइकार्बोनेट से कि यार तू ना प्लीज थोड़ी देर के लिए ना तू सेल के अंदर चला जा. तो द क्लोराइड वाज रिफ्यूजिंग टू गो इनसाइड द सेल. सो बॉडी रिक्वेस्टेड क्लोराइड बाइकार्बोनेट को. बाइकार्बोनेट इज आल्सो पार्ट ऑफ द बॉडी. उसको बोला यार तू यार थोड़ी देर के लिए चला जाना सेल के अंदर में. सो बाइकार्बोनेट वाज इंस्ट्रक्टेड टू गो इनसाइड द सेल्स. एंड नाउ आई थिंक इफ यू रीड द डेटा, please just read my English statement that if bicarbonate will go inside the cells, I want everybody to hit the comment button. Agar bicarbonate will go inside the cells, then bicarbonate in the blood will become less. If bicarbonate in the blood will become less, what will it cause, guys? Metabolic acidosis. Yes, guys. फिर से बोलता हूँ, क्लोराइड इन द बॉडी इज मोर ना. तो बॉडी ने क्लोराइड को बोला तू सेल के अंदर चले जा. कह रही मैं नहीं जा रही, हम तो मेहमान है, हम नहीं जाएंगे. तो फिर बॉडी ने बोला चल कोई बात नहीं. बाइकार्बोनेट को बोला अच्छा यार तू चला जाना यार, ये तो मान नहीं रही है, चल तू मान ले. घर पे मेहमान आएगा यार, तो लाइक लॉट्स ऑफ टाइम, नो, लाइक इफ like you are short on space and everything, and the relative is poaching on your sofa and couch, you requested them to vacate the couch, मना कर दिया. तो आप किसी और को बोलोगे चल यार तू कहीं और जाके सो जाइए, उसको सोने दे यहाँ पे. So similarly what happened was that the body requested bicarbonate to go inside the cells, and if bicarb will go inside the cells, then there would be metabolic acidosis. So if you can remember the rationale, be my guest. I will be so happy if you can remember and replicate that in the exam. But one of my students said कि सर rational नहीं आया. मुझे तो बस ये पता था, आपने बोला था मेटाबॉलिक एल्कोलोसिस का एंटीडोट नॉर्मल सलाइन होता है, तो एसिडोसिस ही करता होगा, तो ज़्यादा दे देंगे तो मेटाबॉलिक एसिडोसिस हो जाएगा. मैं कहा परफेक्ट भाई, बिल्कुल सही करके आया. Okay, guys. So I think we are sorted for this one. Next is fluid of choice for metabolic acidosis is ringer lactate, as already discussed. Test for acute exacerbation of chronic bronchitis is non-invasive ventilation. I have one more question for you guys. Best for management of तुम भी ऐसे हो जाओगे हैकर, पढ़ो तो सही रेगुलरली. Best for management of respiratory alkalosis. Best for, yeah, NIV. Bye bye. Perfectly, Rohit, you're fine. How do you treat respiratory alkalosis in a patient? Causes of respiratory alkalosis can be panic attacks. It can be pneumonia. It can be ARDS. वो कोई भी कंडीशन लिख दे. The hack is respiratory alkalosis is less CO2, that is hyperventilation. In all of these patients, respiratory rate will be more and CO2 will be less. If CO2 is less, H2CO3 will be less. If H2CO3 is less, that carbonic acid अगर less हो गया तो pH of the patient will rise. Right in front of you, CO2 is less, pH is more, arrows opposite, respiratory alkalosis. If the guy will breathe more, you kick out carbon dioxide, less carbonic acid, more pH, and therefore you'll have, yeah, mountain sickness also. Yes, Dr. Siva Subramaniam, spot on. That's gonna be mountain sickness. So perfectly spot on. High altitude pulmonary edema, high altitude cerebral edema, mountain sickness, spot on. Will be having metabolic alkalosis. How would we be getting the pH back to normal? Like this lady, she's sitting in a plane and she's afraid of heights. When she looked down from the plane, the airline allocated a window seat. Now you would have seen, you travel by plane. When you ask them, don't give me a window seat, they will give you a window seat. And when you ask them ale, they will give you window or they will put you in the middle. So here, this lady, she's afraid of heights. She's traveling by plane today. So she requested the counter clerk that, ma'am, please don't give me window seat. I'm afraid of heights. The counter clerk still gave her a window seat. And when the plane was, after the taxi, when the plane took off, when she looked down, she started having a panic attack and she started feeling nervous. She started having respiratory alkalosis. So what will we do in this particular patient is, we will be doing is a paper bag rebreathing. We will go for a paper bag rebreathing in the patient. Yes, guys, it's a paper bag rebreathing that is required. Exactly. विंडो ओपन करवा दो. दरवाजा ही ना खुलवा दें. या फिर बोइंग का जहाज हो, दरवाजा अपने आप से ब्लो आउट हो जाए. What Boeing did, na, that the plane, the window blew off, poor quality, pure QC was bad there. Okay, guys, so we are at page 116 here. We still have a lot of good things to talk about, but we'll go for a break at the moment. Yeah, agreed. So we take a break here, guys. 30 minutes का break है. 30 minutes, right? We'll start after 30 minutes. अब कितना हो गया 30 minutes? It's तो time बताओ ना यार. It's 5:40, I think, है ना? So 6:10 is what we start here, right? 6:10. 30 minutes कर ले यार. 6:10 is what we start again. Okay. Yeah, you can type the doubt, doctor, quickly, please. Rest of the guys can leave. Sir, अभी देखो आप प्रॉम्प्ट मत करो ना, अभी किडनी का टॉपिक है उसमें बात करेंगे. डाउट प्लीज. आउटे चला गया यार. हैगमा पूछना है, दैट विल बी डिस्कस्ड इन द किडनी पार्ट. हैगमा किडनी भाई, हाई एन गैप मेटाबॉलिक एसिडोसिस, नॉर्मल एन गैप मेटाबॉलिक एसिडोसिस इन द किडनी सेक्शन. पता नहीं आई मिस्ड इट. तो भाई मारवा मेडिसिन एंड जीमेल पे भेज देना प्लीज. आई मिस्ड व्हाटएवर वाज द डाउट. We will have to compare, Dr. Nazia. We cannot compare directly. Like patient will not come with fully compensated. Now, how can he come? See, fully compensated is after treatment, doctor. So he might have taken treatment from some other place, but I agree to your point that we cannot differentiate or we cannot identify. Surely. A hint I can say for how will we differentiate is if CO2 is more, then it is respiratory. If CO2 is more or less respiratory, bicarbonate more or less, it is a metabolic. We can differentiate between the primary process we can pick up by PCO2 also. That is poor sugar control, Rajesh. That 7% tu bola na, that is for poor sugar control, not the cutoff for diagnosis. If value of HbA1c is more than 7%, we call it poor sugar control. That is not diabetes mellitus. हाँ सेम ही तो नोट्स है यार, यही तो पढ़ने. Content in नो नॉट एग्जैक्टली, वो लिखा हुआ है पहले से ना, तो आपको पता नहीं चल रहा। टर्शरी इज अनट्रीटेड सेकेंडरी ना, अनट्रीटेड, इफ यू डोंट ट्रीट सेकेंडरी देन इट गोज इनटू टर्शरी ना, दैट इज अनट्रीटेड। पुराने जमाने की बातें होगी ना, पहले सीकेडी का लोग इलाज नहीं होता था हमारे पास में, सीना कैल्सेट नहीं होता था, तो फिर हम क्या करते थे कि हम सेकेंडरी को टर्शरी में कन्वर्ट कर, मतलब अगर आप इलाज नहीं करोगे तो सेकेंडरी टर्शरी में चला जाता है, तो देन इट बिकम्स ऑटोनोमस, सो इट इज प्रिवेंटेबल ना। Like tertiary hyperparathyroidism causes hypercalcemia. That's the difference. I agree to that. But then the point is nowadays it's not gonna happen because we treat CKD. चलो चाय पीते हैं। Okay, guys, please join back so that we can get started. Okay, I think we are good to go for this current session. The topic of interest now would be pneumothorax, which is taught in surgery also. And like, I think this is where, hi Priyesh, Nadeem, Saurabh, like, I think you will be pretty relaxed with when it comes to this topic. I'll keep on quizzing you in between as well, usual. If you focus on this X-ray, there is absent lung markings in this case. That's main highlight. Normally तो lung की blood vessels को आप देख पाते हैं and the blood vessels tend to taper out as we go towards the periphery. But ये तो पूरा का पूरा like black color का lung है. The lung is gonna be jet black in color. So the word here is absent vascular markings. और vascular से भी ज़्यादा मैं बोलूँगा, ज़्यादा आसान है याद रखना. रेडियोलॉजिस्ट तो बड़े थोड़े फैंसी वाले वर्ड बोलते हैं ना, हाइपर ट्रांसलुएंट लंग. In my opinion, start trying and remember that word hypertransluent lung. Simple word याद कर लो. Absent lung markings they are written because आगे मैं बोलूँगा absent breath sounds, absent air entry, तो वो यूनिफॉर्म हो जाता है. Absent air entry, absent breath sounds, absent lung markings are a feature of pneumothorax in a patient. और ये जो दिख रहा है आपको, ये collapsed lung. This is basic. देखो लंग में हवा होती है तो काला दिखाई देता है ना, लंग में हवा नहीं है तो वो व्हाइट दिखाई दे रहा है. सो न्यूमोथोरैक्स एक्सरे इज वन ऑफ द इजीएस्ट वंस टू आइडेंटिफाई एंड ट्रेकिया की पोजीशन पे ज़्यादा रिलाई नहीं करना क्योंकि एपी व्यू होता है और एपी व्यू में ट्रेकियल पोजीशन इज नॉट वेरी वेरी रिलायबल. सो द इजियर वे टू आइडेंटिफाई इज दैट ओके द लंग इज मोर ब्लैक एज कम्पेयर टू नॉर्मल. मोर ब्लैक लंग इज इन सीओपीडी ऑल्सो, बट वहाँ पे लंग मार्किंग्स नहीं होती हैं. So the key thing for this question is absent lung markings as are highlighted. And now let me explain to you. I think people have joined in. The topic that we study is pneumothorax, and the case that I'm describing is of a patient who got a stab injury to the chest. This was a penetrating injury. It will create a suction wound. ये जो penetrating injury होती है, ये एक suction wound create कर देती है. इस suction wound की वजह से क्या होता है कि हवा अंदर तो चली जाती है लेकिन बाहर नहीं निकल सकती है. मैं ऐसे बोल सकता हूँ कि जैसे आप अपनी गाड़ी के टायर में जब हवा भरते हैं or when you fill tire into the tire of your bike, then you will notice air will go inside but will not be able to come out. If you have a one-way valve, similarly in this particular case there would be a sucking wound created. That sucking wound would cause air to go inside and not come outside, so it will behave like a one-way valve. The pressure outside in the atmosphere is 760 millimeter of mercury, and the pressure in the intrapleural space, that is between the visceral and the parietal pleura, is in negative. The pressure in the intrapleural space is -2 to -6, and then is centimeter of water. So you can notice that there is a huge pressure difference between the atmosphere and the covering of our lung, and therefore this is like a one-way entry into the chest cavity, that the air will accumulate between two layers of the pleura. I will just give a symbolic representation. This is the parietal pleura, which is adherent to the lung. Sorry, visceral pleura, which is adherent to the lung. And the second one that I'm marking in color green, this is gonna be the one that was breached here. This is the parietal pleura. So air is accumulating between the two layers of the pleura, the visceral and the parietal pleura, as I've shown in the line diagram. The bad news is that the lung has got deflated. So person will be operating on only one lung, and if person will operate on one lung, then I can say God has given us two lungs. Now only one lung is operating. Saturation will begin to fall. The reason why the lips of the patient will start turning blue is because only one lung is functioning. God has given us two lungs for functioning, so therefore the saturation will begin to fall. The bad news is that the pressure in the chest will also start affecting the venous return. You see here, there would be veins. The vein would be like inferior vena cava coming in the right side. We are having superior vena cava coming in the right atrium. So because the pressure is turning positive, it will also cause kinking of the great veins in the chest. The biggest problem with respect to pneumothorax is that the superior vena cava and the inferior vena cava will exhibit a kinking, that is वो दब जाएंगे. Because of this, the venous return to the right side of the heart will become almost zero, and if the venous return to the heart will become almost zero, the BP will crash. When to say tension pneumothorax? It is hemodynamic instability. When to say tension pneumothorax? When the BP of the patient will begin to fall This is the main thing that I want you to understand, that in tension pneumothorax, tension word का बोलना है when the patient's blood pressure will begin to crash, hemodynamic instability will be occurring. All these findings that I have described here before you are technically called as obstructive shock. In cardiology, I taught you obstructive shock in the form of cardiac tamponade, but today I am teaching you the second cause of obstructive shock, which is tension pneumothorax. In this particular condition, the heart is beating, but the pulse is absent. You can yourself see why the pulse is absent is because in this patient, the venous return to the heart will become zero. If there is no input, there is no output, and therefore the pulse is absent. So I can at this moment say that this is also an example of pulseless electrical activity. For management of this condition, you will not be giving a DC shock. You will be putting a wide bore needle in the fifth or the second intercostal space depending on the age. You will not be giving a DC shock to the patient, so the examiner will once again quiz your knowledge regarding whether it is a shockable rhythm or whether tension pneumothorax is a non-shockable rhythm. As I explained to you, the heart is beating, pulse is absent. You will put a wide bore needle in the fifth or the second intercostal space as the case may be. So at this moment, when I start this topic, I think a couple of words are very clear. The first word that I want you to be very clear is the word obstructive shock is a feature of tension pneumothorax. This is the second example of obstructive shock. The first one that was taught to you for obstructive shock was tamponade. Some MCQs will use the word pulseless electrical activity. Some MCQs will use the word non-shockable rhythm. They deliberately will use this kind of terminology because they want you to think in terms of cardiovascular perspective. But then what will be given in the question? That immediately you will know that this question is not from the topic of cardiology, but is from the topic of respiratory system. The question will mention auscultatory findings. When you will be putting your stethoscope over the chest of this patient, if I zoom into this diagram where the superior vena cava IVC were kinked, if I place my stethoscope on this particular area, and if I will try to auscultate this patient, the auscultatory finding of this particular question will always say the word absent air entry, absent breath sounds. Whenever you read this phrase, absent air entry, absent, because there is no lung, man. You see the lung is totally collapsed. It is crushed by the air and positive pressure accumulating between the two layers of the pleura, the visceral and the parietal pleura shown in blue and green. So therefore there is no air entry happening. So absent air entry and absent breath sounds will immediately tell you that this is not a question of that cardiac tamponade, obviously, and the person is having tension pneumothorax. Let me just summarize. I think everybody has joined in at the moment. Tension word in the MCQ कब बोलना होता है? When any of the following, when any of the one words, any one of these are present. Either he may write the word hypotension / crashing patient, or if he mentions the word mediastinal shift or apex beat displaced away, like normally our apex beat is in the fifth intercostal space 2 centimeter midclavicular line. If he has an injury, then the apex beat will be shifted towards the right of the midclavicular line or will go in the interaxillary. The question will also mention the word elevated jugular venous pressure. If any one of these findings are present, we will say patient is having tension. I want to bring to attention of everybody in the MCQ of yours, recent in FMG and NEET, the word also traumatic pneumothorax was given. If the BP is recordable, if mediastinal shift is not described, elevated JVP is not given, then you will answer traumatic pneumothorax in a patient. If any one of these findings are given, mediastinal shift, hypotension, elevated JVP, then it is tension pneumothorax. And for pneumothorax, obviously, like I have said it, and I have it on the text matter here as well, that is absent air entry, absent breath sounds, and hyperresonant percussion node 4, 5 and 6. 4, 5 and 6 help me in diagnosis of pneumothorax. And any one of point number 1, I'll just zoom. Yeah, now it's better. If these words are written, absent air entry, absent breath sounds, hyperresonant node, that means that you're dealing with the case of pneumothorax, and then any one of the remaining things like hypotension, mediastinal, elevated shift, that is going to be indicative of the word tension. If those words hypotension are not given with absent air entry, absent breath sound, then answer it as traumatic pneumothorax. This is one of the commonest mistakes that I see people making. In traumatic pneumothorax, you will not be putting a wide bore needle. You put a wide bore needle only in case of tension pneumothorax. There I will put a chest tube directly. But in tension pneumothorax, because it's a medical emergency, the BP is crashing, I need to put needle. so that some little bit of air can come out. So at least the pressure on the great veins becomes relatively lesser. The lung will also re-expand. The pressure on the great veins will also be lesser. So at least the BP will become recordable. The rationale for putting a wide bore needle written as needle thoracostomy is to make the BP from unrecordable to recordable. If BP is already recordable, you don't need to put a wide bore needle is the final summary that I want to say for this condition, which most of the time will be easy to identify on the basis of the word gunshot injury or stab injury to the chest. Like a couple of guys, they went to a discotheque. They had a fight with the bouncer. Now these bouncers are rowdy people, so they got stabbed in the chest and therefore the pneumothorax manifestation would be occurring. Now, if you change the position of the stethoscope, yeah, I will write traumatic again. If you place the position of a stethoscope and you place your stethoscope over this area that is around the heart of the patient, same victim around the heart, the air can be dancing. Air can reach up to the traumatic knife hai na, so knife can reach up to and can cause a deep injury, so there can be air dancing around the heart also. What I'm trying to say is that sometimes you could be having coexistent pneumomediastinum present in the case also. What will be the auscultatory finding of coexistent pneumomediastinum in the patient is what I described next, though some people have commented, but I'll just do the talking once again of what is the auscultatory finding of pneumomediastinum. The sound that you will hear here will be as if somebody is walking on freshly fallen snow. A lot of you have been abroad, you would have seen snowfall. So somebody is walking on freshly fallen snow with leather boots on. तो बर्फ पे चल रहा है तो पच 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 की आवाज आ रही है. This is called as Hammond Crunch sign. This again is a question of your exam, that Hammond Crunch sign is the auscultatory finding of. Your answer is pneumomediastinum is where the Hammond Crunch sign can be seen. I'll write the duty once again. I'll write the finding again. Crunch मतलब जैसे चिप्स नहीं खाते, लेज के अपने क्रिस्प खाए, चिप्स खाए तो क्रिस्प, that when you eat chips you get that crunch sound. The word is Hammond Crunch. It's an auscultatory finding as if somebody is walking on snow with leather boots. Is the heavy duty military grade leather boots is the description with respect to Hammond Crunch sign. This finding may or may not be given in the question. This may not or may not be given. This is not how I diagnose the condition. The diagnosis is based on the aspect that I said. If obstructive shock is present in a patient, you say tension pneumothorax. Otherwise, I will say traumatic pneumothorax. अगर unrecordable BP नहीं है तो traumatic pneumothorax ना, it could be only hemothorax in a patient and that can cause internal bleeding, but it is not making the blood pressure unrecordable. So 1, 2, 3 are of obviously a paramount importance. If it is traumatic pneumothorax and he says क्या करोगे, it is X-ray, but if it is tension pneumothorax you straight away have to answer wide bore needle. No time out doing X-ray. अगर BP क्रैश कर रहा है यार तो मैं एक्सरे थोड़ी ना कराऊंगा. अगर mediastinal shift present है, elevated JVP है, हार्ट दब रहा है, बाहर से पॉजिटिव एयर प्रेशर वाली एयर उसको दबा रही है, then I will not go for X-ray. I will go for the standard treatment which you are all familiar with, comfortable with from a surgery class, but I'll write it here. You will be putting in a wide bore needle. This wide bore needle will be put in the second intercostal space or in the fifth intercostal space as the case may be. The objective of putting the wide bore needle is primarily to decompress the chest cavity of the patient which is having air at positive pressure. सारी एयर तो निकलेगी नहीं, इतनी भी मोटी needle डाल दो कि सारी एयर तो निकलेगी नहीं ना. So it will always be like you have to like use a chest tube. This is just a temporary solution to ease off the pressure on the great veins and reduce the obstructive shock. So the needle will be put in the fifth intercostal space. Most of the time it will be put in anterior to the mid-axillary line. Yes, I will put it in the triangle of safety, agree to that, but triangle of safety as a phrase is like more appropriate for the chest tube. So at the needle that I'm putting, the word is fifth intercostal space anterior to the mid-axillary line. Obviously, this is the data for adults. If it is child, then I will say second intercostal space, and then the area where I put the needle will also change. That would be lateral to the mid-clavicular line of the patient. So at this moment, I want to bring to your attention that when it comes to adult in a patient, it is usually the fifth intercostal space anterior to the mid-axillary line. If it is a child, I will be putting the needle in the second intercostal space lateral to the mid-clavicular line. In recent FMG exam question, unfortunately, it was adult and fifth intercostal space was not given. lot of students got confused and they left the question or they got it wrong कि सर fifth तो दिया नहीं था. So if in the adult patient fifth intercostal space is not given, no problem, you can do it in the second also. I have written second intercostal space for both adult as well as children. The ATLS guidelines mention adult can be put a needle in both fifth as well as the sixth space. In fact अभी जो guidelines है वो fifth की है. When I was a student it was second only. Second मतलब क्योंकि air rise करती है. Why they changed that was because now we get this in soldiers who are wearing bulletproof vest. Bulletproof vest के through bullet चलेगी chest में, तो obviously like you know आजकल high velocity high power rifles होती है, so individual can get injured also because of a high power rifle which the bullet went through the bulletproof vest. You know, like the guy, you know, who shot at Trump yesterday, the soldier got injured. Now one of the security guys got injured because the bullet went and injured his chest. It is causing bruising only, but luckily, like you know, it was a high power rifle he was trying to use, and routine the policeman will use a vest which is not designed to stop that high velocity bullet. So in those circumstances, like unfortunately, like this soldier who would have got injury did not develop a pneumothorax. But if you don't have time to remove the vest, ना vest इतनी भारी होती है, 18 किलो की vest होती है. और पेशेंट ऐसे सोल्जर गिर गया, मान लो 80 किलो का सोल्जर और 18 किलो की वेस्ट, तो आप उठाओगे कैसे? So in those circumstances you can put the needle in the fifth space. So any of the two can also be there. So you can either be using the fifth space or you can be using the second space. Seventh space is answer for thoracocentesis. जब छाती में पानी भर जाता है, जैसे किसी को टीबी हो गई, तो टीबी की वजह से जो छाती में पानी भर जाता है उसके लिए हम यूज करते हैं सेवंथ या एट्थ इंटरकॉस्टल स्पेस. सो आई विल कम टू योर क्वेश्चन ऑफ सेवंथ इंटरकॉस्टल स्पेस ओनली. लेकिन अभी तो हवा की बात कर रहे हैं यार, अभी पानी की बात नहीं कर रहे हैं. सो होल्ड ऑन. Thoracocentesis, when it comes, will be the next topic, that is pleural effusion. Right now we're discussing pneumothorax. It is fifth space which would be utilized routinely. If not answered, then the answer is second intercostal space lateral to the midclavicular line. So we will go for a wide bore needle thoracostomy, not a thoracotomy. है ना, इंग्लिश में घुमाने की कोशिश कर रहा है. वाइड बोर नीडल thoracostomy because you're making a hole. I've written couple of data in bold. These are non-negotiable data. This is non-negotiable data. In all cases the tension pneumothorax where the BP is crashing, you have to put a wide bore needle thoracostomy. तो needle डालते ही उस पे ना hissing sound प्रोड्यूस होती है, इससे प्रेशर कुकर पे सीटी बजती है ऐसे. That's because the air will escape. But then the point is, it is not a permanent solution. It is not that it will cure the patient. It is just a temporary maneuver to ease off the pressure. What is the main treatment? The main treatment is ICD, that is intercostal drainage tube. The main treatment is ICD. The main treatment is ICD. You will be putting in this patient ICD. That is basically a intercostal drainage tube. This intercostal drainage tube by default is always put in the fifth intercostal space, and it will be put in the triangle of safety. I will be mentioning the boundaries of the triangle of safety when I'm done with this set of discussion. But at the moment, I want to highlight that the main treatment for this guy is not a wide bore needle. It is just a temporary solution. It is a intercostal drainage tube that will be put in the patient in the fifth intercostal space in the triangle of safety. Those who have worked in the hospital, बताओ कौन से नंबर की ट्यूब डालोगे? The patient is a victim of gunshot or maybe like stab injury to the chest. कौन से नंबर की ट्यूब डालोगे? Just general question, not important for the exam, just general. You ask the nurse for chest tube, now कहती है सर कौन से नंबर की चाहिए? Yes. Waiting for your answers. Sir, you put a wide bore needle ना, इतना 36 to 40 French gauze. मोटी ट्यूब डालेगी, खून होता है ना, खून जम जाता है. If it is a motor needle, then it is a 36 to 40 French gauze needle that will be put. Otherwise, we usually put like something in the range of 32 to 36, 36 to 40 for those big ones, right? The chest tube that is put is 36 to 40 French gauze tube that is put. That's to decompress because lots of time there can be blood also present. Lots of time there can be blood also present in this case. Hemopneumothorax, na stab injury मैंने बोला, या I said bullet injury in a patient, then it is a chest tube that will be put. और उसके बाद में आता है main treatment. एक्चुअली में चेस्ट ट्यूब डालने से थोड़ी ना हवा निकल जाएगी. चेस्ट ट्यूब कैसे निकलती है? तो चेस्ट ट्यूब मतलब चेस्ट ट्यूब से हवा कैसे निकलती है? तो यू कनेक्टेड टू, दिस इज द गेम चेंजर. लाइक आई वाज टीचिंग यू दैट कार्डियक अरेस्ट के पेशेंट में एड्रेनलिन इज द गेम चेंजर, इन वेंट्रिकुलर फिब्रिलेशन डीसी शॉक इज द गेम चेंजर. वैसे यहाँ पे एक बैग होता है, उस बैग की फोटो भी दे रखी है यहाँ पे, अभी हम डिस्कस करेंगे उस बैग को. यू कैन सी अ बैग प्रेजेंट हियर. दिस इज द रियल गेम चेंजर गाइस. ये जान बचाता है. This is what saves the life. So what you will do next in the patient is that you will be connecting the chest tube to underwater seal drainage. This is the underwater seal drainage bag, and this is the real game changer क्योंकि ये negative force create करता है, and then negative force will cause evacuation of air from the chest of the patient. So there are total 3 steps in this particular case. सबसे पहले डालते हैं wide bore needle in a patient. So if he simply says what is the main treatment of this patient, first line management, answer is wide bore needle thoracostomy. Answer would be 5th intercostal space, if not in the option 2nd intercostal space. If he says what is the treatment of choice of this condition, then the treatment of choice for this condition is chest tube plus. I'll write this underwater seal drainage word again in capital just to emphasize the importance of it. Just give me a few seconds to just write down the data. This underwater seal drainage bag is the real game changer because it generates negative force, it generates negative pressure, and you can adjust the force of the negative pressure also. The treatment of choice is chest tube with. जो खाली चेस्ट ट्यूब डाल देंगे तो एटमॉस्फेयर के अंदर चली जाएगी. चेस्ट ट्यूब डाल के छोड़ दिए तो ऐसे थोड़ी ना हवा निकलनी शुरू हो जाएगी, एटमॉस्फेयर की एयर भी अंदर चली जाएगी. तो अंडर वाटर सील ड्रेनेज इज द मेन ट्रीटमेंट बिकॉज इट जनरेट्स नेगेटिव सक्शन फोर्स, एंड दैट नेगेटिव सक्शन फोर्स विल कॉज इवैक्यूएशन ऑफ बोथ ब्लड एंड एयर फ्रॉम द चेस्ट ऑफ दिस पेशेंट. सो एट दिस पर्टिकुलर मूवमेंट द मेन एस्पेक्ट इज कि पहले क्या करना है और ट्रीटमेंट चॉइस क्या करना है. और इस पेशेंट में बिकॉज इट इज अ मेडिकल इमरजेंसी, एक्सरे विल बी डन after I have done a chest tube insertion and connected it to underwater seal drainage because I will not have time. But in a traumatic pneumothorax patient where BP is recordable, I can first do X-ray and then confirm and then plan a chest tube for the patient. There is no need of wide bore needle in a traumatic pneumothorax, but it is a wide bore needle only for tension pneumothorax. Tension word का बोलना जब BP unrecordable हो जाता है. Majority of questions will always give you vitals, pulse, BP, etc. So you need to answer according to the information that I have provided. Let's have a look at the triangle of safety at this moment. The triangle of safety would be a couple of muscles that you can see in the representation here. You can see anterior boundary is formed by pectoralis major muscle. The posterior boundary is formed by latissimus dorsi, and then is gonna be the inferior boundary. Inferior boundary is formed by, then your answer is 5th intercostal space. Let's do this again. What is the anterior boundary of the triangle of safety? Pectoralis major. What is the posterior boundary? It is latissimus dorsi. What is the inferior boundary? The inferior boundary is the 5th intercostal space. So the chest tube is inserted in the 5th intercostal space. That's called as triangle of safety. In the same area, you are putting the needle also initially. But then subsequently, like you have to work, and the needle is not going to be a permanent way to evacuate the air in the chest of this patient. So you can see a doctor putting in a wide bore needle anterior to the mid axillary line. It is not anterior axillary line, it is not mid axillary line, it is little anterior to the mid axillary line, where a 14 gauge needle or angiocatheter can be used, which is perpendicular to the chest wall, and that is what we are trying to get access into the pleural space of the patient. Subsequently in this patient we will be putting in a bag, and this bag is the main treatment. So bag में तो देखो यहाँ पे एक तो collection chamber होता है. In this collection chamber there would be blood present. In the collection chamber there would be blood, क्योंकि जब आप bullet लगी या knife लगा तो blood भी होगा. So you can see the blood accumulating in this area, और इस वाले area में बुलबुले आते रहते हैं. बुलबुला you understand हिंदी ना, bubbles. So यहाँ पे bubbles आते रहते हैं, intermittent bubbling होती रहती है. That intermittent bubbling would tell you that air is getting evacuated. So what you can see in this particular line diagram is two things. This is the air collection chamber. ये जो bag होता है इसका initially air collection chamber होता है, और along with the air collection chamber the second area जहाँ पे मैंने लाल दिखाया है, that is the blood collection chamber. So like both of them which are present in the chest will come out, but they'll not come out together. They'll be accumulating in two different areas, and we can adjust the force of the negative suction. यहाँ पे ये negative suction knob है, इस knob से हम ना pressure को change कर सकते हैं. To the knob you can adjust the pressure, because if there's like a substantial amount of blood and air, I need to evacuate them relatively faster. So what we will do for this particular patient is a quick recap. एक बार ही बोला कि बता दो सर, तो एक बार quick recap कर लेते हैं. The guy got a stab injury to the chest. Like let's look at it. This guy went to a discotheque, or like this particular person had a fight with somebody who stabbed him in the chest. तो एयर जो है वो कहाँ एक्यूमुलेट करेगी? इट विल एक्यूमुलेट बिटवीन द टू लेयर्स ऑफ द प्लूरा, विसरल एंड द पैराइटल प्लूरा, और वो हार्ट को भी दबा देगी. और हार्ट को दबाएगी. हार्ट को दबाने का मतलब कि मेनली द एसवीसी एंड द आईवीसी विल गेट कंप्रेस्ड. तो वेनस रिटर्न जो है जीरो हो जाएगा, बीपी क्रैश कर जाएगा. तो टेंशन वर्ड बोलते हैं जब बीपी क्रैश कर जाता है, और न्यूमोथोरैक्स के लिए जो वर्ड होता है दैट इज एब्सेंट एयर एंड ब्रेथ आउट। मिनिमम जो आपको फिलहाल आना चाहिए राइट नाउ राइट हेयर इज, when do you say the word tension, hemodynamic instability, when do you say pneumothorax, absent air entry and absent breath sounds in a patient, hyperresonant note दे दे तो अच्छी बात है, otherwise absent air entry, absent breath sounds are the core things। then he will say कि करोगे क्या। तो द फर्स्ट स्टेप इन द मैनेजमेंट ऑफ दिस पेशेंट विल बी दैट, यार आप लोगों ने सर्जरी में नहीं पढ़ा क्या ये टॉपिक, मतलब वेरी शॉकिंग दैट आई एम गेटिंग रिपीट्स बोल रहे हैं यहाँ पे, मतलब आई थॉट कि दिस वुड बी अ ब्रीज। ओके चलो एनीवे आई डू दैट, आई डू दैट, माय जॉब। इफ ही सेज कि सबसे पहले क्या करोगे, तो सबसे पहले हम डालेंगे वाइट बोर नीडल। वाइट बोर नीडल से ऐसे ऐसे प्रेशर कुकर पे सीटी बजती है, ऐसे करके थोड़ी सी हवा निकल जाएगी, तो एटलीस्ट प्रेशर ऑन द एसवीसी विल बिकम लेस। बट उसके बाद में चेस्ट ट्यूब डालनी पड़ेगी। So first line management is wide bore needle, second is chest tube to be inserted। अब वाइड बोर नीडल कहाँ पे डालते हैं वो मैंने साइट्स बता ही चुका हूँ, फिफ्थ स्पेस एंड सेकंड स्पेस। अडल्ट में दोनों में से कोई भी यूज कर सकते हैं। फर्स्ट प्रेफरेंस इन अडल्ट, अडल्ट बड़ा होता है तो 5 नंबर, बच्चा छोटा होता है तो 2 नंबर। फिर से बोल रहा हूँ, अडल्ट बड़ा होता है तो 5 नंबर, बच्चा छोटा होता है तो 2 नंबर। दैट इज हाउ यू कैन रिमेंबर इट, दो आई सेड यू कैन यूज सेकंड फॉर इवन अ अडल्ट ऑल्सो। Then you put in a chest tube by default in the fifth intercostal space in the patient, and then we will connect him to a underwater seal drainage। The real game changer is part number 3, the underwater seal drainage, जिसमें जब आप बैक कनेक्ट करोगे तो बैक को आप चेस्ट ट्यूब से कनेक्ट कर दोगे ना। आपने तो चेस्ट ट्यूब डाली थी, दैट चेस्ट ट्यूब विल बी लाइक दिस ना। You will notice that this is gonna be a chest tube that is put in the, this is the chest tube which is connected to the underwater seal drainage। The underwater seal drainage will basically allow the blood to accumulate and will allow air to evacuate। और इसमें जो बुलबुले आते हैं वो कंटिन्यूसली नहीं आते हैं, वो इंटरमिटेंटली आते हैं। अगर कंटिन्यूस आएंगे तो अभी पढ़ेंगे व्हाट इज द रीजन व्हाई कंटिन्यूस बबलिंग इज हैपनिंग, बिकॉज यू हैव टू कनेक्ट द बैग ना। यहाँ पे कनेक्टर लगा होगा बीच में, सो फ्रॉम द कनेक्टर टू द बैग वी विल बी कनेक्टिंग द ट्यूब टू द underwater seal drainage, and this is the real game changer as I've said। air collection chamber, blood collection chamber present। एयर कलेक्शन चैम्बर में यू विल हैव इंटरमिटेंट बबलिंग इन द पेशेंट। जैसे कि मैंने बोला कंटिन्यूस बबलिंग हो रही है, लाइक आपने रिलेटिव को बताया था कि भी ऐसे इसमें बुलबुले निकलते रहेंगे और तेज तेज आए तो मुझे बता देना। तो यू हैव नाउ पुट द चेस्ट ट्यूब एंड नाउ यू वर लाइक, आपने सोचा थोड़ा सो लेते हैं, आप अपने ड्यूटी रूम में गए, अभी आप लेटे ही थे तो रिलेटिव आ गया, 15 मिनट का भी एडमिट हुआ है पेशेंट पहले, तो आ गया सर जी वो पेशेंट जो है ना डॉक्टर साहब, वो उसमें ना बुलबुले बड़ी तेजी से आ रहे हैं। आपने उसको इन्फॉर्म किया था कि भाई तुझे दिखे ना तो मुझे बता दियो, वैसे तो आपकी रिस्पॉन्सिबिलिटी होती है, बट यू थॉट यू टायर्ड एंड यू जस्ट टेक अ रेस्ट। तो आया, नॉक किया, डॉक्टर साहब वो जरा देख लो प्लीज। तो द मोमेंट यू गो एंड सी कि यहाँ पे तेज तेज बुलबुले आ रहे हैं, दैट इंडिकेट्स द फैक्ट दैट आई कैन पीपल कमेंट इन द चैट बॉक्स व्हाई विल यू गेट कंटिन्यूस बबलिंग, दोज हु अटेंडेड अ सर्जरी क्लास गाइस, क्यों कंटिन्यूस बबलिंग होती है। यहाँ तो बुलबुले इंटरमीडिएट, जैसे एक निकला दूसरा निकला, ऐसे ऐसे मतलब फेज में आते जा रहे हैं, तेज 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 बुलबुले निकल रहे हैं। तो व्हाई वुड दैट हैपन। आपका आंसर होगा एयर लीक। एयर लीक मतलब ये जो कनेक्टर होता है ना, अगर आपने इसको ठीक से कनेक्ट नहीं किया, इफ द कनेक्टर इज नॉट कनेक्टेड प्रॉपरली देन एटमॉस्फेयर की एयर विल बी सक्ड इन, then the atmosphere की air will be cut in। The number one reason for continuous bubbling of air, the number one reason for continuous bubbling of air is what is called as air leak। What I mean by air leak is the poor connection। आपने ट्यूब को और बैग को कनेक्ट करना है ना सर कनेक्टर के थ्रू, अगर आपने प्रॉपरली कनेक्ट नहीं किया तो इससे दिस बैग जनरेट्स नेगेटिव प्रेशर, तो ये जो एटमॉस्फेयर की हवा खींचना शुरू कर देगा। सो इट आंसर इज एयर लीक। एयर लीक बेसिकली मीन्स दैट इट इज अ पुअर कनेक्शन। तो वन डॉक्टर हैज आंसर्ड वेरी वेरी राइटली, दैट इज द इनिशिएट क्वेश्चन जहाँ पे उसने बोला कि एयर लीक नहीं है। नाउ व्हाट कुड बी द पॉसिबिलिटी, द पॉसिबिलिटी इज कि स्टैब इंजरी जो थी उसने लंग को भी डैमेज कर दिया, तो लंग की हवा प्लूरल स्पेस में आती जा रही है कंटिन्यूसली, बहुत लार्ज वॉल्यूम में, जितनी बार सांस लेगा उतनी बार हवा जो इंस्पिरेटरी एयर है वो भी जा रही है। सो द नेक्स्ट पॉइंट इज एक्सक्लूसिवली फॉर इनिशिएट एंड नीट पीजी एस्पिरेंट्स, क्योंकि आपके लिए तो वो इतना सिंपल तो करेगा नहीं कि भाई पुअर कनेक्शन है। तो आपके लिए क्या टेक्निकल आंसर होगा, ब्रोंको प्लूरल फिस्टुला। ब्रोंको प्लूरल फिस्टुला मीन कि लंग के टिश्यू को डैमेज हो गया, लंग के टिश्यू को डैमेज हो गया तो जितनी बार सांस लोगे तो हवा और जाएगी प्लूरल स्पेस में, उससे कंटिन्यूस बबलिंग होती रहती है, लेकिन उसमें तो ना फिर स्टार्टिंग में से ही होगी। अगर ब्रोंको प्लूरल फिस्टुला है ना तो मोस्टली स्टार्टिंग में ही कंटिन्यूस बबलिंग प्रेजेंट होगी। यहाँ पे मैंने थोड़ा केस बना के आपको बोला कि यार आपने अभी जैसे ट्यूब डाल दिया तो इट इज इंटरमिटेंट बबलिंग एंड लाइक 1 घंटे के बाद में रिलेटिव केम के डॉक्टर साहब अभी कंटिन्यूसली आ रही है। तो बिकॉज पेशेंट वॉज शिफ्टेड फ्रॉम द माइनर ओटी टू द वार्ड, पहले माइनर ओटी में रहते हैं ना चेस्ट ट्यूब को, तो बेड पे शिफ्ट करते हैं, वार्ड में शिफ्ट करते हैं, शिफ्टिंग के दौरान क्या है वो कनेक्शन लूज हो गया। पेशेंट, यू पुट द चेस्ट ट्यूब इन द माइनर ओटी And from the minor OT, then the patient will be sent over to the ward, the emergency ward or like the main surgical ward. तो वो लिफ्ट विफ्ट से लेके जाते हैं पेशेंट को स्ट्रेचर पे डाल के. तो on that transit route, probably due to pulling and because when you're shifting a patient, then you understand, the patient has to be mobilized, 2-3 people are required. तो कहीं ना कहीं वो connection हिल गया होगा. तो that is like the usual reason why it can happen, air leak and a poor collection. But obviously like bronchopleural fistula is a good answer. Pranav and couple of other people have answered. And now comes the issue which is like a question open to everybody कि intermittent bubbling रुक गई है. रिलेटिव को आपने बोला था कि नहीं इसमें बुलबुले आते रहने चाहिए. And the intermittent bubbling stops after, let me say, 1 hour. Intermittent bubbling stops after 1 hour. And the relative came, वो कह रहा डॉक्टर साहब आपने बोला था कि ना इसकी हवा निकल रही है छाती की, तो अभी 1 घंटे बाद हवा निकल गई सर, अब तो बबल्स बंद हो गए. वो सोच रहा है कि भाई ऑल एयर इज आउट, कि सर 1 hour इज पास्ट बाय. व्हाट कुड बी द रीजन? देन योर आंसर इज ट्यूब दब गई होगी. देखो सर, हॉस्पिटल का जो मैट्रेस होता है ना, गद्दा जो होता है, दैट इज वेरी थिक. सो लॉट्स ऑफ द ट्यूब कैन गेट कंप्रेस्ड अंडर द हॉस्पिटल मैट्रेस इन द बेड, एंड बिकॉज ऑफ द ट्यूब किंकिंग, the air will stop coming out. Another possibility, yes, tube can be blocked by blood. So Rohit, you have a very good point, but then my point is usually we put a wide bore cannula, so thoda sa less hai. So can I have one more answer? Rohit, your point is right, tube clotting of blood in the tube. जब भी hemothorax होता है ना, we put two tubes, one for air, one for blood, because we want to, and the position of the tubes is also different. So like, your point, I am not totally trashing it, but like I want a different reason actually, like, that the tube से अब air निकलनी बंद होगी. Displacement, exactly. Yashika was spot on there. Displacement, dislodgement. Actually displacement नहीं बोलेंगे, हम टेक्निकल वर्ड बोलेंगे dislodgement, क्योंकि जब पेशेंट को हम शिफ्ट करते हैं तो पुलिंग की वजह, दो वी पुट अ सूचर ना, वी पुट अ ट्यूब और यहाँ पे स्किन से उसको सूचर कर देते हैं ताकि निकले ना, बट समटाइम्स द सूचर कैन आल्सो कम ऑफ. सो डिसलॉजमेंट ऑफ द ट्यूब इज अनदर रीजन, कि जो ट्यूब इंटरकोस्टल स्पेस से अंदर प्लूरल कैविटी में गई हुई थी वो वहां से निकल गई है. तो डिसलॉजमेंट ऑफ द ट्यूब इज अ डिस्टिंक्ट पॉसिबिलिटी. एंड नाउ आई हैव गुड न्यूज. द गुड न्यूज इज कि 7 days के बाद में या 10 days के बाद में, वट एवर आफ्टर 7 days, देयर इज बबलिंग स्टॉपिंग. If bubbling will stop after 7 days, then I'm happy, because अब लंग क्या धीरे धीरे expand कर गया था, because the air got evacuated from the visceral and the parietal pleura, so the lung will gradually re-expand. So this is good news. This is gradual re-expansion of the lung, and this explains the fact that क्यों हम इन patients में daily basis पे chest x-ray करते हैं monitor करने के लिए, and you compare the previous x-ray with the previous day's x-ray and previous with previous day's x-ray, तो lung धीरे धीरे expand करता रहता है. So after 7 days, it is good news, like if the bubbling will stop, because obviously the lung is re-expanded, but initially if it stops, then it is a cause of concern. So the blue data is the only one to be remembered, though this is a bit of surgery, but then for examiner उसके लिए medicine surgery नहीं है. वो तो हमने मन में धारणा बना रखी है, this is medicine and this is surgery. For the examiner, it's just a simple topic that they're putting up, and that is why they ask about these aspects also. And now I have a very important question for all of you. Blood is also coming. How much blood should come? How much blood should come for how many hours? That you are gonna call the surgeon for an emergency thoracotomy, because if the guy was stabbed in the chest और से knife घुमा दिया, then the injury too could have occurred to bronchial artery, bronchial vein, pulmonary artery, pulmonary vein. The guy is bleeding in the chest. All the blood will be lost from the body. So how much blood? Like the surgeon तो ट्यूब डाल के मेजर ओटी में चला गया, जो लीड सर्जन था, he put the tube, he went to the major OT for case, you are the intern on duty. How much ml of blood for how many hours? Then this is again a very repeat question, that if the drain amount is more than 200 ml for 2 consecutive hours, you have to inform the surgeon that, sir, this question is never ever to be forgotten. This is a very oft repeated question of your exam, that when would you inform the surgeon for performing emergency thoracotomy if you notice that more than 200 ml of blood is present in the collection chamber for 2 hours. जैसे अभी ट्यूब डाला 200 ml आया, फिर अपने नर्स को बोलते हैं आवरली चार्टिंग करने के लिए, तो 250 ml अभी आया था, अगले आवर में फिर 350 आ गया. So total amount is exceeding 400 ml threshold, no? Like 200 ml per hour for 2 hours. So total amount इतना चाहिए 400. So like first hour it was 250, next hour it is 350, because the guy is bleeding inside the chest. He's lost almost more than half a liter of blood. Immediately call the surgeon for what? The surgeon क्या करेगा? उसका काम ही यही है, चेस्ट को ओपन करके हेमोस्टासिस अचीव करेगा. why the surgeon should be informed is, I will obviously plan a blood transfusion for this guy while the surgeon is on his way, but the main way to manage this patient is emergency thoracotomy with hemostasis, because if we don't do that, the guy will literally bleed into the chest cavity, maybe 1.5 liter and even more, because if a person is very tall, Jat from Haryana, the chest cavity is very big, like tall vascular guy, you could lose almost all of the blood of the body into the chest cavity. The second answer to the question that I raised was, कितने से ज़्यादा ब्लड यहाँ पर प्रेजेंट हो, दैट सिंगल रीडिंग पे भी, दैट इज 1.5 लीटर की, जैसे अभी आपने ट्यूब डाली 1.5 लीटर ब्लड निकल गया, तुरंत ओटी में लेके जाना। आप ट्यूब डाले तो यहाँ पे भरना शुरू हो जाएगा ना, आप देखो ना यहाँ वैल्यूज लिखी हुई हैं 200 ml, 300, 400, 500, 600 लाइक दैट। तो सडनली पूरा 1.5 लीटर भर गया ट्यूब, इधर तेजी से ब्लड आएगा, इधर से फास्ट ब्लड आएगा इसमें, and पूरा 1.5 लीटर भर गया, that means you have to तुरंत shift the patient to the OT for a emergency thoracotomy that I currently mentioned before you. The points that I've highlighted on this particular slide are total of 4. All these 4 are hardcore surgery questions, but though the surgeons also talk about it, I have deliberately decided to incorporate these in my discussion because these are questions that have been asked in the exam in the previous years. सम क्वेश्चंस आर ऑब्वियसली सिंपल, दैट वुड बी कि पहले क्या करेंगे या इसका मैनेजमेंट क्या होगा। तो टेंशन न्यूमोथोरैक्स का जो मेन मैनेजमेंट है वो तो मैंने लिखा 3 ही पॉइंट है। वाइड बोन नीडल thoracostomy, that is the first step. Then is insert a chest tube, that's the second step. After giving local anesthesia, you insert a chest tube, and then last point is underwater seal drainage, that will help in management of this. This is the oft repeated emergency which I've currently discussed at the moment before you, including the aspect of indication for emergency thoracotomy with hemostasis in this particular case. This is the second time I've taught you indication for thoracotomy. The last time I taught you thoracotomy was for a traumatic cardiac tamponade. Let me write it here so that you are able to remember this. Emergency thoracotomy आपको कब कब यस बोलना होता है। इफ ही सेज कि पेशेंट को पेरिकार्डियल टैम्पोनाड है या कार्डियक टैम्पोनाड है, तो कार्डियक टैम्पोनाड का जो ट्रीटमेंट होता है वो तो ऑब्वियसली एक इकोकार्डियोग्राफिक पेरिकार्डियोसेंटेसिस होता है। बट अगर वो कार्डियक टैम्पोनाड बोलता है इज ड्यू टू हेमोपेरिकार्डियम, like this guy, he was stabbed in the chest and he's having a hole in the heart. If there is a traumatic cardiac tamponade, if there is a traumatic cardiac tamponade due to hemopericardium, तो यार अब अगर पेरिकार्डियोसेंटेसिस करके ब्लड निकाल भी दोगे तो उसकी जगह पे और आ जाएगा। अब वो निकाल दोगे तो और आ जाएगा, तो बॉडी का सारा ब्लड तो नहीं निकाल सकते ना। द गाय वाज स्टैब्ड इन द चेस्ट, there was a puncture in the pericardium and the myocardium of the heart also. So the myocardium of the heart is injured, or suppose myocardium ना भी हुआ, मान लो coronary artery damage हो सकती है, coronary vein damage हो सकती है. If any blood vessel of the heart will be damaged, then it will bleed into the pericardial space. You can't remove all the blood of the body. So you will do a emergency thoracotomy to do a hemostasis. That is one. And second is obviously what I described at the moment. That is traumatic. This is again traumatic pneumothorax in a patient. For traumatic pneumothorax, the guidelines that I mentioned here before you are 2 of them, which I'll just mark as 200 into 2, or I will mark as more than 1.5 liter. It is either 200 into 2 as I explained, or it is 1.5 liters that we'll be doing for evaluation of this patient. So at the moment, it is emergency thoracotomy, 3 indications. Also, I want to utilize this opportunity to say one more fact, that is obstructive shock. Obstructive shock has come in a discussion 2 times, so I'll write it superiorly. I can utilize this slide here. You can do it on page 117. 3 causes of obstructive shock which you should be always aware of. 3 causes of obstructive shock that you should always be aware of. The first one was discussed on, I think, the first day itself, cardiac tamponade. I invested time into that. Non-pulsatile elevated JVP, steep X and absent Y descent. So like multiple things were discussed for obstructive shock that is caused by cardiac tamponade. The second indication for obstructive shock or second cause of obstructive shock is what I described right at the moment. The word is tension pneumothorax in a patient. Tension word तभी बोलते हैं जब BP unrecordable हो जाता है. मुझे third cause बता दो please. What is the cause for development of obstructive shock in a patient? The third one, and the hint is कि इसको deep vein thrombosis था. The hint is the guy had deep vein thrombosis. Due to deep vein thrombosis, there is a pulmonary embolism, and due to pulmonary embolism, the clot will go and block the pulmonary artery. I can't make it easier than this, guys. I expect answers. Rishi Karan was the first one to ask that. Rishi Karan was the first one to answer. Vaishnavi, Maria, yes, Uzair. All of you are now right. It is a massive pulmonary embolism in a patient. So these are three situations of obstructive shock that they love to ask. At the moment, I've taught you two: cardiac tamponade, where we do a pericardiocentesis, tension pneumothorax, where we put a wide bore needle in the fifth space or in the second space, as the case may be for an adult. Massive pulmonary embolism, I will be teaching you later. Now tell me causes of distributive shock. Distributive shock. No. Aortic stenosis is not a cause of obstructive shock. Aortic stenosis does not cause shock. There is a compensatory hypertrophy. Tell me causes of distributive shock, please. डिस्ट्रीब्यूटिव शॉक कब बोलते हैं? जब सिस्टमिक वैस्कुलर रेजिस्टेंस लेस हो जाती है. जब सिस्टमिक वैस्कुलर रेजिस्टेंस लेस हो जाती है, the causes of this are SAN, SAN. That would be one entry was perfectly spot on. Most guys caught it immediately. Septic shock is distributive shock. Yes, continue please. Sepsis is done. Next one please. A लिख दिया ना? Yes, guys, absolutely. Anaphylactic shock as well as Addisonian crisis. Anaphylactic shock as well as Addisonian crisis are examples of distributive shock. And N would be for neurogenic shock in a patient. I will rate this as a super important table for your exam. I will rate this as one of the super important table for your exam, which is never ever to be forgotten. Distributive shock feature is systemic vascular resistance becomes lesser. In obstructive shock, the pathogenesis has been described, and I'll continue doing it in the topic of massive pulmonary embolism as well. This is one summary table that you never are supposed to forget. Even if in your sleep you are awakened rudely by somebody and said कि बताओ distributive shock के कारण क्या होते हैं, तो SAN. And for obstructive shock, I have not gone into any mnemonic like SAN van. I've tried to just go into rationale to describe the important causes of shock. So you will notice that almost all the points that have been discussed here are a repeat from whatever the surgeon would have said, but I've tried to organize the data in such a fashion that it becomes much more rememberable. And once we are done with the topic of pneumothorax, I will now be explained to you regarding like what will we do if there is fluid accumulation in the pleural cavity. If there is a fluid accumulation, then we call it pleural effusion. So if you look at the next X-ray, you will notice that there is a concavity which is present here. You can notice a very clear Ellis curve which is present, along with obviously the fluid is white in color, so that is understandably fluid only. But if you look at it, you will notice a very characteristic finding that has come up. The concavity part that I've highlighted, this is called as Ellis curve. E-double-L-I-S, Ellis curve. Instead of Ellis curve, the alternative term that we use for this is also called as meniscus sign. Either of the two, if given to you in a question, Ellis curve or meniscus sign tell you that you're dealing with a pleural effusion in the patient. In one of the previous exams, my students told me that boss, everything was identical. It was white only, so I could identify fluid. The CP angles were blunted, but the border was not concave. You can see that this is not concave. This is like more, I would say, like horizontal. So in those circumstances, if it is a straight line, then I will not answer it as pleural effusion. I will change my answer to hydropneumothorax. Let me write down the data. The first X-ray which has been explained to you at this moment, this is presence of water, this is presence of fluid. So you will say this is hydrothorax in a patient. You will say this is hydrothorax, alternative name for pleural effusion. But that green thing that I highlighted before you, where it's a straight line, you will say two things present. Water is also there and air is also there. So you will say hydropneumothorax is present. So two images are what I've clarified at this moment, hydrothorax and hydropneumothorax respectively. You will also notice that this angle that can be seen, is because of gravity, it is lower. So this angle that I've highlighted at this moment is the first angle to be obliterated. The technical name for this angle is costophrenic angle. The other angle can be cardiophrenic, which is closer to the heart, but this is called as costophrenic angle. Costophrenic angle is the first to be obliterated. The rationale is very simple, that because of gravity ये पहले obliterate हो जाएगा. Like if I put numbers here, this is 1 costophrenic angle, this is 2 cardiophrenic angle, so 1 is lower as compared to 2. So when the fluid will start accumulating, it will first fill at area number 1, then will fill at area number 2. So blunting of the costophrenic angle, or first to be obliterated in a case of hydrothorax, first to be obliterated in a case of hydrothorax would be answered as what I explained, costophrenic angle. How comes कि करेंगे क्या? So we have to remove the fluid. So it is a site for thoracocentesis. For thoracocentesis, the site we will select is as low as possible. If second, fifth, seventh, and eighth options are given, if second, fifth, seventh, and eighth options are given, you will select as low as possible. As low as possible is the 8th intercostal space in this particular patient. So because you're taking out the fluid, therefore we're going to call it a therapeutic thoracocentesis to ease off the breathing difficulty. If you're doing for diagnostic purposes, you will say diagnostic thoracocentesis. It is 8th intercostal space. You guys can tell me which line. Options are anteraxillary line, mid-axillary line, and the scapular line. While I try to sketch this before you, my questions are, what is the preferred line where you would like to put in a needle? You can see this is the scapula, this is the scapular line. This is the blue thing that you can see is the right at the tip of the scapula. So if I just draw it again a little more medially, and this line, this is the scapula. Yep. So I can say this is the scapular line. No, not exactly. It's not exactly the scapular line. No? You can see it is being put between the posterior axillary line and the scapular line in the patient. This green thing will be the mid axillary line. This green that you can see is the mid axillary line. So where will you be putting the needle? You will be putting the needle between the scapular. S is the scapular, and the red one is what is called as the posterior axillary line. In दोनों के बीच में is the site where the needle of yours would be introduced. So the technical answer is not mid-scapular, it is not the posterior axillary line. Your technical answer is, I'll zoom it into the image again. जो हरा line है वो mid-axillary है. उसके पीछे चले जाओ तो it is posterior axillary line. The green line is the mid-axillary line, MAL. उसके पीछे जाएंगे तो posterior axillary line हो जाएगा, उसके और पीछे जाएंगे तो scapular line हो जाएगा. So we will be putting the needle between the two lines, between the red line and the blue line. So the technical answer will be, I hope it is very clear to everybody, that the site is 8th intercostal space for thoracocentesis. And where will you put the needle? Your answer is, it is 8th intercostal space. I will be putting the needle midway between. You can type in the chat box so that you remember this. 8th intercostal space midway between the posterior axillary line and the scapular line. So it is neither in the posterior axillary line, it is neither in the scapular line. दोनों के बीच में डालते हैं. You have to take out the fluid for diagnostic purposes. You will send it for laboratory evaluation. So one they've asked regarding the site as I've highlighted. The second thing that they've asked is also from the perspective of the neurovascular bundle, which is I can draw here before you. You can take this as representation of the rib, like 7th rib, 8th rib, and below every rib there is an artery that is going, that is called as intercostal artery. It is intercostal artery. Also going in this particular patient is also present in this is the intercostal vein. Also present here is the nerve. It is the intercostal nerve. मैंने जो ऑप्शंस दिए थे उसमें आपने पता क्या बोलना था? पोस्टीरियर स्कैपुलर लाइन. सॉरी, आपने क्या बोलना था? पोस्टीरियर एक्सिलरी लाइन. बिलो एवरी रिब इज द न्यूरोवैस्कुलर बंडल. तो अगर मैं नीडल को ठीक जगह पे नहीं डालूंगा तो ये इंजोर हो जाएगा. ठीक जगह का मतलब क्या है कि आई विल बी पुटिंग द नीडल एट दिस एरिया and not in the upper part of the intercostal space, so that I don't cause injury to the neurovascular bundle. For symbolic purposes, I will be drawing the red से बना लेते हैं. For symbolic purposes, I will be drawing the intercostal artery, intercostal vein once again, and obviously there is a nerve also. We want to avoid injury to the neurovascular bundle is the rationale in this particular case. It's injury to the neurovascular bundle which is to be prevented. That is why the needle will be put in the following fashion. In your exam, the options were, what is the site for thoracocentesis? One option was lower border of the upper rib and second was superior border of the inferior rib. I'll say the options first. Don't look at the diagram. Don't look at the screen. Just type in the chat box. You can use short forms. Options are inferior border of the superior rib, superior border of the inferior rib. Waiting for comments. See, I've drawn the diagram, so it is, I hope, very, very easier for you. It is the superior border. We always have to ensure that we give local anesthesia and then we insert the needle in the superior border. आप देख सकते हैं superior border, जो मैंने green dot बनाया है वो superior border ही तो है of the नीचे वाला rib. It is the superior border of the inferior rib. See, at this moment it will look super easy to you और आप बोलोगे अरे सर ये तो बहुत आसान है, superior border of the inferior rib. बिना डायग्राम के जब एग्जाम में आज से 1 महीने बाद अगर पूछा जाता है तो then people get confused. That is why I said type, so that जब manifestation आदमी करता है, जब लिखता है, कोशिश करता है तो फिर याद भी रहता है. It is superior border of the inferior rib. Exactly, Tabriz, you spot on. SBOIR. Superior border of the inferior rib is the correct. SBOIR is a good way to remember because you want to avoid injury to the neurovascular bundle, that is the intercostal artery and the vein and the nerve. How much amount of fluid can you remove per sitting? Because if you will remove all the fluid, it will again cause re-expansion pulmonary edema. According to the British thoracic guidelines, हम 1.5 लीटर से ज़्यादा नहीं निकालते हैं. So if he says how much is the amount of fluid that can be removed from the pleural space per sitting, it is less than 1.5 liters that can be removed per sitting. We don't try to remove more than this. Actual practice में तो इतना भी ज़्यादा नहीं करते, 500 ml करके, उससे भी कम निकालते हैं. Usually, हाँ जी, less than हो जाएगा बेटा, less than हो जाएगा. The reason why we don't go ahead more than 1.5 liters is primarily because of the risk of री एक्सपेंशन पल्मरी एडिमा के जो लंग दबा हुआ था ना पहले पानी से, अभी एकदम से प्रेशर आपने ऑफ कर दिया तो उसकी वजह से हम देखते हैं कि देयर इज अ कॉम्प्लिकेशन दैट इज डेवलपिंग बाय द नेम ऑफ री एक्सपेंशन पल्मरी एडिमा. सो ही सेज दैट वेयरएवर लाइक पॉसिबल ट्राई टू डू इट इन मल्टीपल सिटिंग्स रादर देन सिंगल सिटिंग इफ यू आर डूइंग थेराप्यूटिक. डायग्नोस्टिक में तो कोई दिक्कत ही नहीं है ना भाई, डायग्नोस्टिक में तो थोड़ा सा फ्लूइड निकाल के लैब में भेज दो, उसमें क्या है. Saying suppose 2 liters of fluid is present or 2.5 liters of fluid, कैंसर के पेशेंट लाइक लंग कैंसर के पेशेंट्स में छाती में पानी भर जाता है, प्लूरल एफ्यूजन हो जाती है, जिसको मैलिग्नेंट प्लूरल एफ्यूजन बोलता है. So for a lung cancer patient, it is advisable we might even put a chest tube and take it in installments of 400-500 ml, and then gradually the fluid will be removed from the chest cavity of the patient. So the words to be remembered are 1.5 liters. Why? Because of risk of re-expansion pulmonary edema. Where do you put the needle? It is the superior border of the inferior rib to avoid injury to the neurovascular bundle in the patient. And there is 2 types of fluid that can accumulate in this case. The fluid that will accumulate here can be transudate or it can be exudate. So I will now be giving you an explanation for transudative versus exudative. This is optional. If you want to note down, it is okay. Otherwise, at the bottom in the next page, this is given in the form of like alphabets and literature also. But let me explain what I mean by transudative. Let's imagine this is blood vessel of the lung. This noting down, this is optional. Let us imagine this is a blood vessel around our lungs, and every blood vessel will be having a hydrostatic pressure at. Due to hydrostatic pressure, the fluid will move into the third space. The third space is called as interstitial space or is also called as pleural space. The normal amount of fluid in our pleural space is in the range of 5 to 15 ml. The amount of fluid which is present in the pleural space is 5 to 15 ml. That fluid remains constant. The reason why it is constant is because of the fact that fluid will come back into the blood vessel also because of the oncotic pressure. Hydrostatic pressure and oncotic pressure maintain a balance. And because of this balance, the fluid amount remains constant 5 to 15. If there is an imbalance, that is when pleural effusion will be occurring. For the oncotic pressure part, I said albumin is the protein that decides the oncotic pressure. I'll repeat the data once again. This is not SAG. SAG will come in ascites. SAG will come in ascites at the moment we talk about pleural effusion. The rationale is the same. Your SAG point is okay, but for ascites, the rationale is still the same. Hydrostatic pressure and oncotic pressure, जितना बैलेंस मेंटेन करते हैं तो फ्लूइड की मात्रा कांस्टेंट रहती है. नाउ व्हाट आई एम सेइंग इज कि अगर हाइड्रोस्टैटिक प्रेशर बढ़ गया तो मोर फ्लूइड विल कम इन दिस एरिया. द अमाउंट विल बी मोर देन 15 ml. द बेस्ट एग्जांपल ऑफ इंक्रीज ऑफ हाइड्रोस्टैटिक प्रेशर इज हार्ट फेलियर. द ऑपोजिट ऑफ दिस आई कैन से दैट एल्ब्यूमिन इन द बॉडी इज बिकमिंग लेस. If albumin will become less, oncotic pressure will also become less, and therefore fluid will not be able to come back. The medical condition in which albumin will become less is cirrhosis, क्योंकि albumin बनता कहाँ, liver में बनता है. Or for that matter of fact, albumin can be lost in the urine, that is nephrotic syndrome. Nephrotic syndrome में भी pleural effusion होती है. Nephrotic syndrome में भी pleural effusion होती है because of the decrease in the oncotic pressure. So I've described at the moment before you transudative pleural effusion के three causes: heart failure, cirrhosis and nephrotic syndrome. The logic to be remembered by you is transudative pleural effusion is always due to pressure problem. Transudative pleural effusion is always because of pressure problem. It is always due to pressure issues. That is, या तो hydrostatic pressure बढ़ जाए या oncotic कम हो जाए, दोनों में से कुछ भी हो जाए, प्लूरल कैविटी में पानी भर जाएगा. इन तीनों में से जो मोस्ट कॉमन कॉज है ट्रांसुडेटिव का, द मोस्ट कॉमन कॉज ऑफ ट्रांसुडेटिव शुड ऑलवेज बी रिमेंबर्ड एज कंजेस्टिव हार्ट फेलियर. Others are cirrhosis and nephrotic syndrome. Transudative is just like water. Transudative pleural effusion is just like water. Now I will explain to you what is exudative pleural effusion. Now I will explain to you what is exudative pleural effusion. Till now I was describing transudative. Now I will describe exudative. Exudative pleural effusion, page number 120. You need to note down that this is inflammatory fluid, this is fibrin rich fluid. This is again a very basic exam question, that which of the following fluids in the pleural cavity of the patient, that is exudate versus transudate, which of the two is rich in fibrin, then it is exudate which is rich in fibrin. Transudate तो पानी के जैसे, transudate is just like water, you keep it in a syringe, वो कभी clot नहीं करेगा, लेकिन exudate will always clot on standing. Exudate will usually clot on standing. So therefore one I can easily differentiate between transudate and exudate on the basis of whether, I mean, it clots in the syringe or not. But in an era of evidence-based medicine, as Rajesh mentioned in the chat, in an era of evidence-based medicine, वो कहता है कि भाई you should not rely on subjective finding like whether the fluid is clotting or standing or not. Like transudate, exudate, you can easily differentiate by like taking the history of the patient. Heart failure, transudative. It does not clot, transudative. If it is TB, then it is exudate. If I write causes, usually two important causes in India that cause exudate is tuberculosis. And the second important cause that can be is lung cancer. TB and lung cancer are two important causes for exudative. But then the point is, in the era of evidence-based medicine, I would like to rely on Light's criteria to differentiate between transudate and exudate. So what they usually ask in the exam is not this explanation. This explanation was only for understanding. आपसे exam में क्या पूछेगा? He will ask you Light's criteria are used to differentiate between. Your answer will be transudate versus exudate. What are the causes of transudative pleural effusion? The mnemonic is CHAP. The mnemonic is CHAP. C stands for congestive heart failure. H stands for hypoalbuminemia. That could be due to any of the reasons. The best example is like cirrhosis of the liver. C can be for cirrhosis also. A is ascites, and an additional point that I did not say earlier and I'm teaching you now is peritoneal dialysis. Let me just bring that into a better focus. What are the causes of a transudate? The mnemonic is CHAP. CHAP. C stands for congestive heart failure and even cirrhosis, which will ultimately contribute to development of hypoalbuminemia. Alphabet A is for ascites, again related to cirrhosis. Ascites can be seen both in cirrhosis and nephrotic. Cirrhosis and nephrotic both have a common thing. दोनों में फर्क सिर्फ इतना है कि cirrhosis में albumin बनता नहीं है और nephrotic में यूरिन के रास्ते निकल जाता है. In cirrhosis, albumin is not formed in the liver. And in nephrotic syndrome, it is lost in the urine of the patient. So a common thing that I have highlighted, including the word peritoneal dialysis, is for transudative. In transudative, when we will take the fluid out of the chest, we will send it in a test tube to the laboratory for checking the protein and the LDH. You have taken the fluid, you will send it in a test tube labeled with the patient's details. If the question mentions pleural fluid protein to be less than 0.5 and pleural fluid LDH to be less than 0.6, of the serum protein and serum LDH respectively, हम यहाँ पे pleural fluid का प्रोटीन की मात्रा चेक करते हैं, सीरम प्रोटीन का वैल्यू चेक करते हैं. If the value is less than 0.5 and 0.6 respectively, then you will say that this is a transudate. Now using ink change and saying that suppose they give you a question in which the value is given to be more than 0.5 and more than 0.6, then you will say it is exudate. So for today you have to remember one of the two. Don't try to do both of them. Remember what I wrote in the end, because exudate is usually asked TB and lung cancer. Light's criteria क्यों use करते हैं? Light's criteria are used to differentiate between the two things that are currently explained at the board before you, transudative और exudative को differentiate करने के लिए. Though I said clinically I can differentiate by checking out the fluid in the syringe also, but he says in an era of evidence-based medicine, do the testing also. The values to be remembered are more than 0.5 of the serum protein, more than 0.6 of the serum LDH. If the more than data is given there, then you will say it is exudate. If the more data is given, then you will say that this is an exudate. If it is less, it is a transudate. In NEET PG, they will actually make you do calculation. He will mention the protein in the pleural fluid, he will mention the serum protein value, and then he will make you calculate, and you will find that, well, this is a transudate because the ratio will be less than 0.5, 0.6 respectively. In FMG exam, he is simply asked कि Lights criteria क्यों use होते हैं, तो differentiation part, और in FMG what is done is उसने combine कर दिए causes. चैप निमोनिक वाले causes में से जैसे 3 cause लिख दिए और एक कॉज कर दिया टीबी, तो मैं स्टूडेंट्स वर एबल टू आंसर दैट इमीडिएटली कि सर टीबी तो इन्फ्लेमेटरी होता है ना, तो एक्सुडेट हमने बोल दिया ऑल एक्सेप्ट एमसीक्यू में, लाइक दे विल जंबल अप द डेटा. ऑल आर कॉजेज ऑफ ट्रांसुडेटिव प्लूरल एफ्यूजन, all are causes of exudative pleural effusion. For transudative it is 2 to be remembered, that is for transudative it is 4 to be remembered: heart failure, cirrhosis, nephrotic and peritoneal dialysis. For exudate it is 2 to be remembered: TB and lung cancer. तो पूछने को तो ऑटोइम्यून डिसऑर्डर लाइक रोमेटॉइड आर्थराइटिस भी पूछ सकता है, ऑटोइम्यून है ना यार, इन्फ्लेमेटरी होगा तो एक्सुडेट कर ही दोगे. नाउ दिस इज अ इंपॉर्टेंट क्वेश्चन. This is a fact-based question that I'm dealing. Pleural fluid adenosine DMNS levels. This is elevated in tubercular pleural effusion. This is a extrapulmonary TB. So ideally for tubercular pleural effusion, I would be more comfortable doing a CB-NAT. Though for diagnosis of TB pleural effusion, I'll be comfortable doing CB-NAT, but then in the exam, like he did not mention CB-NAT because उससे तो कर ही लोगे यार कि ये TB का केस है. So he asked like what test can be done. It is adenosine DMNS levels which are elevated. They're not 100% confirmatory. It is suggestive. So I want to highlight the word is S by O, that is suggestive of, not diagnostic of. If he says diagnostic, it is by default CB-NAT only. You guys can comment in the chat box what condition causes bilateral pleural effusion. Among the conditions that are discussed, bilateral, yeah, suggestive, more than 40. Which condition causes bilateral pleural effusion? Your answer is all transudative varieties. ये जितने भी conditions मैंने लिखे हैं, heart failure, cirrhosis, nephrotic syndrome, or the word peritoneal dialysis, all the transudative varieties will contribute to bilateral pleural effusion because pressure is distributed equally. Now I said pressure issues in a patient, so transudative pleural effusion is always bilateral. यूनिलेटरल कौन सा होगा, तो वो यूजुअली या तो टीबी वाला होगा या लंग कैंसर. दोनों साइड पे तो होता नहीं ना, यूजुअली तो एक ही साइड पे होता है. Transudative pleural effusion is always bilateral, like heart failure, pressure is distributed equally. Nephrotic syndrome, oncotic pressure becomes lesser, pressure is distributed equally. The number one cause of bilateral pleural effusion is heart failure. Yes, unilateral can be lung cancer in a patient. And now we will talk about right-sided effusion. This is from OBGY. So this discussion has become a little integrated because pleural effusion will be having multiple other subjects also coming in. Like they want to hear about this tumor of the ovary which can contribute to Meeks syndrome. The reason for Meeks syndrome is a solid tumor of the ovary. The solid tumor that I'm talking about is obviously not teratoma, it is cystic. It is either a fibroma or it is a thecoma. It is fibroma or a thecoma. Yes, it can be a complication related to subphrenic abscess also. It can be reactive, sympathetic. Most of the time he wants to hear about Meeks syndrome where there's a triad. The triad will be having fibroma, thecoma along with ascites. And then would be right-sided pleural effusion. The reason for right-sided pleural effusion is that we have transdiaphragmatic holes, and the transdiaphragmatic holes will be causing the ascitic fluid to move into the peritoneal, from the peritoneal cavity into the pleural cavity. हमारे जो diaphragm होता है उसमें holes होते हैं, उस transdiaphragmatic hole से जो ascitic fluid है, जो reactive fluid है, in response to fibroma or thecoma will move on to like the pleural cavity, and therefore right-sided pleural effusion would be developing in a patient. Yeah, can be developing due to any complication below the diaphragm. That can be like phrenic abscess. It can be reactive with respect to even a amoebic liver abscess and a ruptured one, obviously. Okay. Chalo, which is the commonest ovarian tumor by the, yeah, left sided can be more common with pancreatitis and esophageal malignancy. इसका उल्टा एमसीक्यू भी लिख देता हूँ, though you guys are commenting very well. If he says left sided pleural effusion, if he says left sided effusion, then though left sided effusion can be seen with multiple scenarios, most of the time in MCQs you will notice that when we will discuss Boyrev syndrome, then we will say esophageal malignancy, and then would be pancreatitis involving the tip of the pancreas, not the head of the pancreas. If it is acute pancreatitis involving the tail of the pancreas, only then you would have a left-sided pleural effusion in a patient. Boyer have esophageal malignancy, acute pancreatitis, they cause, I can call it unofficially sympathetic effusion. The disease is not in the esophagus. I mean, disease is in the esophagus, but the lungs are having that sympathy. Oh, तुझे cancer हो गया, तो मैं भी थोड़ा दुख दिखा देता हूँ, that kind. So it's a sympathetic kind of a manifestation that is occurring here, involving acute pancreatitis, involving the tail of the pancreas. Now comes the aspect of bloody, yeah, which is the commonest ovarian tumor, guys? Yeah, pancreatic is absolutely. Yeah. Good for your exposure. Yes, guys. Let me know what is the commonest pancreatic tumor, by the way. Oh, not metastatic, pancreatic malignant. Sorry, pancreatic बोल रहा हूँ मैं. I think मैंने ovarian पूछना था. Which is the most common ovarian tumor? Yeah, epithelial tumor. I think I said it, but anyway. If I did not clarify, I'm asking you about ovarian cancer. कौन सा एपिथेलियल इतने सारे होते हैं जी. The most common ovarian cancer is serous cyst adenocarcinoma. The most common ovarian tumor is serous cyst adenocarcinoma, and the problem with this is that it can metastasize to the peritoneal cavity and it can cause a development of malignant ascites in a patient. In a similar spirit, I can say, what is the most common lung cancer, by the way? Which is the most common lung cancer? The most common lung cancer is adenocarcinoma of the lung. जो सेमोमा बॉडीज है ना, वो अडीनोमा के साथ में ज्यादा कॉमन होती है ना. अडीनोकार्सिनोमा में तो आर्किटेक्चर डिस्ट्रॉय हो जाएगा ना. या the most common primary lung cancer is adenocarcinoma of the lung. This is a peripheral tumor, so it will cause a development of malignant pleural effusion in a patient. I basically wanted to bring to your attention that the leading cause of malignant ascites is commonest ovarian tumor, and the leading cause of malignant pleural effusion is adenocarcinoma of the lung. Another question I want to cover here is, how do you manage a malignant pleural effusion? तो फ्लूइड तो निकाल देंगे, लेकिन फ्लूइड निकालने के बाद में what we do is that we inject doxycycline into the pleural space. This is very peculiar. Patient is asking me कि सर कोई इन्फेक्शन है क्या, तो मुझे तो आपने बोला था कैंसर है, तो मैंने बोला कि नहीं इन्फेक्शन नहीं है, बट वी विल इंजेक्ट डॉक्सीसाइक्लिन इन द प्लूरल स्पेस क्योंकि वो एडिशंस करा देता है. आई विल डेलिबरेटली कॉज एडिशंस बिटवीन द टू लेयर्स ऑफ द प्लूरा. आई विल डेलिबरेटली कॉज एडिशंस बिटवीन द टू लेयर्स ऑफ द प्लूरा, ताकि दोनों लेयर आपस में चिपक जाएं तो फ्लूइड वापस नहीं आएगा. पहले तो फ्लूइड निकाल दोगे, दैट इज ओके, बट नाउ द फ्लूइड विल कम बैक बिकॉज कैंसर इज स्टिल देयर. सो व्हाट वी डू इज प्लूरोडिसिस. मीनिंग ऑफ द वर्ड प्लूरोडिसिस क्या होता है? ऑब्लिटरेशन ऑफ द प्लूरल स्पेस. इट इज अ डेलिबरेट obliteration of the pleural space. The doctor will inject doxycycline into the pleural space. You are injecting doxycycline into the pleural space to obliterate the pleural space, and that will like prevent the reaccumulation of fluid. It will prevent the reaccumulation of fluid present in the pleural cavity of the patient. So there are two aspects I said. Common ovarian tumor can cause ascites, malignant one, and then the commonest lung cancer, adenocarcinoma, could result in development of obliteration. It could result in a malignant pleural effusion in a patient. Let's cover the remaining ones. Bloody pleural effusion would be seen in. So bloody pleural effusion is seen with patients on trauma. It can be seen in patients who are on warfarin. Those are like easy ones. Anybody can answer trauma, and anybody can answer like it can be somebody on warfarin where like warfarin can cause bleeding also. But what I wanted to remember is TB and lung cancer can also contribute to a bloody lung cancer. So malignancy and tuberculosis are the important ones. Trauma and warfarin is standard. Then is low sugar with cholesterol crystals are seen in. Yes, guys. You have to answer me this one. Cholesterol crystals are present. Low sugar in the pleural fluid can be multiple reasons. One of the causes of low sugar in the pleural fluid, the first one that must be suspected is malignancy. I've written the word query malignancy, so I will be going in for cytology and immunohistochemistry of the pleural fluid. If I find low sugar, I will be doing cytology and immunohistochemistry of the pleural fluid, so that I'm sure about, like, I'm not missing out a cancer. And low sugar with cholesterol crystals, that is a feature of rheumatoid arthritis. Cholesterol crystals is a feature of rheumatoid arthritis. I had a good answer from Ashok Kumar. He said mesothelioma. यार mesothelioma यहाँ पे नहीं आता. Mesothelioma is क्यों पूछता है, चलो उसको लिख लेते हैं, बिकॉज आपने पॉइंट बोला तो मैं लिख देता हूँ. So mesothelioma is a characteristic cancer that is seen in patients of asbestosis. Mesothelioma क्यों पूछता है? So mesothelioma is gonna be like a pre-malignant condition. It's a pre-malignant condition. Mesothelioma is a cancer, right? It's a cancer. Asbestosis can trigger mesothelioma and it's a cancer. The reason why they will ask you is because यहाँ पे pleural plaque calcification होती है. Nowhere else will you read this word. Pleural plaque calcification is seen in the answer is mesothelioma. So this one condition that I've currently highlighted, mesothelioma, this is gonna be like a cancer related to asbestosis. It is a characteristic cancer. Not the commonest one. Commonest one in these patients also is adenocarcinoma, but the characteristic cancer of asbestosis is mesothelioma, and that causes a pleural plaque calcification. We don't read this word anywhere else. Pleural plaque calcification is a feature that is seen with mesothelioma. Empyema would mean that there would be pus in the pleural space, for which we'll have to put in a chest tube. I'll write that and when I've finished that. But meaning of the word empyema is that the person had a parapneumonic effusion, and then it was not treated on time, so empyema will develop, that is pus in the pleural cavity in the patient. Why not nephrotic for cholesterol crystals? Well, I would say rheumatoid arthritis is more specific. For nephrotic syndrome, I will say that it is mainly fat bodies that are present, right? Not cholesterol crystals. More specific is rheumatoid arthritis. Autoimmune condition, and then associated with rheumatoid pleural, associated with the extrapulmonary manifestation of rheumatoid nodules. Yeah, they're not specific. They're just, यार कोलेस्ट्रॉल क्रिस्टल तो myxedema में भी होते हैं. हाइपोथायराइडिज्म की जो myxedema लंग होता है उसमें भी प्रेजेंट होता है. Get cholesterol crystals even with myxedema, तो वो तो कुछ नहीं, वो तो इशू नहीं है. मैं I can elaborate this list here, that I can write cholesterol crystals with hypothyroidism also. बट अगर सिंगल बेस्ट आपको करना है तो मोस्ट ऑफ द टाइम जो ऑटोइम्यूनिटी वाला सिचुएशन है, क्योंकि लो शुगर का कंपोनेंट वो दे रहा है, देन इट वुड बी आंसर्ड एज लाइक रूमेटॉइड आर्थराइटिस. Okay, Ji. So what I've described at the moment before you are some of the important aspects for pleural effusion. And prior to that, we have discussed about pneumothorax. So let's take care of another topic for today. That would be pneumonia. We'll try to wind off at or before 8 o'clock. So depends on like how much time you give me to do the talking. Okay, Ji. So in this particular case, you can notice right upper zone consolidation. What is the auscultatory finding on pneumonia? Yes, guys. Fast comments here. What is the most reliable auscultatory finding on pneumonia? Yeah, yes, exactly. There are lots of reasons for cholesterol crystals are never a diagnostic feature of anything. Great. Last page. Okay. Yes, guys. Remaining people, please. What is the auscultatory finding of pneumonia? Yeah. More people, please. Crepitations are not a reliable finding. Crepitation तो हार्ट फेलियर में भी होती है. Most people answer it as coarse crepitations. Some people answer it as fine crepitations. The most reliable auscultatory finding on pneumonia is not creps. It is not crepitations. Not crepitations. I'm repeating. यही तो बोल रहा हूँ. Moist trails and fine crepitations, coarse crepitations. No. The most reliable auscultatory finding on pneumonia is bronchial breathing. Like you can see here, that when I'll put my stethoscope on this area, I will be having a inspiratory-expiratory ratio totally different from what I hear in normal. अगर आप नॉर्मल पर्सन का ब्रीदिंग सुनते हो तो नॉर्मल पर्सन का जो ब्रीदिंग होता है उसको बोलते हैं वेसिकुलर ब्रीदिंग. नॉर्मल पर्सन ब्रीदिंग इज कॉल्ड एज वेसिकुलर ब्रीदिंग. दिस वुड बी हैविंग अ inspiratory-expiratory ratio of 2:1. It will be having an inspiratory-expiratory ratio of 2:1. And you will notice it will be continuous inspiration, expiration, and the ratio is 2:1. Now I will mention regarding the most reliable auscultatory finding for lobar pneumonia. This is called as bronchial breathing. In bronchial breathing, when you will check the inspiratory expiratory ratio, it is gonna be 1 and 1 is to 1, and also you will notice a audible gap, like सांस अंदर गया, inspiration, then there's no sound for a few seconds, and then that's because of pus. That's because of the pus in the alveoli, and then the expiration part will happen. So one of the easy ways to identify is that is there a audible gap? If you notice that there is a audible gap, then yeah, this is bronchial breathing. So in our exam, they don't ask regarding like, I mean like OSCE में तो क्या होता है कि they ask you to hear the sound. They'll give you a software and they'll make you listen. But Indian exams are not about OSCE and they ask you the theory component. So the statement is, this is the most reliable auscultatory finding of lobar pneumonia, as I asked you. I'll write this once again. The most reliable auscultatory finding of pneumonia is bronchial breathing, also called as tubular breathing. Can you hear bronchial breathing of lungs of a normal person? Can you hear bronchial breathing over lungs of a normal person? If yes, where? Yes. Can you hear bronchial breathing in the lungs of a normal person? If yes, where? Yeah, you have to read Hutchinson clinical methods in your final year now, or if you're not PJ Mehta or Hutchinson, something has to be read, no? Or McLeod's clinical methods. Yeah, it is over the trachea, na? Just below the suprasternal notch. If you auscultate, you can hear bronchial breathing in a normal person also. So bronchial breathing is normal in over the trachea, but over the lung fields, it is not normal. Bronchial breathing can be heard over the trachea at the suprasternal notch. It would not be like this in the over the trachea. It will be normal. It will not be normal over the lung fields of the patient. No, I never asked all over the lungs. I never said all over the lungs. I said respiratory system ना. Respiratory system में तो trachea पे ना. It's like suprasternal notch पे यहाँ पे मिल जाएगा ना, middle part में. You will be able to hear it. So the answer is yes. The answer is a yes here. Now coming back, the most reliable auscultatory finding of pneumonia is bronchial breathing, also referred to as the tubular breathing. Now the next question says, which bacteria will cause both typical and atypical bacteria? So I'll be testing a lot of your microbiology here as well in the last topic for today. Which is the organism that causes both typical and atypical pneumonia? Answer my questions. Typical also, atypical also, then good. The answer is Legionella pneumophila. The answer is Legionella pneumophila. This causes Legionnaire's disease. It can contribute to multilobar consolidation. It can cause a atypical pneumonia. This is more of a bacterial, bacteriology kind of a question. Typical and atypical. Overall, most common. Pneumococcus is the answer here. If I ask you, what is the bacteria responsible for community acquired pneumonia? Then you will say that this is the same bacteria that causes bacterial meningitis. So pneumococcus and streptococcus pneumoniae. Pneumococcus and streptococcus pneumoniae are the two bacteria which are responsible for causing development of, it is responsible for development of community acquired pneumonia. Both basically mean the same. So I can say pneumococcus is answer to 2 MCQs. It is the leading cause of bacterial meningitis. I would like to remind you, I have taught you pyogenic meningitis may after 3 months to up to 55 years, the organism is the same. Pyogenic meningitis is pneumococcus/streptococcus pneumonia. The age group is very wide, guys. 3 months to more than 3 months to 55 years. And for community acquired pneumonia, obviously standard data pneumococcus or strep pneumonia. Then comes ventilator associated pneumonia, for which it will be Pseudomonas aeruginosa. This is a nasty bug. Most of the time it's gonna be multi-drug resistant, and it will contribute to like high level of mortality if the person is developing this kind of infection. If Pseudomonas aeruginosa is not in the options, you will have to answer Acinetobacter for this condition. I will put 2 fast questions for you for Pseudomonas. Let me know what is the preferred culture media, selective media, and second, let me know what is the antibiotic of choice for Pseudomonas. Culture media for Pseudomonas, an antibiotic of choice for Pseudomonas. The culture media is Cetrimide agar. This organism can grow in antiseptic. ये कहता है हम वहां ग्रो करते हैं जब बाकी सोच भी नहीं सकते, कहता है जहां तुम्हारी सोच खत्म होती है वहां हमारी सोच शुरू होती है. He's boasting in front of other bacteria, एटीट्यूड दिखा रहा है, उनको कह रहा है तुम्हारे बस की नहीं है, अब वहां ग्रो करते हैं जब तुम सोच भी नहीं सकते. दैट इज एंटीसेप्टिक. सेट्रीमाइड एगार इज वेयर दिस वुड बी यूज्ड. And what is the preferred antibiotic for this particular condition? Yes, Balaji is spot on. More people please. Peptaz is a good answer. Single best answer guys. Peptaz use करते हैं. Agreed. सर वो सिंगल बेस्ट आंसर आजकल तो मीरोपेनियम में रहता है. So left, right, center. Most people are writing meropenem, but I don't dispute that. I mean, if meropenem is not in options, then piperacillin and tazobactam is another antibiotic that can be used for this condition. The main issue is that of resistance in the intensive care unit. So nowadays we are having superbugs which are gonna be little troublesome. Then he will ask you what is the leading cause in children with cystic fibrosis. Cystic fibrosis is a condition in which there is very sticky lung secretion. So we call it mucoviscidosis. This occurs because of F508 mutation. And F508 mutation के उससे पूछा हुआ कि कौन सा amino acid will be mutated. So normally there are 1480 amino acids in the cystic fibrosis transmembrane protein. There is almost like 1480 amino acids in the cystic fibrosis transmembrane protein. उन 1480 जो amino acid sequences होती हैं, there are 1418 amino acid sequence in cystic fibrosis transmembrane receptor protein. उसमें due to this mutation 508 पे phenylalanine is deleted. It is at 508 position there is a deletion of phenylalanine on chromosome number 7. These are the genetics part that he asked, that what chromosome is involved? 7. What is the pattern of inheritance? Autosomal recessive. What is the name of the mutation? F508 mutation. Which amino acid is deleted? Phenylalanine. At what level? 508 divided by 1480. The total amount of amino acid sequence is 1480. At 508 position, it is the phenylalanine molecule that is deleted. Phenylalanine amino acid that is deleted. This name is not to be forgotten. Cystic fibrosis transmembrane receptor word you will remember. Protein word you will remember. Chromosome 7 nobody forgets. It's the numbers to be remembered. 508 mutation and phenylalanine. And now comes like what is the bacteria responsible. So I'm still waiting for answers here, though some people had commented bacteria which are not the answers. So yes guys, which is the leading cause of pneumonia in a cystic fibrosis patient in the first decade of life? Then your answer would be given as yes. Just waiting for comments for a few more seconds. बोलो. Okay, collapsula बोल रहे हैं. Okay, first decade of life. नहीं यार, फर्स्ट डिकेड ऑफ लाइफ में नहीं होता ना. फर्स्ट डिकेड ऑफ लाइफ में इट इज स्टाफ ऑरियस. यस, इन द फर्स्ट डिकेड ऑफ लाइफ इट इज स्टाफ ऑरियस, and in the same patient after 10 years of age, because of recurrent hospitalizations, it is Pseudomonas that would be responsible. Now should we be admitting a patient of pneumonia or should we be like giving hospital based treatment? The decision making is based on CURB 65 score. The update is called as CRB 65 score, but the operation of the same will still remain the way you use the score will still remain the same. So I will now teach you about CURB 65 score, which is used to decide for hospitalization. The score is used to decide for the need for hospitalization. Yeah, EF2 gene. Yes. EF2 gene. Then it is confusion because hypoxia will be there. Blood urea gets elevated because of concomitant sepsis. If one can be written, urea can be written. Respiratory rate you will give in the question. If it is more than 30 per minute, you give 1 point. If the blood pressure of the patient is less than 90/60, you will give 1 point. If the age of the patient is more than 65, you will give 1 point. In CURB 65 score, you will be giving 1 point for each of these parameters which is currently highlighted, and then you will add up this entire parameter and decide how many points are present in a patient. The problem with urea is that the lab report will take few hours to come. So there will be a delay in hospitalization. So he says that even if you don't have urea, it is okay. Even if you don't have the Bunn report, chalega, you can still manage the patient with CRB. So even in CRB, the interpretation that I will say before you will be same as that for CURB. Even if you remove the urea component, it does not change anything. If the score of the patient is between 0 to 1, 0 to 1 means 1 is only for age. Mark my words there, 1 only for age. Like suppose I say to you, 70-year-old man is diagnosed with pneumonia. Blood pressure is 120 by 80, respiratory rate is 20, urea is normal, 1 is normal, and the confusion part is not there. Only age is more. Then I can be treating this patient on OPD basis. Though this man is 70 years of age, I will still be happy giving this patient oral antibiotics. I don't want him to come to the hospital environment and catch some super bug. But now if I change the question and I say that a person who is 60 years of age, 60, then the score is not 1. 60-year-old patient with pneumonia is having respiratory rate of 36. 60-year-old patient of pneumonia is having respiratory rate of 36. Then the score is still 1. But now it is any parameter apart from age, I will be admitting the patient. So see, you got me or not, please let me know. Suppose a person is 50 years of age with pneumonia and is having confusion. Will you treat at home or would you call the patient to hospital? Yes guys, 50-year-old guy is diagnosed with pneumonia. Would you like to treat the patient at home? He's confused, disoriented. Would you like to treat at home or would you like to go for hospital treatment? Hospital treatment. The point is, if it is 1 except age, this is the source of error कि 1 का score में sometimes the answer is given as oral antibiotics and sometimes it is given as IPD basis IV treatment. So the query of students is कि सर कभी तो 1 के लिए आप बोलते हो oral antibiotic, कभी 1 के लिए बोलते हो IV antibiotics. भाई अपनी मर्जी से नहीं कर रहा था. Guidelines say कि if only age is the parameter present, like 70-year-old man with pneumonia, no need for admission, घर पे भेज दो. But suppose the 70-year-old man is having respiratory 36, then becomes 2, I have to admit. तो 2 में भी कोई दिक्कत नहीं है. But suppose I state my question again, 60-year-old man with pneumonia is unconscious. It is only 1 point. That means that I have to admit the patient. Or for that matter of fact, 60-year-old man is having respiratory 36, still 1 point. I have to admit the patient. Apart from age, if the score is 1, you need to admit this patient. So the data to be remembered is 0 to 1 in a patient. Let me just write it once again. 0 to 1 given in a question. Your answer is OPD basis. If it is 1 to 2, it is IPD basis. It is IPD basis, that is IV antibiotics that would be given to the patient. And then if the score of the patient is 3, like let me say it again, 70-year-old man is admitted with diagnosis of pneumonia. The respiratory rate is 36 and the BP is 90 by 60. So that is a cause of concern. 60-year-old patient, 70-year-old patient, 1 point. Respiratory rate 36, 2 point. Blood pressure 90 by 60 or lesser, 3 points. So if it is 3, I will go in for ICU basis treatment, but I will be using IV antibiotics in this case. As you can see, 2 and 3 will never cause a problem. No student will ever mess up between 2 and 3 or between 0, 2 and 3. Confusion occurs only with respect to 1. तो मैं 1 को फिर से हिंदी में एक्सप्लेन कर रहा हूँ कि अगर एज सिर्फ प्रेजेंट है, एज इज द ओनली रिस्क फैक्टर, तो घर पे इलाज कर लो ना. लाइक दिस पर्सन इज 70-year-old मैन, रिटायर्ड फ्रॉम द इंडियन आर्मी, फिट है, हेल्दी है, तो उसको एडमिट करने की जरूरत क्या है. बट मैंने बोला एक यंगर पेशेंट है 60 साल का और उसको निमोनिया हो गया पर उसको कंफ्यूजन है, तो फिर हम भर्ती कर लेंगे. सो द स्कोर ऑफ 1 दैट आई हैव हाइलाइटेड एट द मोमेंट इज कमिंग 2 times in the table. So that is where most of the questions of the PYQ have been focused on. If the score is 2, it's super easy for me. I will say the score of 2 also. आपके बेनिफिट के लिए हिंदी में बोलूंगा. 70 साल का इंडिविजुअल है, उसका रेस्पिरेटरी रेट 36 है, भर्ती कर लेंगे. 70-year-old man with pneumonia, blood pressure is 80 by 60, तो भर्ती कर लेंगे. So as such, I don't think so that anybody will have issue with 2 or 3 का score. It is just that with one parameter the answers will change, and that is why they have done the parameter कि 1 को पूछ लेता बार. Now, I hope I've been able to explain to you at the moment why are you using a curve 65 score. Then it is not to choose the antibiotics, it is to decide the need for hospitalization. Why is CRB used? Then CRB is used not for choosing the antibiotics, it is to decide the need for hospitalization. Decide the need for hospitalization, that CRB 65 score is used. Even if urea report or Bunn report is not available, we can still manage the patient in the same way. 0 to 1 report, OPD basis 1 to 2 with except age, then it is like IPD, and 3 is gonna be ICU. I hope it is clear, guys. This is a rationale for how would we admit the patient. And why are we admitting to ICU? Well, better care, better monitoring. You see the nurse to bed ratio in intensive care unit. The nurse to bed ratio in a intensive care unit is 1:1. वार्ड में तो रेशो 1:10, 1:20 भी हो सकती है, depending on how many nurses have you have posted with. But in ICU there is no, like, you know, like we can't take a chance. So the in nurse to bed ratio is in the ratio of 1:1, and you have better monitoring, plus your ventilator care. You can intubate the person. Therefore, I can say that difference between 2 and 3 is only 1. Both are getting IV antibiotics, but better monitoring is possible. Need for hospitalization, need for ventilator and intubation support would be better done in intensive care unit. Now we'll focus on the treatment. So treatment is based on the score value. So let me write that before you. Suppose the score of the patient is anywhere between 0 to 1. 0 to 1 means that it is a home-based treatment. It is oral antibiotics that would be given. The oral antibiotic that we can give to the patient is 2. It is amoxicillin that will give coverage for gram-positive organisms. And the second thing that I can give to the patient apart from oral amoxicillin is azithromycin, again orally. This azithromycin will help me take care of atypical organisms like Legionella pneumophila or Mycoplasma. Oral amoxicillin and oral azithromycin are the drugs that would be used. There could be a possibility that in some MCQs, he may deliberately incorporate comorbidities in the patient. Comorbidity can be like, it can be like stents in the coronary arteries. Comorbidities can be chronic kidney disease, chronic liver disease. वो कुछ भी ऐसा situation create कर दे कि patient को comorbidities हैं या पहले कभी previous hospitalization है. So I might have become a bhoot at the moment, but then it is okay. I'm still persisting. So my voice will be carrying at the moment because you can understand it is hot, and then the internet, the government supply will go off. Obviously the power system will come back, right? So I'm a ghost at the moment. I'm still writing. So keep the focus on and keep focusing on the aspects that I'm saying. The only thing is that the power system should come back very soon. So I'm waiting for that to come back. Meanwhile, stents, CKD, CLD, if they are given, what will be used in the patient? Then oral amoxicillin. ऐसा क्यों होता है यार इंडिया में? थोड़ी सी जैसे हवा चलती है, आंधी आती है, बचपन से मैंने देखा है, थोड़ी सी भी बारिश आती है ना तो मुझे लगता है कि आंधी चल रही है अभी बाहर, डस्ट स्टॉर्म है. तो लाइक यू नो, लाइक फ्रॉम अ किड्स, एंड यू वुड हैव आल्सो सीन, नो, थोड़ा सा भी कुछ होता है, एंड द फर्स्ट थिंग दैट हैपेंस इज कि जो बिजली वाले हैं वो इलेक्ट्रिसिटी बंद कर देते हैं. I mean, you guys have been abroad, right? तो कई लोग तो आप तो पढ़ के आए यार, और न्यूक्लियर पावर है, शायद रशिया में तो न्यूक्लियर पावर है ना, वो अंडरग्राउंड से वो उन्होंने केबल्स डाले हुए हैं, कभी बंद नहीं होता यार, कभी बंद नहीं होता. यस, इट इज ओरल अमोक्सिसिलिन विद, साथ में क्या करेंगे, इट इज क्लेवुलानिक एसिड. It is oral amoxicillin with clavulanic acid that will be used in the patient, and along with that we will be using azithromycin for this patient. So at this moment guys, I want you to keep the focus on, I know थोड़ा distraction होता है, but then we are at the critical part of our discussion, so थोड़ा ध्यान रखना. Jokes apart, the point to be remembered is that what is the antibiotic, earthquakes and power doesn't go off. In Philippines, मेरे को पता है Philippines में यार, वो कौन सा जगह, मैं नाम भूल गया, that's a big island, very good. और वहां पे तो earthquake 7 का आया, पता है, in Philippines there was an earthquake on Richter scale 7, and like everything was on there. Those guys are chill, man. Okay, so oral amoxicillin and oral azithromycin. I mean, again, you know, Filipinos are like, you know, awesome people, man, awesome people. The way they are able to pull this off. Okay, Davao, yes, exactly, Davao. So oral amoxi and oral azithromycin are the molecules that would be used in a patient. But then at the same time, you can see that I'm being a little proactive. I'm being a little proactive because I want to use beta-lactamase inhibitor for my patient, that is clavulanic acid, that would be used in this patient. So at this moment, one, I want to bring to your attention that if he says in the question, if he says in the system that, you know, some comorbidity is present, then answer it as beta-lactamase inhibitor that would be given in a patient. And now what I will do is, I will change the situation to a score of 2, or like I can change this to a score of 1 to 2. And the moment I say score of 1 to 2, then you can see that we will be like, more proactive IV treatment in this patient will be managed. Okay, score of 1 to 2 is what we are focusing at the moment. It is IV treatment that I'll be focusing on inpatient, and IV treatment would be used obviously like this guy is sick, critically sick in intensive care unit or in ICU. So I can write 1 to 3 in fact. It can be 1, it can be 2, it can be 3. Obviously 3 is ICU, 2 is general ward, and 1 would be, like I said, any parameter apart from age. So guys, what is the IV antibiotics that would be used in this particular scenario? Your answer will be the first antibiotic I will give to the patient will be, right? First antibiotic that I will be giving to this patient would be ceftriaxone. This is the easiest answer, that is to ease our lives. That is ceftriaxone can be given. And second, what I do is apart from ceftriaxone, I can be giving azithromycin to the patient. So there are two main antibiotics that we are gonna use. Once again, azithromycin is the king pack for atypical organism. Macrolide king is azithromycin. Some people use in those circumstances. Some people use doxycycline also, but then these are the two antibiotics that are used. Now in some MCQs, yes, very good Ashok. I was waiting for that, I was waiting कि कोई comment करे. तो वो क्या करता है कि वो जानबूझ के सेफ्ट्रक्सन नहीं लिखेगा यार, क्योंकि वो तो बता दोगे तो he will ask you to select between ampicillin sulbactam and then azithromycin. Ampicillin sulbactam and azithromycin in the patient. That is when, this is again beta lactams which are coming up in the discussion. But now you will realize that lots of time when you write so many antibiotics for your patient, if you write so much antibiotics for your patient, they can be diarrhea also. You writing so much antibiotics, patient is saying, Doctor Saab, this is causing diarrhea, I'm not very comfortable, I'm having to go to the washroom. Oral antibiotics से तो diarrhea होता है यार, even IV antibiotics would be causing it. So therefore, we will be using respiratory fluoroquinolones, and the respiratory fluoroquinolones that somebody commented are L, M, and G. Respiratory fluoroquinolones are levofloxacin. Levofloxacin. Then is gonna be moxifloxacin. Then is gonna be gemifloxacin. So if it depends on the decision of the physician and which antibiotic are you more comfortable with. But I just want to say at this particular moment that any of the three combinations, it is a or between any one of them. It is or between any one of them. Ceftriaxone, azithromycin, ampicillin sulbactam with azithromycin, or respiratory fluoroquinolones. Any of the following antibiotics can be used for this patient. But now I am worsening the situation by saying patient required even ventilator support, or the patient required a central line, and central line then caused a CLABSI, central line associated bloodstream infection. So if the person was admitted and central line was also placed, and now the patient is going into sepsis, because see, central line is a big time portal from where the entry of Staph aureus can occur in the patient. So I need to give coverage for Staph aureus also. So here the antibiotic that I'll be adding in the patient is linezolid. I would like to clarify the fact that Staph aureus के लिए, because we assume by default that in intensive care unit the strains will be vancomycin resistant Staph aureus. We assume that the patient would be having vancomycin resistant Staph aureus. I would like to write this data once again. If I have to add coverage, right, the coverage is to be added for Staph aureus. By default, it is VRSA. The risk factors for Staph aureus causing problem in the patient is like central line insertion, blood culture turning positive, local pyoderma, anything like that given, like, okay, it is like central line in place. And then there can be requirement of intubation also. If there is a requirement of intubation, then Pseudomonas aeruginosa will come up. So what other additional antibiotics will be added? That is meropenem. So now you can see that number of antibiotics suddenly exploded. Like earlier I was like, okay, yaar, moxifloxacin to dena patient theek ho jayega. But then along with moxifloxacin, I might have to add linezolid if required, or I might have to add meropenem for management of these patients as well. The point I want to bring to your attention at this point of time is that if the score is ultra high, we have to be ballistic about the patient. We have to be super aggressive. आपको लगता है निमोनिया छोटा मोटा illness है, guys? No. Pneumonia can have up to 30% mortality. Pneumonia can have 30% mortality. Please comment in the chat box that in a patient or suspected, like I mentioned,